Good morning, everyone. Without wasting any more time, today I'm going to talk about approaches in TKR, both primary and revision. To the youngsters and even the experienced people, I would like to remind that TKR is not an operation to open the joint, cut the bone, put the cement, place the implant, reduce the joint and close the skin. No, this is not this. TKR is basically a surgery to correct the deformity, align the joint, restore the axis and obtain soft tissue balance to reduce abnormal forces on the implants. So as we plan the surgery, the first thing that we have to plan is patient selection, and then comes the approach. So the attributes of the ideal approach, it should be simple. The joint should be dislocated easily. There should be scope for adequate soft tissue balancing. Good stability should be achieved. The closure should be easy, and post-operative early mobilization should be provided by the approach. So this slide explains the blood supply. We have superior, inferior, medial and lateral genicular arteries giving the blood to the knee joint. And the medial side has better blood supply, more blood supply than the lateral. So the surgical approaches that I'll be touching upon in this talk will be a standard medial parapatellar approach, then the tissue sparing approaches like subvastus, midvastus and trivector, the lateral parapatellar approach and the extensile approaches basically used for difficult and revision cases like quadriceps snip, inverted V-shape and tibial tubercle osteotomy. All these approaches can be done through a standard midline skin incision. The length of incision depends upon the size of the knee and the patient's BMI. Incision should be made full thickness vertically up to the fascia of the quadriceps tendon to avoid devascularization of the skin flaps. The incision should be kept slightly medial to the tibial tubercle to avoid any pressure coming on the bony prominence. And if we see edges coming into the shape of V, we have to extend the incision and convert that V into a U. So first we'll talk about the medial parapatellar arthrotomy, the main workhorse. It was initially described by von Langenbach way back in 1879 and is still considered as the gold standard. All the other approaches are compared to this. In this, the arthrotomy is done with the knee inflection extended from the quadriceps tendon at its junction with the vastus medialis obliquus around the medial border of the patella and ends just medial to the patellar tendon and tibial tubercle. Here you can see that vertically in the tendon, medially leaving some tissue with the patella so that the closure of the arthrotomy is easy. Then the knee is extended, a deep MCL is detached to expose the proximal tibia plane between patellar tendon and fat pad is identified and fat pad is removed. The patella is either subluxated or everted according to the surgeon's choice. The advantages of this approach is it is familiar to most and it gives excellent exposure even in challenging cases. The disadvantage is that sometimes there is failure to close the medial capsule. The lateral patellar subluxation is more often seen because the medial restraints are lost. The lateral gutter is not very clearly visible and it may jeopardize the patellar circulation if lateral release also is required. Now let's come to the tissue sparing approaches. They are based on the theory of using less invasive approach to reduce the soft tissue damage by avoiding violation of quadriceps mechanism for better surgical outcome, less pain and early functional recovery. They are basically the subvastus, midvastus and trivector approaches. So the subvastus or the southern approach, it was first described by Urke way back in 1929, but was repopularized by Bechol and then lately by Hoffman in 1991. In this, a L-shaped capsule incision is given with proximal limb of the incision along the posterior border of the vastus medialis obliquus. The inferior edge of VMO is lifted of the periosteum of the femur, and by using blunt dissection, descending branches of the genicular artery and the saphenous nerves are protected. The incision continues distally to the medial joint capsule, tibial tubercle, and extensor mechanism are displaced laterally. The advantages are it is comparable, it gives comparable exposure to the medial parapatellar approach. There is less need to perform the lateral retinogram release of the patella. There is less blood loss, less post-op pain, faster recovery of the quadriceps mechanism. It maintains vascularity of the patella and allows more accurate evaluation of the patellofemoral tracking during the surgery. But the disadvantages are increased chances of hematoma formation beneath the vastus medialis obliquus. It is least extensile. There is potential of denervation of the vastus medialis obliquus, and Hoffman has described some contraindications like obesity with short femur, patella baja, stiff knee, revision TKR, and a history of previous HTO. Then the mid-vastus approach, which was described by Eng in 1977. It is a compromise between the standard medial parapatellar and the subvastus. In this, the VMO is exposed, incision of VMO fascia is given, preserving most of the VMO attached to the quadriceps tendon, proceeding distally in the usual fashion up to the tibial tubercle. There is preservation of the descending branch of the genicular artery, and this ensures the patellar vascularity. The advantages is it spares the extensor mechanism and ensures faster recovery. There is greater patellofemoral stability, less requirement of lateral release of patella, and less chances of bleeding and hematoma formation. But it has the disadvantages of potential denervation of the vastus medialis obliquus. It is less extensile, and exposure is difficult in obese and flexion contraction patients. Now, briefly, we'll talk about the trivector approach. In this, the arthrotomy starts at the medial border of the tibial tubercle, extended medially along the edge of the patellar tendon, and 0.5 centimeters supromedial border of the patella. It is divided in two. The one snip is along the VMO fibers, and the other follows the quadriceps tendon. And both these snips go for about 1.5 centimeters. This ensures better mobility of the patella, especially when it is stiff. The advantages are the same: faster recovery, and it has been proven at 6 months quadriceps strength is much better. Now let's come to the lateral parapatellar approach. It was described by Kebish for severe fixed valgus knees. It provides better exposure and also the chance to release the tight lateral structure better. And it begins lateral to the quadriceps tendon, extends 1 to 2 centimeters lateral to the patella through the medial edge of the Gerdy's tubercle, and ends in the anterior compartment inferiorly. The advantages are it is very useful in fixed valgus deformity. It preserves the blood supply of the patella. It prevents lateral patellar subluxation, and it gives direct access to the lateral side in a tight valgus knee. But it is technically demanding and may require a tibial tubercle osteotomy. Now let's come to the extensile approaches. These are useful in the difficult exposure of the joint, like in fibrosis, patella baja, stiff ankylosed knees in obese patient, when there is history of fractures around the knee and previous surgical scars are there. The easiest of them all is quadriceps snip. It was described by Insal in 1984. In this, the incision starts at the origin of the quadriceps tendon, extends at 45 degrees towards the fibers of the vastus lateralis, and rest is similar as the medial parapatellar approach. The beauty of this approach is that we don't have to change the post-op rehab protocol. Now the inverted V-shaped quadriceps tendon, also known as quadriceps turn down, it was initially described by Coons and Adams, and it was then later modified by Insal. Here the arthrotomy starts at the center of the quadriceps tendon and extends distally, medially and laterally in both the sides along the patellar tendon in the inverted V fashion, allowing distal turn down of patella and complete joint exposure even in very severely ankylosed knees. It has got a lot of complications, especially the reattachment of the reattachment in appropriate tension is an issue. More than 10 to 15% patients have significant extensor lag, and there is a significant risk of devascularization of the patella. Now the tibial tubercle osteotomy, it allows an extended approach in complex primary and revision scenarios without endangering the extensor apparatus. A trapezoidal osteotomy of 7 to 8 centimeter long, 2 centimeter in width and depth is made, leaving the periosteum and lateral muscular attachment intact of the bony fragment. Once the tibial tubercle is overturned, extensor mechanism is raised proximally, allowing complete exposure of the joint. The advantage is there is a chance of correction of the eventual axis deviation. If the extensor axis is deviated, that can be corrected and fixed at the appropriate position. The osteotomy can be fixed by screws or wires. It's a technically very demanding procedure with high risk of complications like failure of fixation, non-union, and tibial fractures.
Sachin, please sum up.
Yes. Just to sum up, the talk is incomplete if I don't talk about these two things. There are some at-risk incisions. If there is a previous old single scar, if it is suitable, it can be used. Otherwise, at least 5 centimeters of gap should be given between the new and old scar. The distance between old and new incision should be not less than half of the length of the existing scar. If the horizontal previous scar is there, then a perpendicular scar can be taken. And if multiple scars are there, use the most lateral one. There is a sham procedure or a sham incision described, especially when there are multiple incisions already present. The patient is taken an OT and an incision is given up to the fascia and it is closed. If the flaps heal in 2 weeks, then the same incision can be taken for a revision surgery. Thank you very much.
Thank you, Dr. Sachin. Any questions? Anybody want anything about the approaches? Any question for him?
No. By the time Dr. Nima comes here, I have a question to Dr. Sachin. Mid-vastus, sub-vastus and middle parapatellar. So, between the three in a routine normal patient, what are the end results?
So the short-term results are better with the sub-vastus and mid-vastus because the patient is able to walk early. There is less pain and the extensor lag is not there. The active SLR comes very early both in mid-vastus and sub-vastus. But if we compare this approach at 6 months,
yeah.
there is no...
Yeah, so I think the point is at 1 year the SLR and the quadriceps strength in all the three approaches are same.
Is the same. It is just that when we want a early recovery, if we want to make the patient walk early, and there is less pain in subvastus, but there are definitely some contraindications. It cannot be used in all the cases.
The second question is for TTO.
Yes, sir.
One or two specific indications where you think that this will, because see by routinely, I think there are 50 people sitting here.
Sir.
I'm not sure, probably I'm sure, none of us has done TTO in last 5 years or 2 years at least. So what are the 1 or 2 very specific indications where you will need that?
If the knee is very stiff, you don't have even 20 degree of a range of motion and there is significant fibrosis all around. Frankly speaking, even I have never done this in last 5 years.
Yeah.
Fuse.
Hello. Better?
Yuvraj, anything you want to add?
TTO.
That is the reason why it is we have now not been
Correct. And another indication is in a revision TKR where you have a stem knee. Yes?
previously arthroplasty knee, and after some time patient feels
Yeah.
I should have a knee joint.
Yeah, correct.
Initially he had undergone arthroplasty and after some
stem tibia in a revision case. When you have a stem tibia, probably there's another place where you need that.
To remove that, yes.
Yeah.
Thank you, sir.
Thank you. Let's move forward. Yes, Dr. Nemo.
Good morning.
Hello.
After Dr. Chabra, who talked about all the approaches, I'll talk on especially for subvastas approach. As all of us know, total knee replacement is the end stage of treatment for end stage arthritis of the knee. And we have seen several advancements with the time, which includes implant design, material used, and the surgical approaches. While there have been a discussion and debates about design, the metal used, and whether or not is spare, PCL, very few have discussed approaches to the knee joint and their consequences. As Dr. Chabra told, these are the approaches. An anterior midline incision with the medial parapatellar arthrotomy is the most common skin incision for primary total knee replacement arthroplasty. Few surgeons use the mid-vastas approach and still fewer prefer to use subvastas. Anterolateral is seldom used. And here if I want to compare the subvastas approach with the medial parapatellar approach, it's like when you want to enter a chamber or a room, you don't cut the door. You open the door and get inside, and when you go out, again close the door. So subvastas approach is similar to entering a room, opening the door and closing the door. But when you cut the muscle, it is medial parapatellar approach. Early rehabilitation after a total knee replacement arthroplasty is desirable for patient satisfaction and to minimize the post-operative complication. Although medial parapatellar is an extensile approach and provide adequate working space, but breach in the quadriceps mechanism has been considered a major disadvantage. The subvastas approach was described by Hoffman in 1991 as an alternative approach to TKA. These are some steps for subvastas approach, which I would like to cover in a small video. So, it's a very easy approach. Midline incision. This patient had about 20-degree flexion deformity. Raise the medial flap along with the fascia, because the devascularization of the medial flap will cause necrosis. So always raise it along with the fascia. That's the very good tip for this particular incision. And try to go on the medial most part of the subvastas muscle, vastus medialis muscle, and try to reach on the posterior aspect. Once you reach there, with a blunt instrument, you can find the intermuscular septum and you can free the muscle with the help of a finger. Just lift the vastus medialis muscle. With a blunt instrument, you can create more space in the parapatellar pouch, suprapatellar pouch, and insert a right angle spike. And now you find the insertion of vastus medialis on the patellar retinaculum. With a cautery, you cut the muscle either in the right angle, inverted L shape, or in the oblique curved fashion along the patella and up to the patellar tendon. And you are directly reached on the medial femoral condyle. At this stage, the most important is to free the vastus medialis from the pet fat of suprapatellar region. And as you do it in the medial parapatellar approach also, so it's not very difficult and there is no risk here. Just lift up the muscle and clear the pouch. The next step, you'll clear the patellar tendon, free it little bit, and at this stage, you find it tight, then go proximally, free the muscle in the intermuscular septum only with the blunt dissection, or come down. You can little bit increase the incision 1 centimeter and free the just few millimeter patellar tendon. And now you have to clear the pad fat from the patellar tendon. The approach is over and you have everted the patella and you can dislocate the knee. So it's very simple approach. The advantages of subvastas approach. It preserves the integrity of vastus medialis. As the name suggests, the quadriceps muscle is spared in this approach, and the main advantage is 100% muscle power in immediate postoperative period, less postoperative pain and blood loss, early and satisfactory mobilization. The preservation of blood supply to the patella is also maintained. So avascular necrosis, which can cause fracture or persistent anterior knee pain, can also be avoided. Lateral retinocular done for patellar tracking in medial parapatellar approach is avoided in this approach. You hardly get any chance when you want to release the lateral retinoculum. Overall, subvastas approach offers better patellar tracking, less need for lateral retinocular release, and faster rehabilitation. And several studies shows that muscle strength and therefore rehabilitation in early postoperative period is better by subvastas approach as compared to medial parapatellar. As the integrity of quadriceps muscle complex is not breached, there is appreciably less amount of pain, and also the usage of opioids is minimized. The patellar tracking is the chief advantage of subvastas approach. Since the intact vastus medialis acts as a strong force medially, it does not allow patella to track out of the trochlea laterally. And early rehabilitation causes shorter hospital stay, less expenditure, and more patient satisfaction. Here, closure is also very easy because you just cut few centimeter of the parapatellar region. The superficial and deep structure doesn't lie in the same plane. So chances of infection are also minimized because the muscle acts as a great barrier. If at all there is a superficial infection, the muscle does not allow it to go to the implant or the joint. Friends, technology cannot replace the quality surgeon. Even with the navigation and robotic technology available, exposure and closure remains a very crucial part of surgery, which is made easier by subvastas approach. There are few disadvantages also. The learning curve is there. Once you do few cases, you master the technique. Increase in the operative time is also said one of the time, that it increases the operative time by 5 to 10 minutes. But I never noticed it in my practice. Once you are familiar with the approach, the time taken is same. Inadequate exposure, yes, in very few cases like revision cases or very obese or stiff knees, sometimes you may not take this approach. Superficial skin flap necrosis can be there, but you can avoid it when you raise the skin flap along with the fascia. We have studied about 110 cases in our center, and mean age was 65 years. And we started from knee score of 2.415, and which increases up to 82.55 in the due course of 12 months' time. Another study, and we had very good satisfactory outcomes. These are the few photographs. The tips and tricks for subvastas approach. Superficial MCL release should be done when you go for the incision in the medial aspect, partially release the patellar tendon if required. It is not required routinely, maybe an aid in the obese and severely deformed knees. Lateral bend release on the lateral aspect of the patella, again not advised regularly, but can be done by just lifting the patella and cutting the superficial facial bends. Fat pad removal is necessary from the suprapatellar as well as infrapatellar region. Thanks for giving me this opportunity to come on this platform. Thank you very much.
I have one question.
Sir.
You've done a large series of 110 patients, which is quite good. You mentioned one point that by using this subvastus approach, the need for the lateral release is reduced. Do you think, in your opinion, that the approach is going to help the patella tracking better, or it is our rotation of the implant which matters for the tracking of the patella?
Sir.
So do you think that by just doing this subvastus approach, your requirement for the lateral release will be reduced? You think that's your experience?
Yes, most of the time any surgeon would try best to keep the rotation, femoral rotation and cuts in their own standards. But I do all my cases with the navigation. I noticed even when you do with the navigation, patellar tracking was a problem in medial parapatellar approach. But when I started using about 4 years back, so I noticed that I hardly required a lateral release, a retinocular release with this approach. And the most important reason for this is the whole muscle is intact and pull is on the medial side. So it doesn't allow the patella to laterally subluxate. So this is my personal feeling, but this is true. Thank you, sir.
Now I'll invite the next speaker is Basics and Role of Active Robots in TKR, Dr. Vinod Arora.
Good morning, everyone. I think as per my expectation, crowd is quite less. Anyway, something different which is there in last few years, and now we are seeing it more and more. I'm going to talk about role of robot. If I look at the previous two speakers, Sachin rightly said it's not only opening up the joint and putting the implants inside with the cement. You have to correct deformities, you have to look after soft tissue balancing. This is very, very important. And as rightly said by Pramod also, it's not a navigation or robot which is going to take care of everything. Surgeon has to be wise enough to go inside the joint in a proper fashion. Soft tissue care is important. But anyway, technology never comes over here. If you talk of technology, technological part is on the bone cuts. So let's come into this era now. Basically, it's a programmable device which we had to program before, and then we had to get lot many things or functions performed by this machine. This term is a Czech term, comes from robota, and it was introduced in English language in year 1921. The first surgical fraternity or specialty which started using robots was neurosurgery, we all know, and then it was followed by urosurgeons, and later on lot many specialties, they started using this particular technology. In orthopedics, of course, the main aim to use a robot is to cut short our mistakes with bone cuts especially, and to put the implant in proper position. In latest, or if I talk of advanced robots, what we need is a 3D picture through CT scan. We need 3D picture in all the robots, but there are few robots in which we need a CT first, so that we can have a three-dimensional image with us and we can design everything beforehand. And of course, this is going to restore our joint line, which it is going to restore our balance, flexion, extension gaps, and patellar tracking. I don't agree with Pramod, that's just only with approach we can get rid of patellar. This is not, approach is not going to matter at all. Only subvastus is not going to help us in proper patellar tracking. What is needed is proper bony cuts and rotation. That is going to take care of that. Surrounding tissue is, care of surrounding tissue is very, very important, and with robots this becomes better if we go with, especially if we go with bursts. And iatrogenic injuries to soft tissue can be avoided nicely with the help of robots. It is, as I said before, it is going to improve our bony preparation, and literature demonstrate that acceptable flexion and extension gaps in 94% of the cases is there with robotic TKR. When we go for conventional, this figure is around 80%. Now there are different type of robots, and fully active robots do all the steps of tibial and femoral bony resection. Semi-active robot assists the surgeon in controlled resection of tibia and femur. This is the basic difference in between the two. A robotic system has visual and audio and tactile feedback that assists the surgeon in controlling his force and the direction of movements. And this is how robot helps us to save the soft tissue. Now, there are many type of cutting systems involved with individual robots. There are robots which are available with bone saw, saw blade, and this has got its own disadvantages, because though there is soft tissue preservation, that blade will not go in the area where we don't have to cut. But many a times, as you are holding the device in your hand, this may go little haywire. There are burr-based systems available in which you have to use, in semi-active also we have to use burr, we can use burr, but then you have to hold the device in your hand. When we go for fully active system, then robot does all the cutting job, and that becomes definitely of third generation, where robot can handle most of the things independently. Dynamic referencing to assess knee stability, alignment, and knee range of movement intraoperatively is the job done by robots. Reduce soft tissue dissection and muscle injury definitely helps for better improvement and achievement of physiotherapy goals. And as the CT scan is uploaded to software to create three-dimensional image, surgeon plan the surgery pre-operatively a day before. A virtual surgery is performed a day before, so whatever you have to do in the operation theater, wasting your time over there probably becomes little more troublesome. You can devote that time a day before and plan the surgery nicely beforehand, so that you know what kind of size, what kind of rotation, what kind of inclination you are going to have in that particular patient. Several types of robots are available for TKR with different brand names. And little bit of comparison over here. There are all the probably leading companies, they are in the market with robots, including Zimmer, Smith & Nephew, Stryker, Depew is probably they have already launched their machine outside, but not in India so far, and Merrill. Now, if we look at this particular chart, CT imaging is not needed in all the machines. It is needed only with the Mako and QVIS. The QVIS which we have and we are working on it, which is a fully automated machine. Mako is another from Stryker where we have to be CT based. Otherwise, with Smith & Nephew, Corey and Rosa and probably with the Depew machine also, though I'm not aware of, but the figure which I got from Google is this only, that they also don't need any kind of CT scan. CT scan definitely gives you better 3D picture, and this becomes very important. In rest of the machine, what happens, in the operation theater itself, you are going to do mapping and then only you have to proceed for a 3D picture which is created over there, and then you use that picture for the rest of the job. But here, you have to be CT based, which is much more accurate. Fully automatic, if you look at it, only QVIS is the one which is fully automatic. Third generation, you can call it, where they can do almost everything independently. Preoperative planning is definitely with QVIS, you can go ahead with rest of the machines also, not with all, but probably the second half of this particular session today, we are going to have a discussion whether it is a marketing tool or really it is helpful. So probably what I feel, if I look at rest of the machines, especially Smith & Nephew's machine and a few of other also, they probably you can call them. They are like marketing tools. But if you look at the fully automatic machine, then probably you will agree with me by the end of this day that this is of great use. Robotic TKR is expensive bit because definitely cost of machine is involved, CT cost is also involved. And preoperative CT add on certain more issues like increase of radiation and the cost. There is an increase in the time of operation, especially during learning phase. To begin with, yes, you have to devote little more time. Later on, it becomes, when it comes in habit, it works for you. And one more disadvantage over here is you have to have a technical person inside the theater who can help you out in surgery while handling this particular machine. Hence, most arthroplasty surgeons support continuous use of robotic technology to improve surgical accuracy because of the advantages which we get out of this particular procedure. We have got promising mechanical, radiological, and clinical results which are in favor of robotic TKR. Basically, robotic TKR, if I try to conclude this particular talk, is characterized by decreased postoperative pain and requirement of analgesia, quicker restoration of straight leg, and short stay in the hospital, and better knee flexion at the time of discharge. Probably we have to wait for long-term results. So far we have almost 10 years data with us, but with time probably this particular technique will prove itself. Thank you very much. Thank you very much for patience listening.
Thank you, Dr. Vinod Arora. Any question to him? If any is there, then anybody can ask. Yes, Dr. Mukesh.
Hi, sir. My question is, pre-op CT scans, you have all osteophytes, deformity, flakes, posterior, medial. How you plan your soft tissue balance on that pre-op CT with inbuilt osteophytes and all?
That you have to consider over there. They are not going to, those osteophytes, you can see those osteophytes, whether they are medially, posterior-medially, laterally, that even implant sizing, that you have to guess over there and work over there that after removing these osteophytes, what will the seed like? And that you can do virtually over there.
So then what's the advantage of
No, it's not like that. Advantages of CT, if you try to compare it, you are asking this particular question pertaining to conventional versus robotic or robotic versus robotic? Okay, I'll answer from both the aspects. If I talk of other robots and autonomous robo, fully active robo, the mapping which we do during the operation, you cannot reach up to the posterior condyle nicely. So the kind of 3D image which you are going to create inside the theater will not be that accurate what you are going to get with CT scan based robot. 1. 2, if I talk of conventional and other, many a times we do get surprises in our operation theater itself that we thought probably this particular osteophyte was there on medial side, but it is not there, it is on lateral side. With CT, you will get individuals' anatomy very nicely a day before with you. And then, of course, the size of osteophyte you can make out in that CT only. And after resection of that particular osteophyte, what will be the scene? That there you have to have your own, you have to use your own brain also. Can you correct me here?
Since Navio since last 3.5 years. So you can do very well mapping with complete posterior condyles and everything.
Can you compare it with the 3D mapping which we can do
That's what
with
my
CT?
question. So see what I'm asking, what I want to say, I'm not against any robotic system. It's not like I want to promote any one system or you want to promote anyone. The thing which I want to tell you, ki even if you do pre-op CT, intra-op, you have to do all that mapping and staging again to get correct component, even if you are using Mako or if you are using QS.
Which one will make you more comfortable? If a choice is given to you, both the machines are available in front of you.
I think, Dr. Mukesh, I'll interrupt you. This debate will go on. Yes, Dr. Mohanty, you want to make any comment?
Good morning. No, just, why robo and navigation, all this thing came into picture, because we know from the literature around 25 to 30% of the patients of total knee replacement, they are unhappy patients. Okay, though you see X-ray is good, alignment is good, everything is good, but the patient is unhappy. That's why the robo came into picture to improve the outcome. But whether robo or the navigation, it has improved the patient-related outcome measure, or what we tell PROM. That is not yet proved. So, okay, we are saying, more or less alignment issues we have solved. We are kinematic alignment now, whatever, little varus, little valgus, that doesn't matter. Main problem of the dissatisfaction is instability now. So, solving the matter of instability. At present, the biggest advantage of robo is that it prevents soft tissue injuries. Inadvertent injury to the medial collateral ligament or vascular injury or whatever, that is what is the biggest advantage of robo at present. Sir, I would request you that if you can evaluate your patients about satisfaction measure and just show it in the meetings, that would be,
Oh yes,
helpful.
thank you so much.
Dr. Mohanty, that bunch of 1 to 2% dissatisfied patient will remain there irrespective of use of the robot, I think. That dissatisfied patient will remain be there, that bunch of group.
But it will definitely reduce it from 20% to probably 2 to 4%.
TKR is a soft tissue surgery, as we were taught long back. Now robot has come and it is avoiding the soft tissue releases. So what is right? We have to understand this. You can throw some light on it. Whether it's with the robot you release the soft tissue or you don't release it.
Sir, just last one final comment and then we'll conclude.
I will not answer this particular question. Probably we will leave it for next speaker to answer this. The reason I was speaking on basics only, but in short, I can tell you, we can avoid many releases. Nowadays, we do minimal releases on our patients, and most of the balance can be achieved through bony cuts only. Bit of rotation, bit of flexion, and it solves your problem.
I'm afraid the live surgery is going to start.
They started.
Yes, just start. Yes.
Good morning, everyone. Am I audible?
Yes, you are audible. Go ahead.
Yes. Good morning, everyone. I hope everyone has enjoyed their breakfast, and after these wonderful lectures in morning session, we are ready for this live surgery from MedSquare Hospital. With me, Dr. Akhil is there. So he's been doing this robotic surgeries routinely here. So he's 59-year-old gentleman with tricompartmental osteoarthritis of the right knee joint. And just to save time, we have placed, can you just focus the camera here? We have placed the pins on the tibia arrays on the femoral as well as on the tibial side, and we just exposed the joint. And now we are ready for the registration process. So, yes. Can we have some camera on that screen as well? Or can we have some output, screen output there? Yes? Collect? Yes? Sorry? Yes? Okay. Yes? 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 Initial RMSE looks good. Proceed, yes. 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 Yes.
I just want
Yes.
to know what planning he has done. That's what I wanted.
Yes.
Yeah.
Yes.
Has he done CT scan or not?
Yes. 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 So this essentially completes our registration for the femur, which usually takes a couple of minutes.
Dr. Neeraj,
Yes.
just for the sake of the audience, can you just show
I'll
us the
just
preoperative X-ray and a CT, if anything, just for the sake of the audience?
Yes. Yes. Okay, just give me a minute, please. Yes. Okay. So X-ray, as you can see on the screen, and is a tricompartmental OA plus there is around 5 degrees of FFD clinically and 10 degrees of varus. It's a correctable varus, and on CT and as well as on the X-ray you can see there are posterior osteophytes. Now we ready with the TBL registration. Once the resection starts, we can discuss many points. Next, please. Can we again focus on the yes? Yes. 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 Okay. Yes.
Neeraj, this is Deepak Dave.
Yes. Yes. Just a minute. Yes. So we are registering the medial tibial condyle. Yes.
If there is a
Just
bone
hold on.
defect in
Yes,
the
sir.
medial,
Deepak, sir.
yeah,
Yes.
if there is a
Sorry?
bone defect in the medial tibial plateau,
Yes.
what would be the guide? How would you, the tips for that? If the point which you're taking in a tibial condyle,
Yes.
if there is a medial tibial defect, what would be your suggestion?
We take it in the defect, how it is there on the CT image. So otherwise that RMAC will differ. It is not going to accept if we don't take it in the defect. So that's the answer. Okay. Yes. 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 The other trick here or tip here is, yes, try to cover maximum surface area. Yes. As it applies to all the robotic systems or yes. 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 Yeah, screen is visible. Yeah. Yes. 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 So looks good. The RMSE root mean square error, as you can see on the screen, it should be less than 1. It is 0.55 here. Yes, that means the CT image, what we have loaded as per plan. Yes, and this image, our registration process is matching nicely. Yes.
So can you show us throw some light on pre-op CT planning, how you did, if you have that?
It is not available. I will show it to you during my presentation.
No, for this particular case,
next. Yes, we can discuss it during the presentation. At the moment, we don't have this pre-op CT planning for this particular case. Why you went back? I just want gap check. Yes. So as you can see here, the medial, our flexion is around 111 degrees, and the medial, can we see the, yes, and that's better. The medial gap is around 11. थोड़ा सा वहाँ पे focus कीजिए. Yes. And 11 on the medial side, 13 on the lateral side. On the screen, you can see that 10.6 will be, as per our preoperative CT planning, we will be resecting 10.6 on the medial side and 8.8 on the lateral side. So there is still tightness on the medial side. So we'll go to femoral rotate. Femoral rotate. We'll externally rotate the femur. 1 more degree. 1 more degree. So this looks, so I think this, just 1 more degree of rotation. So 1 more, external rotate. So this looks just steady and perfectly balanced. 12, 12 now, check please. So as you can see in that bottom chart now, flexion is 12, 12. And now we extend it on the, so it is pretty tight. As you can see, it is showing around 10, 11 degrees of varus, around 5 degrees of FFD, as we noticed during our preoperative examination. And so it is around 8 on the medial side and 13 on the lateral side. So we are going to give femoral varus 2 degrees femur rotate, varus 2 degrees, varus. One more. So, and go to tibia shift, tibia rotate please, yes, tibia rotate, and a degree of varus in tibia. Check please. So this looks okay to me, and so again we checking the flexion. So it is around 12, 12, 12. So looks good to me. Slight tight still on the medial side. I think with removal of the osteophytes, posterior osteophytes and the medial osteophytes, we should be able to achieve the complete correction. So I'm not going to match it completely with the lateral side as far as the extension is concerned. So I'm happy to go ahead, proceed with the resection here. So go to next, please. Any questions so far? Pins,
No,
please.
Dr. Neeraj, it looks perfect. No need. Go ahead.
Hello. So there is one question.
Come.
Hello.
Yes, please.
While you are
Yes,
calculating, while you are calculating the gaps in extension, you are giving a valgus stress. I mean, you are correcting the deformity and then calculating, or it's a static.
So we give varus and valgus. We give varus and valgus stress, and we check for how much opening we have on both the sides. Yes, proceed.
Can I ask
So
a
these
question,
pins are for
Dr. Atkar?
soft tissue retraction.
Dr. Neeraj, there is a question.
Yes, please.
Dr. Atkar, so you have balanced the knee in soft tissue while the osteophytes are still there,
Yes.
and you have not
Yes,
made
yes,
the cuts.
I
Once
can
you make
hear
the
you.
cuts and the osteophytes are removed, then the soft tissue will be released. So this calculation will
So
be
these
different.
pins are primarily to retract the soft tissues, because slightest of the movement robo is not going to allow, and so
Your readings will change once you have removed the osteophytes and balance medial collateral ligament becomes lax after removal of the osteophytes. So these readings probably would not have any meaning.
okay. Okay, retraction please, and shank spin. So medially as well as laterally. Yes. Sorry.
No, I was asking.
Retract please.
Hello.
No, that is not required actually. Yeah. So this pin is to attach patient's body to robo. It is placed just above the epicondyle.
Dr. Neeraj, there is a question from Dr. Arvind Rawal. Just answer, please, that.
Yes, please.
I was just
I
asking.
can hear you.
Yes. I was just asking, if you remove the osteophytes, the readings which we have taken of the soft tissue balancing, they will change.
Yes. Please go ahead with your question.
हेलो
No, my question is, what is the...
अरविंद रावल सर के माइक का आवाज यहाँ नहीं आ रहा है ऑडिटोरियम प्लीज चेक या चेंज द माइक प्लीज चेंज द माइक रावल सर
Dr. Neeraj is asking that if you do a osteophyte removal, then your present reading will change.
See, it increases by a millimeter or two. That's our experience. So that's why we keep slightly tight on the medial side, about a millimeter or so. So it usually opens out after removing the osteophytes.
So why don't you remove the osteophytes before doing this reading? That was my question.
So it is not possible to access the posterior osteophytes before we take the cuts. So honestly, that is not possible. So that's what we anticipate, and that has been working consistently for us for all these cases. We will also come to know once this case after post-resection gap check. So
Okay, sir.
it is not possible to remove the posterior osteophytes, and yes, should we proceed?
Yes, you can.
Yes. No, थोड़ा सा पीछे ले लीजिए कैमरा, स्क्रीन थोड़ा पीछे ले, बस Okay. No, you're too oblique. It should be here like this. अब बहुत ऐसा स्ट्रेट कीजिए, बस 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 पीछे पीछे लीजिए, पीछे बस. Be slow. Lalit, you should be there on the robo. Turn it, deglow and go there. Yeah, just hold on. Yeah, yeah. Base support on, please. Table up. Base support on. So as you can see here, we are docking the robo, and it just gets locked. So after this, it will not move. And okay, so all this, can we just focus on the screen, please? So on the screen, as you can see, the green array is femur, yellow array is tibia. Both should be in the center, on the top as well as in the side view. Then only that robo will function properly. Okay. Now, can we just focus here? Can we just focus here? Lalit, come from that side. So now we are attaching robo to these pins which we have passed through the okay. Okay. So yes. Check. Check. Yes, yes, check. So this is restoration where robo is just getting ready before we start the resection.
Hello. Can you show the screen which you are seeing? Yeah. So please make it picture in picture. The screen a little small.
Yes, set. Okay, close. Now we identify these points on the femur.
Sir, can
just
you
before the resection. Yes. Yes.
Please reverse the PIP.
We can cover the tibia now. Start, please. There is a lot of movement, so be careful. Yeah, please go.
Irrigation on. Irrigation on. Irrigation.
Irrigation on.
Can we have
Stop
a
the miller.
closer look of?
Pause the miller.
Can you please zoom in where the burr is working? Another view. Can we have a?
Yes, it started. Yes. Lalit, that's fine. Start the miller, please.
Can we have a look from the foot end of the patient? Yes, this is better.
Yes, sir. Yes, please. Start with.
थोड़ा सा हाथ बाजूला ठेव, तेव्हा दिसत नाहीये. स्क्रीन पे ले लीजिए. Movement. हाँ. Okay, start please. No, resume. थोड़ा सलाइन का स्पीड बढ़ा दीजिए. So this is continuous, done under continuous irrigation, and they will not. हाथ संभाला ललित, हाथ संभाला. Uh-huh. So as you can see on the screen, the cutting path is defined, the bright yellow line, uh, beyond that, that Miller is not going to go. And you can see on the screen as well, the medial distal resection is 9.9, lateral distal resection is 8.6. On the posterior side, as we have increased the external rotation, it will be 11.7 and 7.4 on the lateral side. So that's the femoral resection. We have opted for full surface femur resection here, where we'll be completing all femoral cuts in one go. After that, we'll proceed for the tibial resection. So this essentially completes the distal resection. Can I have nibbler, please? Just stop, pause for a minute, and close the water. Close the water, pause, please. So it just keeps bony boundary intact, and we just nibble it out later on. Yes. We can start with the chamfer cut now. Start, proceed. Saline increase कीजिए, saline on कीजिए, please. So this just goes on as per plan. There was some discussion going on why you need a CT scan, pre-operative CT scan beforehand. And so as you must have noticed, the intra-op registration time is very less. And you don't need to identify ankle points. You don't need to identify the hip center. In a non-CT models, I feel it is a bit hypothetical because you don't know how much anteversion you have in the femoral side, femoral head size, because that is going to define the femoral head center there, hip joint center, which is exactly marked on the CT image here. Now we are about to finish the anterior chamfer cut here, and post that we just resect the bone, which is going to be obstructing our path for next cut, that is the anterior cut.
Neeraj, there is a question.
Yes.
Hello.
Yes, please. Yes, I can hear you, sir.
Yeah. For osteoporotic bone.
Yes.
With use of robot burr, is there any special tips or guide? Should we worry about it or should we not?
Yes, one should be worried about it. And the technique which we have opted here, I will show you at the end of the case. Because in osteoporotic bone, these pins which we place for the arrays, there are chances of getting fracture at that location. So the femoral pin, we start from the anterolateral cortex and go to posteromedial instead of going just bang from anterior to posterior. And tibia, so all these pins we drill with a small K-wire, and then we pass these Schanz pins. And you should be extremely gentle while placing these pins. So, and that's the precaution we take, and fortunately, whatever 500 odd cases we have done till now, luckily no fracture we have noticed till now.
I think Dr. Neeraj, basically his question was pertaining to use of burr.
Okay, so I thought it was pertaining to use of those pins for the
which
arrays.
Which is probably
and,
more safer, blade or burr?
Burr is in fact more safer than the saw, and so we are not face any issue while using the Miller, and in fact cuts are more precise than what we get with the saw, and implant placement is definitely better. So no issues in osteoporotic bones.
And there is any sequence of cuts as we do have in conventional TKR in this robotic TKR?
Here it follows that path, but you have option. You can skip one of the cut and proceed, or stop please. We can opt for extension surface. If you're not sure, you can just go for distal femur and upper tibia resection, confirm your gap, and then proceed with other femoral cuts. Okay, proceed please. So it just keeps a thin wafer bone between the MCL, because all of us are worried whether this Miller will touch any important structure posteriorly, especially while taking this posterior cut. But rest assured, it keeps that bony boundary intact, and till now we have not noticed any injury to any of the important structures. No, so femoral array is not visible. Okay, start, resume please. So this is posterolateral resection. So it will nicely prepare the lug holes also, and later on it will take the box cut as well. So CR surgeons can stop at this stage. So while doing the planning, we have option of CR and PS implants, and so we have opted for PS implant in this case. So we are going ahead with the box cut preparation now.
Dr. Neeraj?
Yes, please.
Dr. Amber Mittal here. I have question. Up to how much varus would you give in your tibia and femoral component? And other question.
Collective around 4 or 5 degrees of varus, femur on tibial side.
Okay. And
Stop.
how much
Stop.
external rotation would you give in your femoral component?
So that depends on the how much tightness you have on the medial side. Here intraop we have gone up to 5 or 6 degrees as well without facing any issue.
So would you
Yes,
change
please.
that thing in a valgus knee?
Yes, obviously, because valgus sometimes you have to give internal rotation,
Okay.
and for balancing the knee inflection.
So up to how much internal rotation would you accept in a
So
valgus
that
knee?
varies from case to case.
Okay.
It cannot be defined as like 3 degree, 4 degree.
Mhm.
Has so that's the beauty of robotics. With each case, it is variable, and based on whatever is required, we can plan accordingly.
Okay. Thank you.
So this is trochlear cut, a thin wafer thin bone which is being removed, the trochlear side. So this essentially completes the femoral cuts. Suction please. So before we proceed with tibial resection, I'll just like to take out the posterior medial condyle here because that obstructs the path of the curved osteodome, please. And small nibbler and curved osteodome. Hammer, please. Nibbler, please. Bigger one. Hammer. Can we have a curate, please? It's a big osteophyte and okay, cautery, please. Nibbler. So we just nibble it out at the moment and
Hello.
take it out once the tibial
Dr.
resection.
Adkar, how do you verify
Yes,
your
please.
cuts, sir?
So post resection we can check it, sir.
Okay.
Post resection we can check. Okay. Small nibbler, please. Here, our registration RMSE was good and pro, please. And before we started the resection, all those points, again, as you can see, can we just focus on that screen, please, are identified. Yes. As you can see, I mean, this point on the tibia will not glow unless I'm in that acceptable zone. So I'm approaching that acceptable zone, then only it will glow. So this resection goes exactly as per the planning. Yes, please. And now we can start. Retractor. Retractor, please. No moment. Yeah.
Dr. Neeraj, in
Yes, please.
which alignment philosophy you believe in? Mechanical, functional, or kinematic?
So we plan according to mechanical, but it is all, we identify all these important landmarks and then we balance the joint. So it is, you can say, combination of both, but mechanical alignment is what I like to follow. So here, as you can see on the screen, the proximal, tibial resection on the medial side is 2.1 and lateral is 5.1. We take into consideration burr thickness here, which is around 4 mm. The resection would be around 9 mm in this case. We are aiming for 9 or 11 poly in this case, based on how much it opens out on the medial side post osteophyte resection. But this joint, to begin with, it was a pretty tight joint. So as you can see, it just tilts and goes from medial to lateral. exactly in the surface where it has resected for the medial side.
How this takes care of the slope?
That is planned on the pre-op CT image. If required, we can alter the slope during the procedure, if required. But in this case, it was not necessary. So that pre-operative CT planning, everything I will be discussing in detail during my presentation. Those images, purposely I have saved it, and we can discuss it during my talk. Again, here that boundary is marked for the robo, as you can see, and it just functions.
Hello. Sir, how do you register
Yes.
the most posterior aspect of the tibial condyle?
During the registration process. Okay, so now this resection is complete. We are just going to detach the robo from patient's body. So registration process is what we actually I just now demonstrated.
I just wanted to ask about the posterior aspect of the tibial condyle.
It is possible in
Yeah.
90-100 degrees of flexion, and
Okay.
I agree that in very tight knees it is difficult to reach the posterior aspect. And can I have a drill, please? Take it, base support off and take it back. In that case, if you are not able to reach posterior most part of the tibial condyle, then you register from the front half or the anterior half, and then your RMS is still in acceptable zone, you can proceed with the resection. Can we do the table down, please? Okay, can we just remove these pins, please? Can you take just a pin puller, please? So we are retaining the arrays to demonstrate post dissection gap check later on. So कुछ लगा है नीचे पट्टी वगैरह लगा नहीं है ना नहीं होता है वो ऐसे रख ठीक ऐसा रख दीजिए okay lateral lever please can I have pulse lavage we are not lateral lever Lalit can you just please come here can you just cover these arrays please cover these arrays lateral lever come on the other that side nibbler please pulse lavage please so we are just nibbling out the bone on the lateral distal aspect as well as on the posterior aspect, and it will just take 7-8 minutes before we go for our trial implant.
Sir, is it possible to resurface?
Can the camera focus here?
Hello?
Can the camera focus here? Retract please. Pulse lavage connect please. हिप का क्यों दूसरा नोजल नहीं है क्या एक ही नोजल दूसरा आपने उसमें डाल दिया
हेलो
एक में नहीं रहता
इधर हेलो सर There is one
Yes,
question.
please.
Yeah, is it possible to resurface patella as well in this system?
No, no.
Okay.
Sir.
Neeraj sir, can you check intraoperatively your cuts were correct as per your planning?
Yes, we can. Huh?
Some sort of digital angel? So can you use digital angel and show that cuts are correct as per your planning?
I couldn't hear you. Yes, please.
Is there any system in this robotic to check that your cuts as per your planning are correct, like a sort of digital angel?
See, unlike in other robots where the handhold robots, you need to cross-check your cuts. I just answered that earlier that you identify those points, you identify initial registration, and just before the registration also, suction on please.
So we can't cross check robotic here.
So suction on please. Okay. Osteotome. At the moment not required. So osteotome please. Nibbler. Can you just keep all these required instruments here on the table, please? Cautery. Can one of you please come on that side? Can retractor please on the medial side? Be careful. Okay. Cautery please. Okay. Can I have curved osteotome? Hammer. Push please. Upper tibia push. Yeah. Nibbler. Okay. Okay. Cockers please. Just remove the meniscus now and then cautery please. Cautery please. Okay. Posterior lever. Retractor, please. Right angle. So as you can see, the posterior edge, the rim is kept intact. And just step. Come on this side. And we just take this out now. हाथ रखिए सामने, थोड़ा सा आगे आने दीजिए. Osteodome. What please? Someone.
Is it a regular step to remove these osteophytes with the osteotome and saw, or in particular case we are using?
So it is, we can, while doing the planning, we shift the tibia base plate by a millimeter or two slightly anteriorly, and so it just keeps that bony rim intact. In fact, it is hollow from inside. I mean, it is, the burr has gone inside like this. So the burr has gone inside like this. It may appear big, but so we just need to elevate and take it out. Okay, so please.
It's a two way of doing the burring. One is tunnel technique, what this has done. So in tunnel technique, you go from below the surface of the bone and make a tunnel from the tibial base plate, from the tibia upper part and the below. And the other way of burring is you come from the top and remove. So if you do from the top, you don't have to use this step of removing the osteophytes and all. Okay. But in tunnel technique, you need to.
If the rim of bone is
please.
intact, and while removing it, then at that time we can damage the soft tissue and we can cut, yeah, and the slope of tibia can also be altered.
Preferably use on top technique of burring.
Okay. Tibia preparation. आगे आने दो थोड़ा सा. So yeah. So nibbler please. Nibbler. Okay. Tibia. Over there. Yes. So size 5, that's what we had planned on the CT and looks good here. So you agree, Dr. Akhil? Happy with this? Looks good? Okay. So you have option of tibia keel preparation also in this robo. But I have been doing it with conventional way. Just give it to him. Yes. It's a sclerotic bone on the medial side. And yes. Rush?
Hello, sir.
Yes, please.
While you are doing the manual preparation, is it going to change your rotation, what you have planned?
So here you have option of, as I said, keel preparation with the help of robo, but I've been doing it with the routine conventional way since day one, and I'm comfortable doing this. So Flush? Yes. Okay. Take this out. Nibbler, please. Yes. Retractor, please. Okay. Pin puller, please. Small drill, or you can do it later on. This sclerotic bone. Okay. Retract, please. Okay. Femur there. So it just goes in pretty smoothly. Happy? So it is sitting flush, and mediolateral it is just perfect. Can you just zoom in here? Yeah. Yes. So it is sitting nicely, and 9 poly please. आप इधर आ जाइए, सक्शन गिर जाएगा. थोड़ा सा फ्लेक्शन कमी का. हाँ, ओके. Check please. Anyone on the? Yeah, the tibia is not. थोड़ा सा clean कीजिए. So in extension it is completely balanced, and flexion also looks good, and there is no.
Show the screen, please.
Show the screen, please. थोड़ा सा clean कीजिए tibia. There are some. No. This tibia is not visible. अब थोड़ा सा पीछे ले लीजिए आपका कैमरा.
Good.
As you can see here. Yes. Check. Looks good to me. Yeah. And limb is in say around 0 degrees of flexion and about 2 degrees to 3 degrees of varus. Dr. Mukesh and all senior faculty members there, are you happy with this?
Oh yes, definitely.
Yes, sir.
And this patella tracking is really good. As you can see, can you just focus here, please? Just focus कीजिए आप यहाँ पे.
Looks good.
So good patella tracking. No thumb applied there.
Looks better.
And as you can see, there is no lift up of the tibial base plate here.
So can you show clinically here flexion gap also? Just doing anterior and posterior drawer.
आप रखिए यहाँ पे 1 मिनट. So you can use this. Happy with this? I'm trying to pull it out.
Yeah, looks good.
Looks good. Stable.
Yeah.
Okay, Dr. Neeraj, we are running short of time, so we are now making you off from there. You continue your procedure.
Yes.
We checked everything.
Yes. I hope all of you enjoyed this, and I thank my anesthetist team here, all team from Medisquare Hospital, Dr. Akhil Arora, and his colleagues, and all the OT staff who are here on the Sunday to demonstrate this surgery. And thank you very much. We sign off from here. Thank you.
We'll see you soon here. Thank you. So with this, we end this session. Thank you very much. I thank you, my co-chairman, Dr. Deepak, and Dr. Vinod Arora.
invite Dr. Sachin Chhavda, sir. Dr. Sachin Chhavda. Dr. Pramod Nima, sir. Dr. Vinod Arora.
नेक्स्ट लेक्चर डॉक्टर मुकेश लगता है कि दो हैं बता दो
For next session, I invite Dr. Girish Yavdikar, sir, to chair the session, and Dr. Dimpal Parikh, sir.
Hello, we'll proceed with the next session. First of all, I will call upon Dr. Mukesh Ladda for all burr robotic TKR, accuracy and precision.
Hello. Good morning, everyone. We have seen a nice live demo of robotic TKR using a fully automatic QVIS system. I do all burr assisted TKR with the help of another robotic system called as Navio initially, and now with the Cori robotic knee replacement with all burr technique. So we all know the success of total knee replacement depends upon proper limb alignment, accurate component placement, and precise ligament balance. These three things are the crux for the success of knee replacement. And it was the success of conventional total knee replacement which has brought us to this stage of robotics or say navigation. Because if conventional would have not been a success, this would have not been there. But we all are aware that our 20% of patients are dissatisfied with our knee replacement surgery worldwide. So through research, everyone came to know what was the reason. The one was patient satisfaction, expectation rather than satisfaction. If you set wrong expectations to the patient, they will never be happy after total knee replacement. Second reason is our error in doing proper limb alignment and component placement and ligament balance. So does robotic helps us to individualize total knee replacement compared to our conventional? So if you see the current concept of about alignment, the whole world is now speaking about what kind of alignment we need to put to our patient, whether it should be a neutral mechanical, whether it should be a kinematic, whether it should be functional, whether it should be anatomical. It's too difficult to answer which patient will need what. So, but whole of the world is now moving away from strict neutral mechanical alignment to little bit of say kinematic, or you may say the functional alignment depending on the patient.
How to achieve that is very difficult to answer that right now, but yes, robotic is helping us to certain extent in achieving that. We all know that the component placement position also varies both in the coronal and the sagittal plane. There is no fix, we should put this in 2 degree of varus or 5 degree fixed posterior slope or fixed 3 degree external rotation. So that also has a certain range of implant and component placements. We know ligament balancing also plays a very important role. So how much tight you should be medially and how much lax you should be laterally. You can't be tight both on the medial and lateral, because medially you are dealing with one ligament which is attached on the femur to the tibia, and laterally you are dealing with the ligament which is attached from femur to the fibula. So there can't be a complete tightness, equal tightness on both the sides. There has to be some laxity on lateral side and some laxity on the medial side. But how much? How much we need to lax it? 1 millimeter, 2 millimeter, 3 millimeter. That is what subjectivity is going down now with the help of our robotic system. So whether we are able to achieve this 87 degree, this all angles we know in deformity corrections, are we able to achieve the joint line obliquity with our total knee, because that also plays an important role. So to assess whether this helps us, we have done one study to assess the planned and the achieved alignment, how accurate robotic helps us in planning and achieving the limb alignment, and secondly, how accurate component placements are there in coronal and sagittal plane as per our planning. So this was a prospective study of 63 patients with inclusion criteria of primary and rheumatoid knees. We excluded anteromedial OA where we need to do uni and revision knee replacement. Pre and post-operative standing scanograms were done in all the patients to calculate the limb alignment, and even good AP and proper lateral x-rays were done to calculate the slope and the femoral component flexion. All cases were done by Nevio Robotics. Bone Ninja software was used to calculate all the angles. So this is what a pre-op scanogram showed. The patient is having some 18 degree or 11 degree of some varus. And this is how all bar robotic Nevio works. After you plan, you have to just, it's a handheld robotic system. So you just has a small, very handheld small burr in your hand, and you have to see on the screen and keep cutting it. So the planning is most important thing in any robotic system. If you feed garbage in, the garbage will be out. So execution is not that important. Planning stage should always is very important in robotic. You need to plan and play with the maximum component placement. They say the outlier was 3 degree. You can't put tibia and varus 2 degree or 3 degree, and the whole limb alignment should not go beyond plus minus 3 degree. But that plus minus 3 degree, how to identify on table? That's the $1 million question. So here is what robotic helps us to plan out. And once you finish this cutting, there is a digital angel where you can cross-check whether your planning went correctly or you have deviated from your plan. If you feel you have deviated from your plan, you can again go back in the planning stage. You can correct your adjustment in your planning, and you can again reburr it and correct it on table. And then if you see here, this is what pre-operative planning was. Pre-operative was 9 degree, post-operative 3 degree varus. This medial side was tightness, lateral was little tight, but after cuts we know we can achieve whatever component placement we wanted. And this is how we have measured the posterior tibial slope and the flexion of the femoral component with proper AP and lateral X-ray, and measured them on Bone Ninja software. And here you see that pre-operatively it was 9 degree, post-op 3 degree we planned, and what we achieved is 3 degree of varus. So subjectivity is gone with the help of these systems. Everything is in objectivity, and this is what the pre-op tightness in the ligaments were there on the stress views. And this is on post-op after correction from 0 to 120 degree. The MCL is about 1 millimeter lax, and LCL is about around 2 millimeter laxity is still there. So you know you want that kind of laxity for proper ligament balance and proper function of the knee. And that is what on post-op scanogram you see we have achieved 3 degree varus. So robotic planning helped us, and this is what the whole summary was. pre-op, intra-op and post-op limb alignment. So you see the overall post-op limb alignment was 3.7 degree of varus, not neutral. And that was the planned varus. So the deviation is around less than 0.5 degrees. And what about component placement? If you see, the tibial component was placed in about 2 degrees varus, and what we achieved was also the same. Even in the femoral component, the varus was kept residing depending upon the laxity you want to achieve on the medial side. So 1 degree. So the conclusion of this paper, which has been published in Indian Journal of Orthopedics, whatever alignment philosophy you believe, whether you believe in mechanical, whether you believe in kinematic, whether you believe in functional, if you plan, the overall coronal limb alignment outlier has been reduced to less than 1.2 degree. So if you plan 4 degree varus, you may achieve 3 or 5 degree. So you are quite accurate, and the component placement malposition is less than 1 degree. So as per your planning, if you have planned slope of 5 degree tibial slope, 4 degree of external rotation, the variation will be less than 1 degree. So this has been accepted and published. So accuracy of limb alignment and component placement was quite accurate with robotic. Now, does it also helps us in achieve the external rotation of the femur? We speak a lot about external rotation of the femur, which plays an important role in flexion gap management as well as for proper patella tracking. And we are again the same slide, because we know the success depends on 3 things. So femoral rotation we need for proper patella tracking and proper flexion gap balance. When we get this rectangular flexion gap, we are quite happy. But most of the times you are difficult to get that because of your external rotation and sometimes because of your soft tissue tightness as well. And we have various landmarks where we use conventional white side line, posterior condylar, transepicondylars, you use spacer blocks, laminar spreaders to get that correct flexion rectangular gap. But everything has faults and pitfalls and benefits. So none is perfect. So we all know that 3 degree external, so even in perfectly executed TK, routine setting of femoral 3 degree will yield significant error. So 3 degree external rotation, is it correct to give everyone 3 degree? No, even with computer navigation, there was variation from internal rotation to some degree to external rotation. So whether this external rotation of femur can be achieved correctly with your robotic planning. So we have done another study in which we planned the external rotation as per the tightness of the ligaments and whether we have achieved the same external rotation. So we have done CT scans of all the 30 patients. So it was again a prospective study of 30 patients where same patient, inclusion criteria was same, that primary and secondary osteoarthritis of the knee. Revision and unis were cut out from exclusion and all were done with Navio robotic system. Post-operative CT scan was done in all the patients to assess the external rotation of the femur. Philips 128 slice detector CT scan was used, and both the radiologists, senior radiologists, were unaware of our intraoperative finding when they were doing the external rotation measurement. So this is what your robotic system shows, and you go with the help of posterior condylar axis, 0 degree to it, and this is what the planning stage is, what I was all talking about. So here in extension, you see the medial side is little tight, the 2 mm, 9 mm cuts, but here you see the external rotation is 0, and you see a lot of tightness on the medial side. So once you change that external rotation to 4 degree, your lateral side has been balanced well, and your medial side is hardly any tightness, because we know once we do the posterior condyle cut, there will be some sort of capsular release, and that will open. So that adjustment of 1 to 2 millimeter tightness we should keep in mind when you do this. So that planning stage is very important, and here also you see we have changed the dimensions, everything. So this is the most important step in robotic, because if your plan is perfectly depending on your tightness of the laxity. So lateral side should be balanced well. We all know most of the knees are varus, so there have to be some tightness which will get released once you do your proper bone cuts. And this is the way you again execute your, and this is what it shows, a sequential execution of with help of all burr. And this is what we have achieved. the ligament balance post-op from 0 to 120 degree again, which was tight initially before we started, and it's balanced well. So what our study showed that we need 3 degree external rotation only in 37% of patients, and 1 to 5 degree in 10%, 1 degree in 13. So 3 degrees should not be considered as a norm for external rotation. So this was post-operative CT scan we have done, where line AB passing through the distalmost point of femoral component known as femoral prosthesis posterior condylar line. And then point C is the lateral epicondyle of the femur, and point D is the base of medial sulcus, which is the center of the medial epicondyle. Shows line CD, a line joining the base, so this forms line CD. So the angle between line AB and CD is calculated, which is the external rotation. In this case, it was 2.4 degree external rotation. So this is what the study shows, that whatever we have planned, the variation was less than, so we have planned for 2.86 degree of external rotation and we achieved 3.1. Minimum was 1, maximum was 5. But the strong outcome of this study was there was none of the component was in internal rotation. And again the same thing, that's the stability you get on table after you finish your robotic knee, the medial lateral as well as flexion extension, and that's the rehab of the patient still in the operation, still in the hospital, and then she is discharged. So the conclusion, the deviation is less than 0.3 degree external rotation as per your plan. So take home, all burr robotic assisted TK helps you to achieve your desired limb alignment. Component placement malposition is reduced in all the 3 axes. This in turn gives accurate ligament balancing. Thank you.
Thank you, Dr. Mukesh Ladda. Probably he has to leave for Nagpur. So any questions? Huh?
He has one more talk.
Okay.
I have another talk on revision knee, sir.
Okay. Okay, go ahead. Yeah. Go ahead, proceed with next. The next topic is reasons for failure and revision of aseptic loosening.
Try to be in time.
I will, sir.
Yeah.
Agree, sir. So for revision still we have to go the conventional way. But robotics helps you to understand the conventional also in a better way. Again, the same slide repeats. So the reason for revision TKR is, one is polywear. If the component malposition or limb alignment is not in proper desired position, that will lead to polywear, and you will see this polywear and poly causing aseptic loosening. One of the common reason in long term is polywear. Second is definitely infection, which we all know we have to deal with. Every one of us might have gone through this. So you need to deal, whether it's early infection, it can be a single stage, and if it's a delayed infection, you have to go with the gold standard 2-stage revision knee. Third is component loosening because of bad bone bed preparation or bad cementing, as this case got loose within 2 years post-op, as it was a malposition of the components which has led to the failure of the TKR. Malalignment overall, if you put the tibia in too much of varus, then you will have an early varus collapse and the fracture on the medial side, and then you need to revise it with cones and other things. Periprosthetic fractures in case of osteoporotic bones, if it is there, that could be one of the reasons for revising the knee, and then you have to use LPS rotating hinge knee platforms to revise that. Component malposition, again, as you see, the tibia was not covering the rim, and that's why the tibia sunk medially and it has resulted into varus collapse. So the most common reasons for failure in late stage is polywear, loosening and infection. These 3 are the most important reasons. Then the rest, periprosthetic fracture, osteolysis, instability, are the other reasons which leads to the failure of total knee replacement. Few slides what I want to tell you to avoid TKR in young patients less than 50 to 55, because we know revision is a burden not only to a surgeon but to the patient also. So a nice article in Lancet in 2017, it says that if you do TKR in patient less than 50 to 55, the lifetime revision risk increases by 35%. So be careful when you operate young chaps less than 50, 55, whatever technique you use, but that will have worse results. And the projections in up to 2030, they say that there is an increase in TKR by 55% with the strongest increase in patient age 45 to 55. As a consequence, the number of revisions is increased. So use some knee preservation osteotomies in the patients in younger age. And you see the success rate of patient in less than 50 years. There is 84% survivorship for all kind of reoperation at 13 years. So if you operate anyone in 45, definitely they are going to come to you around 60 for revision, which is not the older age. So a word of caution of operating younger patients for TKR. This was a 76-year-old male who had primary TKR done some 9 years back, and he came to me with limp and pain and unable to walk with instability. All blood parameters, knee aspiration were negative for infection. So revising any knee until proved otherwise, consider infection. So rule out all parameters of infection, even though you believe this is not infection. Get it correct on paper. Exposure in the revision knees is important. You need to have a wide extensile approach, no subvastus approach, no MIS, nothing in revision knees. A good extensile approach, a good medial periosteal sleeve has to be there to sublux the tibia anteriorly. Use this pin on the patellar tendon to avoid inadvertent patellar tendon avulsion. Quadriceps snip, sometimes you may need to get it, but if it's still tight, you can use a tibial tubercle osteotomy to expose your tibia and sublux the knee. But it should be a wild extensile approach. Component removal is important thing. If the component in this case was quite loose, so you are lucky enough to get it out. But see that you remove that with minimum bone loss. Or sometimes you need to use the Gigli saw in the femur to remove a well-fixed component for some other reasons. Use small chisels, osteotome, to make the component free from distal and posterior aspect, and see that you remove it with minimum bone loss. So this should be the aim. The bone loss should be quite less both from the tibia and the femur. Preservation of bone is important for revision knee. Assess the bone loss. We have Anderson classification. Minor bone loss. Type 2 is metaphyseal both on the tibial and the femoral, and there is significant metaphyseal. As in this case, you can see there was a condylar loss on the femur medial side, as well as there was a metaphyseal bone loss. So this was type 2B bone loss in this case. So a good algorithm given in the article by Mr. Seth, how to manage the femoral bone loss depending on if the epicondyles are lost, then definitely you have to use some hinge kind of knee because your collaterals are totally gone. But if the defect is less than 10 and more than 10, if it is less than 10, you can use some augments. If it's more than 10, you need to use some metaphyseal sleeves or cones. So in this case, I have used 2 metaphyseal sleeves both on the femur and the tibial side. You can use cones also from the trabecular metal cone from Zimmer to fill in the gap, and you have to build that metaphyseal bone loss. Condylar bone loss, important here is how to maintain the external rotation of the femur in case of revision TKR. You just need to use posterolateral augment double than the posteromedial. A simple step to get the correct external rotation of the femur in revision. Use posterior lateral augment bigger than the posteromedial, and the distal augment depending on how much you want to get the joint line correct to the correct position. Again, same for the tibia, bone loss, same as what you have discussed. So in tibia, again you need to use the good metaphyseal cone sleeves, or you can use your cones from Zimmer, and you can get the correct joint line distally from the proximally from the fibular head and distally from the medial epicondyle. Joint line maintenance is very important in any knee replacement, revision knee replacement, because that will hamper your flexibility of the knee. And correct joint line is round about 2 centimeter distal to medial epicondyle and around 1.5 centimeter proximal to your fibular head. So you need to use the sleeves to build up the metaphyseal bone. It's not necessary that your tibia should sleep flush on the tibial plate flush on the bone. You can use the sleeve and fill that gap with the help of some cement. And when you flex, the patella lower pole should be in line with the poly. That's what your correct joint line maintenance is. And if you have that correct joint line maintenance, you have a correct femoral rotation, femoral tracking without touching the patella. So this is what you should achieve in your revision knee also. And that was the post-op X-rays with the sleeves and a semi-constrained liner. And this was 1 year follow-up of the same patient. He is having diabetic neuropathy, so he's little cautious in walking, but he's pain-free with good movements, and 1 year follow-up shows, see, the tibial base plate is not touching the original bone because you have used the sleeve in, which takes care of that metaphyseal bone loss. You can even don't put cement and leave it like that if you wish like. This was another patient who had again a loosening very soon because of bad component malposition. So he had a significant anterior bone loss. There was no much metaphyseal bone loss, but definitely condyles were lost. Tibia was not that bad, but anterior femoral bone loss was there. Component came out, but see, it had taken bone with it comparatively in the last case. Tibial didn't take any bone because it was quite loose and came out easily. This is what you do for tibial cut. Intramedullary jig you need to use and take minimum about 1 millimeter of bone just to reshape the proximal tibia surface. After thorough debridement, assess your bones, whichever you have lost. There is no metaphyseal bone loss, only condyles were lost. So I've used the augments here with the intramedullary rod, and then this was the 3 months follow-up, and that was his 6 years follow-up. This guy is riding a bike comfortably. There is no loosening of the components or sinking of anything. No lysis around any part of the femur or the tibia. There is some cement which I have used anteriorly, still looking well osteointegrated at 6 years follow-up. So patient does well if you follow the principles correctly in revision knee as well. So identify the reason for the failure. So it may be a single stage or 2-stage revision. Proper pre-op X-rays are must to assess the amount of bone loss. Always rule out infection, grade your bone loss, use sleeves and augments, and when necessary, go for constraint or LPS knees. Thank you.
Thank you, Dr. Mukesh Ladda. Any questions to Dr. Mukesh Ladda at this moment, please?
In Navio? Yes, because if you see, most of us are in Indian subcontinent, we have tibia vara. So since long we may not be in the correct mechanical 180 degree, and if you give everyone 180 degree, I think that could be one of the reason for dissatisfaction. I have no foolproof answer to it right now. Regarding satisfaction, another study is going on which will be out by a year. How much satisfaction score patient have with all this alignment.
Yeah, but keeping the varus may satisfy the patient, but overall longevity of the implant because of the malalignment.
If you see the kinematic paper by Professor Hovels, the 10 years, 8 years or 10 years results out, there is no loosening of varus. So the 3-degree outlier is still what we are keeping in. But how to keep it 3 degree with conventional, we don't know. So that's what we are keeping it still in 2 or 3 degree of tibia vara, not beyond that.
With the robotic you are doing, you said that you can go back and change the plan, but it is difficult because your planning has been done before making the cuts. You can't change the cuts after you have made the plan, and that is the problem.
No, we can change. We can do that, sir.
You can't.
In case of Navio, if suppose you have planned 9 mm on lateral side and 2 mm on the tibial medial side, when you take
when you do the soft tissue balancing after removing osteophytes, but you can't remove the posterior osteophytes.
I agree, sir.
So when you have made the plan that it is tight in flexion or tight in extension, and then you change your component position accordingly, and once you have made the cut, and when you remove the osteophytes, things change.
It's only the soft tissue changes. The bony cuts doesn't change. So we keep the, if you see the planning is always 2 degree tight on the medial side because of varusness.
That is what is the drawback of Navio or Cori, because I use the Cori as well.
It's not a drawback, sir. We can't, then you have to do over advertent release and then do. So this will prevent inadvertent soft tissue release.
That is what I was asking, how do you manage it? But in future, I think they have to, if they can make something that once you have made it and you can change the plan, then that would be ideal.
They may come up with that feedback. Yeah.
Well, that is what the thing I am facing at the time. That's the only thing.
Right, sir.
Yeah, but then it will cut too much of bone. Suddenly, if you change the plan at that particular time, because
it will excessive cuts.
The cuts already, now suddenly it opens up.
Yeah, that is the thing.
That's
in
why
this, when you are planning it, you have to keep it a little bit tight. Because
So
you have
it depends on the osteophyte, whether there are osteophytes or not and all that.
It differs case to
if-
case.
Yes.
Yeah.
If you
So that
don't
is
have
what-
any osteophyte, then you don't keep it too
Don't.
tight. But if
You
there are
have to do
osteophyte,
that eyeballing at the time of thing. I mean,
So what I feel this robotics is basically helping you to get the maximum bone cuts play also and minimum soft tissue. Things little
The
different.
other thing was soft tissue balancing is still play.
It has to be with us only.
It has to.
It has to be
work
with surgeon only.
Because you can play, you can get a very good, well-balanced knee on the screen, but sometimes.
So that's what it's in our hand. Everything can't be machine.
That's true. In every machine.
so it's a
Yes.
combination of both. It's a human and robotic.
So you have to use your brains.
Have a proper cuts of the bone in a absolutely precise. That is why we need robotics.
Yes, sir.
Mukesh, you just told that in times to come, even younger patients with bad knees or tricompartmental knees are going to come. They have started coming. What is your protocol? How do you counsel them for maybe the next revision?
So in younger patients less than 50, yesterday I have shown I am started doing dual level osteotomies in patients less than 50 years, provided they don't have much of the varus thrust or laxity. So if the younger patient comes to me, I say them whatever good job I do, you will come to me after 15 to 20 years for revision. They say, why sir? I told them you are going to use it more compared to a 65 or 70-year-old guy who will use it less. So younger patients, I have given them options of corrective osteotomies. If they are understanding the concept of it, they won't be 100% pain-free with my osteotomies, but they will get a longevity of the original knee for say another 7, 8, 10 years, depending on how bad is the knee. If they understand, I'll do osteotomy. If they don't, I'll do replacement with some good implants. All implants are good, but with proper balancing and proper placement. But counsel them that you will come back to me within 20 years, around 20 years for revision.
So what is the cutoff age of doing a arthroplasty? Is there any age?
Sir, it all depends upon if it's a rheumatoid. I have done in 40-year patient also because it was a rheumatoid knee. But if it's a primary osteoarthritis knee, I'll try to defer it till 55 years of age. With osteo. Then I have to do. That's what I'm saying. It's a case-to-case base. If it's a very bad tricompartmental, I have done in 40, as I told.
So age will not be that big a criteria.
It has to be a bigger criteria, provided that it's not tricompartmental, it's a unicompartmental, or even if it's a bad varus of say 15 degree and the patient is having very minimal patellofemoral, good lateral compartment, a dual level osteotomy. Or if it's an AMOA, I may go for uni also.
So it's a uni, which is another good option if it is really medial compartment.
But it has the restrictions. You can't go beyond 10 degree varus. It has to be only AMOA.
It is really indicated unless it is not.
So I'll be talking on that uni in maybe 1 hour.
Right, sir.
That is what I was asking, because when you rise in the ladder of the arthroplasty practice, patients come with demand. आपने उनका तो कर दिया है वो 60 साल के हम 50 साल के क्यों नहीं कर सकते? How do you counsel those patients?
So that's what I tell them. वो patient ही बोल रहा है ना साहब वो 60 साल में किया है तो आप 10 साल छोटे हो ना, तो 10 साल आप और इससे साथ ऐसे निकाल लो या हम कुछ ठीक करके निकाल दे और 10 साल बात करें.
So you want them to remain painful for next 10 years?
See, it's a very difficult
asking.
question. There is no foolproof answer to it, sir. There is no foolproof answer. It varies from patient to patient. As sir told, tricompartmental bad knee at 40 also I'll do. Unicompartmental with good patellofemoral, I'll preserve it even at 60. So patient to patient, if that patient who has tricompartmental in 50, I have no option other than TKR to offer him. So, and the stage comes when they are in only unicompartmental, then you can ask them for HTO or you can go for uni. Yeah.
So
What
best
I
thing is to
your
explain
question,
everything.
Hemant, the counseling, I tell the patient you are 45 and this is the main time of your life when you should enjoy your life. So if I do a knee replacement now, probably 15-20 years, you will have a very good quality of life. And don't be afraid of revisions. You'll need a revision and results of revision are pretty good. If primary is done well, revision will do well as well. And by that time, you'll be very well experienced with revisions as well.
We are just talking about absolute indication of total knee. I'm not talking about uni, I'm not talking about HTO.
Absolute is tricompartmental irrespective of age. Yes. Yeah. Internal rotation is a crime. Femoral component internal rotation should not be there. It badly affects the patella tracking and your flexion gap. So no internal rotation to femur.
Atish, alignment philosophy and younger patients. Your comment.
So in that I'll do pre-op scanogram, and if I see that there is a significant varus but that is only intra-articular, there is no much bony deformities, and the varus is say around 8 to 10 degrees only. In younger patient, I'll prefer to do uni in such patient, keeping the knee still in about 4 to 5 degree of varus. Again on scanogram, if I see that the varus is too much and I have to do a TKR, so I'll keep them in alignment of about 4 to 5 degree varus, because I feel younger chaps who have come with primary OA, they have inherent tibia vara or something, that's why they have got early tricompartmental OA. So I won't take them to neutral alignment.
We can label it as functional alignment.
Yeah, functional alignment. Right.
Right. Thank you,
Right,
Dr. Mukesh,
thanks you.
For a very nice elaboration and lecture. Do we have Saket here, Dr. Saket Jati? No, sir. He's not there. Okay, great. So we'll call Dr. Deepak Dave, my senior colleague from Ahmedabad. High flexion, reality or myth?
Okay, so this is the topic about the high flexion knee. It's not the high flexion knee, it's our results, whether we achieve the high flexions or not. We were just talking about younger generations. So their expectations and demand is really very high. They want the knee to last long. That's what just we discussed with Mukesh's lecture. And higher functional demand, they want to do everything, and they also want that your implant should live longer. So because of this, what is a problem we are facing? Does total knee replacement restore the normal function? So in 52% of the patients who are total knee arthroplasties, some degree of limitations of functional activities is there. We all know that people don't get everything what they want. And what functional activities are important in patients with knee replacements? So they feel the squatting and gardening is more important. Do the patients care about higher flexion in total knee arthroplasty? And there is a randomized controlled double-blind trial, and which says that the 130 degree more than 130 degree flexion is associated with patient satisfaction. I think Dr. Mohanty earlier told us that we should try to find out what is the patient satisfaction. Dr. Mukesh also said he's going to come out after 1 year with that study. So most important thing is
what is patient satisfaction. And we feel that if they have more than 130 degree of flexion, they are more satisfied. And range of movement, it does correlate with the patient satisfaction. Now, you don't want unhappy patient, you want a happy patient. And what is happiness? They want the range of movements. So all the literature says that if you have a more flexion, your patients are going to be more happy. That's been documented well with the different studies what we have shown. And we all know the Turkish line in the Asian, not only in India, in Southeast Asia, in Japan, and in the Muslim world, we all know that we need a lot of flexion, and this is our routine. So the patient's expectations and satisfaction for this is going to be important. There is a paper where they said that if you tell the patient that you're not going to get full squatting or full cross leg, they will not go for the surgery. Probably this is still true in some of the patients here also. And at our places also, patient demands that we want this. So where we stand, can we really make our patient happy by giving them full flexion? Is full flexion a reality? Should we go for it? Should we promise them this? And do we have backing of the long-term results that are, as you said, that in younger patients, after 13 years, you're going to need a revision. So is this going to happen along with the high flexion added in a younger age group? They are more demanding. So you have a young patient who uses it more, who does the high flexion, and now you want longevity. Is it going to be possible? Is it a reality? So these are three factors. When we promise the patient, when we assess the patient, when we tell them, don't give us a rosy picture, don't give them a rosy picture. We tell them that, okay, this is the reality. So what are the factors going to affect to give them the full flexion? One is the patient factor, surgical factor, and the implant factor. So patient factors, we all know that the preoperative range of movement is directly related to postoperative range of movement. Careful, those who have a high degree of flexion beforehand may lose something in some cases. Those who have a less flexion are going to gain. But if a stiff knee, they are not going to get the full flexion. We all know that. So many patients, factors like obesity, age, previous surgeries, post-traumatic arthritis, and the post-operative rehabilitation, pain control, that is also important after the surgery to get the movements back. And the female. So these are the factors which we need to keep in mind when we tell them how much movements they are going to get post-operative. But at the same time, there are surgical factors which we need to keep in mind. So if you are oversizing the femur, your flexion gap is going to be tight. If you don't maintain the posterior offset, right, you should avoid the bony impingement to get the more flexion. Don't elevate the joint line. As we know, the acquired patella baha is going to give you less flexion. So this is, if your patella is lying like this, you're not going to get good flexion. These are the important points which we need to do during the surgery. Patellar thickness. So you should avoid the anterior compartment overstuffing and try to measure pre and post. Make sure that you don't increase the height. When the gap balancing is not proper, your extension gap is more than the flexion gap, and you try to put the bigger, thicker poly, it's going to make your flexion tight. It will reduce your the flexion. So surgically, even the slope of the tibia, right? If the anterior slope is there, it's going to make the flexion gap tight. Relatively posterior position of the tibial component, your placement of the tibia, that also makes a difference. And the component malrotation, we already discussed in the robotic things that you don't external rotation or internal rotation, whatever is required. I have not used internal rotation, I have used malrotation. So whenever you need whatever rotation, but if it's malrotated, your one side gap is going to be tight. Posterior osteophyte clearance is not done properly, right? Then also you don't get the deep flexion, and your patellar tracking is also important, whether it is your exposure or your rotation, but you make sure that your patellofemoral tracking is quite good. And this is what we have to be careful. Now with the PFC normal or any simple metal bag PS design or CR design, we are able to get the flexion. Now the point comes that you have taken care of your surgery, you have done proper surgery, you are getting the full flexion. Is this implant going to last or survive the load of the flexion? That is the point now comes where the factor of implant comes into the picture. So here you can see the PFC sigma and PS 150. Good flexion is achieved, but there is the age loading in one of them. So there was a need to revise this, to change the design. We were able to get the flexion, but this is not going to last. It's going to lead to the poly. Even the polytibia, you can see here, you can achieve the flexion, but is this design going to survive the load for the longer time? This was the thought process, and therefore there was the need for the implant design. So various companies, various designers, they thought that let us do something so that you get a better flexion and the implant survive. There is no age loading, there is even distribution. So the design came, none of which is available now, like PS 150, right? PFC RPF, right? And LPS Flex is there, but there are certain designs which were there. And what they found, that these designs were not giving a long-term satisfactory results. And there were lots of issues, like the bone loss was there. You have to cut the extra bone. And these factors were kept into mind. And then they again realized, now we need to change something. Why PFC RP? There is nothing wrong with the company, or I don't want to criticize the implant. I'm not at that level. I can't do that. But we know that the PFC RPF is not there now. PS 150 is not there. LPS Flex Next Gen, you need to cut lot of posterior bone condyle. So these designs were there to aim to get more flexion. And because of this, they had to change because there was a lot of bone loss and other things. Now, because of this, the lot of design factors came into the picture. And the most important point was, as I said, the increase the optimizing the contact area. What they did, the anterior recess of the tibial polyethylene, right? They cut it so that you get a better, less impingement on the deep flexion. It will give you more clearance to reduce the stress on the extensor mechanisms. The cam and post mechanism, there was a lot of change which has come. They have make it little down, posterior in the lower down, so that the stability of the cam and post mechanism is there in the deep flexion. These sort of changes have come. Even the cam and post mechanism, there is an asymmetry, like in the freedom knee, they have designed in such a way that even in the deep posterior part, right, when the deep flexion, the stability is maintained and you get the flexion with the rotation. That is what the design change they have done. This sort of things have been done. The patellar groove have been changed, and so the tracking is proper. Various companies have come out with different designs. Like in triathlon, they were flaring up the posterior condyles, but asymmetry of the condyles is there because, as I said, what you need is the flexion plus rotation. That is what is like design changes have been done. Like in this design, what they have done is, instead of cutting the extra bone, now they have changed the radii. So different companies have come with different principles. Like in the Attune, they were gradius. Like in a freedom knee, there were multiple 7 radii. The radii keeps changing when you go in the posterior part in the deep flexion. Striker has got a single radii. Ultimate aim that you don't cut the bone, you don't sacrifice the bone, and still you get the more flexion. So this sort of things have been done. All the randomized trial of the high flex knees shown in the literature, they don't show the good results. Short-term results were not very good, and therefore this type of design changes have came. All of this was RPF, PFC sigma, PS, RPF, as I said, these were the literature studies which were not showing a satisfactory result, and therefore it was necessary to do some more changes. But very few results are there for the high flex total knee in a short-term, medium-term follow-up. And one of the good paper, which is this where implant survival is 98.7% and deep flexion seems not to affect the long-term durability because of the newer designs which has now come. The previous studies, as I said, many of the studies, they are in favor. 8 studies were not in favor of the high flex design. But now there is nothing like high flex, right? All the designs are incorporating so that you can achieve the flexion if you want, like the radius changes, the tibial recesses, and other factors which I showed. So what it comes down to, your selection of the patient factors, your surgical technique, avoid the problems which I suggested you, and the implants is going to facilitate you to get the flexion, and it will take the load of the flexion for a longer time for the younger patients. This is what it is. Thank you.
So any questions regarding Dr. Dave? So I think if we make them understand, if we allow them sitting on cross-leg on bed or sofa or something on the higher side, that is okay, that will not have that much of forces. But if they do namaz or something sitting on the floor, will have a lot of stresses on the joint. So most of our patient does not have that much of demand, but if they are allowed to sit on the sofa or something with cross-leg, they are happy about it. So it's always better to explain them.
Yeah, it's not a good to give them a rosy picture.
Right.
As I said, there are so many factors. It's not the implant only. Your surgical technique is also important. Your selection of the patient is also important. Stiff knee patient, if you put a high flex design and tell them you are going to get, it's not going to work. So it's a multiple factors, but the good thing is that the new implant which has now come by almost many companies have put lot of change basically to bone saving, because everybody is just discussing here younger age patients, worried about revision, need a bone stock. So cutting the 4 mm extra bone, and especially in a smaller size, when you have 1.5, 2 size and you cut so much of the posterior condyle, you don't keep anything for the future. So, and again you have a PACS there, some designs, plus you cut the bone. So there's a lot of bone loss. So then they came out with a change in the radius, different type of designs have come, so that you preserve the bone and still get the no age loading and get flexion with rotation, which is facilitating the design itself.
And very nicely Dr. Dave said is the pain management. Unless you get a very good pain management for initial 6 to 8 weeks, these people will never get a full flexion or a good flexion. So you should have a very nice pain management in the early recovery phase. Right. Thank you very much, sir. So may I invite Dr. Amber Mittal, who is going to talk on soft tissue balancing in total knee replacement surgery.
Once again, good afternoon, everybody. So I would be talking on soft tissue balancing in TKI, and I still feel that the soft tissue is the most important part of the TKI surgery. So let's start with the factors which affects the TKI survival. Let's start with the ABC of TKI. A stands for alignment, B for balancing, and C for component position. And this leads to a successful TKI surgery. The most important factor in maintaining long-term outcome in TKI is the anatomical alignment, which depends significantly on ligament balancing. So if you have not done a good balanced knee, so the alignment is not going to last long. So why balance the knee? Because an imbalanced knee will lead to pain, will affect the range of motion, will affect the stability. It will affect the implant longevity in terms of wear and loosening. So an imbalanced knee will lead to a tight ligament on one side and a loose ligament on the other side. So this will lead to pain and instability. An imbalanced knee would would distribute unequal contact stresses on the poly. As you can see here, the contact stresses on this side is more, and this will lead to polywear. As we can see in an imbalanced knee, there is an eccentric loading. You can see on the bone skin, one compartment has higher uptake, so there is an eccentric periprosthetic bone loading and stress. And this changes significantly when the knee is malaligned. And this will lead to loosening. So what is an ideal alignment? So now there is a debate about since the morning about the alignment, whether we need functional alignment, kinematic alignment, or a mechanical alignment. So we can have a mechanical alignment perpendicular to the mechanical axis of the leg. With what we want is a symmetric flexion and extension gaps. As we have discussed earlier, that when you have your alignment, the Mikulicz line outside 3 degree, the failure rate is high. This line passes from center of the head of the femur to the talus. So what are the balancing principles in TKA? So we have to balance the flexion and extension gaps. We have to balance in varus and valgus. And in these two planes, this should be balanced throughout full range of motion. So it's not in only flexion or extension. The knee should be balanced throughout range of motion. So what are the basic principles of soft tissue balancing? In short, whatever release, we have to titrate the release carefully. We have to look for osteophytes. If the osteophytes are there, we have to remove the osteophytes first. And then only we go for the soft tissue release. Just do adequate release. If required, release less. Excessive release is an overkill as it lengthens the soft tissue sleeves. Too vigorous soft tissue release might require the use of more constrained implants. So what we want is to achieve a rectangular flexion and extension gap which has to be equal. So let's understand the effect of soft tissue on flexion extension gaps. So how it is related? It is related to their relation to the epicondylar axis. So the structures which originates anterior to the epicondyle, they affects the knee inflection like popliteus and PCL. Structures which originate posterior to the epicondyle like posterior capsule, biceps, semimembranous IT band, they affects the knee extension. And the structure which originates at the level of epicondyle like the collateral ligaments, they affect the both flexion and extension gaps. So in short, I would be discussing on different deformities, varus, valgus, flexion. As in details, we have next lectures on. So first step is to determine whether any deformity is fixed or correctable. So if it required, we can take the stress view, and if it is correcting on like this is a varus knee, and if it is correcting on valgus stress, so these correctable deformities needs minimal releases. So since this tissue, the sleeve is there, so we do not need to release in case of correctable deformities. So what are my approaches? I do standard medial parapatellar orthotomy. Nowadays I have shifted to more of Savastas approach. Resect the medial meniscus, preliminary release of D part of MCL, resect the ACL, externally rotate and deliver the tibia forward, and remove all osteophytes. Removing the osteophytes is most important. Medial release from the tibia in case of varus knee. We do release the D part of the MCL and the posterior medial capsule, remove the osteophytes. If you are a PCL sacrifice, if you do not get adequate release, you can resect the PCL and put a PS knee. Femoral component rotation, as we have seen. So to establish the balanced symmetric flexion gap, we get first balance the knee in extension. We can use a wide side line or transepicondylar axis, and as we have discussed, 3 degree or more external rotation by 1 or 2 degree in varus knees is required to achieve a symmetric flexion gap. So these are the medial structures. So always avoid going too distally, as we do not want to injure the superficial MCL. So the importance of superficial MCL is this is a structure which is 7 to 8 centimeter distal to the joint line. So when we release, you can see in this slide there is a change in gap. So when the part of superficial MCL releases, it's 1 or 2 millimeter opening, but when the superficial MCL is released completely, there is a significant change in the gap. So similarly, when you release the superficial MCL significant change in alignment. So avoid releasing this part of MCL. So joint opening after release of deep MCL is and the semimembranous and posterior capsule. So this gives 1 to 2 millimeter opening. Superficial MCL gives a large opening in the medial joint line. So please avoid releasing the superficial MCL. Just an example, a case with severe varus deformity. Use bone graft with stem. So a proper balanced knee will lead to a successful outcome. In case of valgus knee, I'm not going into the classification. I think Dr. Dave is going to demonstrate today on a valgus knee how to do a balance of valgus TKR in the afternoon. So Whiteside has described sequential releases starting from IT band, popliteus, lateral collateral, lateral head of gastrocnemius. Rarely do you need tibial tubercle transfer. Different techniques have been described by different surgeons. Insal initially released that IT band transversely above the joint line, but that had high incidence of instability. Initial paper by Dr. Ranawat, they divided lateral retinaculum and IT band, and they also detached lateral collateral ligament and popliteus from the femur, and this has led to high instability. Then they shifted their method, and what they did was they cut the tibia first, they balanced the knee in extension with the releases, and then flexion gap is balanced to adjust the femur cut. So femur is rotated to balance the flexion gap. If still the structure is tight, we can do a pie crusting technique where we can intra-articularly release in extension of the contracted posterolateral capsule. So we can do this, the IT band we can slice, and we can do the posterolateral capsule. And we can adjust, we want this to be a flat space, so we can adjust the femoral rotation according so that we get a rectangular flexion space. What is the downside of flexion gap balancing by adjusting the femoral cuts? So if we are externally rotating too much, there is a chance of femoral notching. So we may have to just translate the femur anteriorly and then rotate. Patellar maltracking, especially in case in varus knee, this is not a problem because you are externally rotating a tibia by 1 or more degrees. But in case of valgus knee, you cannot internally rotate the tibia, as we have heard by Dr. Mukesh that internal rotation is a crime. So you cannot internally rotate the knee in a valgus knee to improve the lateral space, as this will affect the patellar tracking. So this is one just slide. As you can see, this is the IT band. So if I release IT band in there, this is not going to give me an extension space in flexion. So for flexion, I have to release this part. If I want more space in extension, then we need to release the IT band. So IT band is parallel to joint line in flexion, so it would not make sense to release IT band if there is a tightness in flexion. So if tight in extension, IT band and lateral posterior capsules are released, so we can divide the IT band and the posterior capsules in to get space in extension. So what are the crux of valgus release? So ligaments are released in their mid substance. Inside out technique is used. Not all lateral structures are involved in the procedure. Popliteus tendon has to be preserved. Balance the knee in extension first, and in valgus knee watch for peroneal nerve function. In short, talk on flexion deformity. I'm not going into the classification. Most important is the removal of osteophytes. And examination under anesthesia is also important, as many cases stretches under anesthesia. So the requirement of release has been minimized. Most important is to use a curved osteotome, go to the back of the knee, take out all the osteophytes, and this will help the extension space. This is important to free the notch of any osteophytes. So flexion contracture is there in mainly four places. The posterior capsules are tight, the PCL can be sacrificed if there is too much FFD, and the distal femur, excess distal femur cut can be taken. However, we should avoid taking distal femur too high, as to avoid the elevation of joint line and mid-flexion instability. So the more severe the deformity, we must consider the pros and cons of additional bone resection and soft tissue releases. So when we take additional bone, the joint line is positioned slightly more proximally and it leads to primarily quadriceps laxity and secondary collateral laxity. So we should avoid elevation of the joint line. So we should always watch for vascularity in case of severe FFD. Look for any vascular insufficiencies, any pressure ulcers, any peroneal nerve palsy in severe FFD. So to conclude, the most important factor in maintaining satisfactory long-term outcome is anatomical alignment, which depends significantly on ligament balancing. No formula is exact for the treatment of the problem. Consider a balance between soft tissue release versus bony resection. I thank you all for a patient hearing.
Any questions? Okay. So I'll request Dr. Ambar, please come here. Dr. Dave, please.
For next session, I invite Dr. Alok Jain sir, Dr. Ankur Maheshwari sir, and Dr. Hemant Mandora sir to chair the session. Dr. Hemant Mandora sir, Dr. Alok Jain sir, Dr. Ankur Maheshwari sir, please chair the session. Dr. Alok Jain sir, please felicitate our chairperson.
At the outset, first of all, let me remind all of you that we are running way late in our schedule. So I would request each and every speaker to stick to his time, and we will try to get away from the formalities. So let's invite our first speaker.
So may I invite Dr. Pradeep Chaudhary to speak on varus knee, principles and video demonstration.
Good afternoon, everyone. Because of shortage of time, I'll escape the video and just finish the talk well in time. Varus knee. What is a varus knee? A macute line, a load-bearing axis passes from center of the femoral head to the center of the talus. Ideally, it passes through the center of the knee. When it is medial to the center, it's a varus knee. As you see, this is left side is a normal one and the right side is a varus knee. There is a definite classification is given about the varus knee. It is described by Paparazzi. The type A is the anteromedial OA varus knee. Type 1A is another posteromedial OA varus knee, which typical sees on the lateral view. And type 1A is a fixed deformity with laxity on the convex side of the deformity. And type M is an anteromedial OA varus knee. And type M, joint line obliquity inverted after HTO. And another one is type D, a distal femur level deformity with extra-articular deformity of the femur. So what is the algorithm to correct varus knee in a TKR patient? Think in terms of anatomy and classified, decide in terms of soft tissue and bone deformity, execute it with tips and tricks and traps of spatial techniques. So basic tenets are preoperative plan, assess and plan, medial release, osteophytectomy, metaphyseal bumpectomy, quadranto deformity in bone loss management, and avoid over-release. Using the steps are there, we'll do a medial exposure using scalpel or subperiosteal elevation of the medial sleeve is done. Include joint capsule in the deep MCL. Continue the periosteal elevator to elevate the medial metaphyseal flare of the tibia. Like this, we go on, release the medial structure. Step 1 in the varus knee is osteophytes. Remove all osteophytes from the femur and the tibia as they can tend the medial soft tissue sleeve and consequently shorten the medial collateral ligament. Remember to check the posterior femoral condyle and posterior medial tibia as they tighten extension gap. This is how we remove the osteophyte from the posterior surface. Step 2 is make sure PCL is resected before balancing. In CR, PCL is left intact. This is how PCL release is done. Cuts and balancing is done. That will in varus knee. Then another, if still a knee is in tight on medially, then if tightness remains medially, the semimembranous and posterior medial capsule can be released off the proximal tibia. This is how semimembranous is released. Step 4 is the posterior ligament. If gap is tight only medially in the extension during a varus valgus stress, then posterior oblique ligament can be released. Best done in figure of 4 position. That is how we do the release. Still there is tight knee on the medial side, then last step is the superficial MCL. Assess the flexion extension gap using lamina spreader. Tight component spacer. Then if tight, both release subsequently a superficial medial collateral ligament of proximal tibia but not completely of the distal tibia. This is how superficial medial release is done. These are the structure responsible for the tightness on the medial structure: superficial MCL, anterior tibia and the posterior fibers, deep MCL, posterior oblique ligament, semimembranous, pars incinus. Step 6 is the last one. You have to sometimes you have to go for a pars release also to be done if a severe tight medial knee is there. And step 7 is shift and the resect. Initial conservative tibial resection based on the lateral side, 10 mm ankle perpendicular to long axis, and measure the size of the tray, downsize it and lateralize it. This is how we shift and resect, with downsize and lateralize it. This is there, and then we can do that, and we can resect it, shift it here again, and then the medial bump of the bone, that is we call it a tibial osteotomy, that can be managed. And this is how we lateralizing the component. If after all this thing doing, if there is a residual laxity is there, IT bands are usually dynamically restored the stability in most cases. First option is increase medial release, medial cut and use thicker poly, or otherwise we may have to do sometime a LCL advancement. This is a case of varus knee. This is managed by a varus release in the post-op X-rays. Unfortunately, this patient got after 6 months of the injury, fell down and got a fracture, periprosthetic fracture. This was managed with a dual plating. This is 1 month post-op. This is a 4-month post-op. And this is almost 1 year. Fracture is united and patient is having a good range of motion. This is another case with a varus knee. It was managed with a TKR with a release, and in most of the cases, just by removal of the osteophytes, medial sleeve is resected. We are not require a semimembranous release or a pars incinus release in most of the cases. And this is 1 year follow-up. Patient is doing good function with that. Another case, this is a bilateral case with a lot of defects also there, which we able to manage with. This is the left side operated with the bone taken from the cuts only. This is right side operated. So in short, the algorithm for the varus knee is to create a medial subperiosteal sleeve with DMCL, remove the osteophytes, take the cut. Remember, ER maybe needs to be increased. Check the gaps, release semimembranous if required, superficial medial collateral ligament release if needed, shift and resect. That is the algorithm for varus knee. Thank you. And I
Thank you,
skipped
Dr.
the video
Pradeep,
part
for-
because of shortage of
yes,
time.
for
Thank you.
Maintaining the time, I thank you. If there are any questions, we can take one or two maybe. Okay, so now I'll be inviting Dr. Neeraj Atkar because he has a flight to catch. He has two talks back to back. One is on medial epicondylar osteotomy and one is on complex TKR using the active robot. Dr. Neeraj, please.
Good afternoon, everyone. There was some issue with the video, so I had to use my own. Yes. So most of the topics for varus TKR have been covered by Dr. Chaudhary in his talk. So medial epicondylar osteotomy is the last thing you need in your armamentarium. आप लैपटॉप उधर लगा दीजिए. Yes. I thank the organizers for having me here. Till that time we can have some questions regarding the demonstration and.
If you operate 100 varus knees, how many medial epicondylar osteotomies you really do? I'm talking about bad knees more than 15 to 30 degrees of varus.
It's less than 5%. It's very rare. So that algorithm, as sir has already explained, so you follow that protocol, and after that you decide. Still that MCL is tight, then last option is either you do pie crusting of the MCL or epicondylar osteotomy. I feel epicondylar osteotomy is slightly safer than pie crusting because pie crusting, okay, it will open out, okay. यहाँ से कर सकते हैं? This one? Yes, thank you. So, thanks the organizers for having me here. So, medial epicondylar osteotomy is one of the, hotly debated or discussed, not debated, I would say discussed topic while treating varus knee. So, in Indian scenario, patients, they present late and they are afraid of the surgery and they often present with such gross deformities. This may be because of ignorance, fear of surgery or financial constraints. So long-standing varus deformity results in fibrosis of the medial structures. At the same time, there may be cartilage and bone loss, and correction of these deformities is often challenging. But their expectations are sky high, and they want results like this, where they want complete knee flexion and they want to do all sorts of activities. So varus and FFD, when you are dealing these patients, so algorithm is, as discussed already, posteromedial release, osteophyte removal, extra distal femoral cut if there is FFD, medial capsular sleeve release, reduction osteotomy of the tibia, that is undersizing of the tibia if required, and pie crusting of the MCL is one option. But today we will be discussing this sliding medial epicondylar osteotomy. So this is, I feel, time-tested modality, and it really works well. So we start with osteophyte removal, and then posteromedial osteophyte removal from the femoral side is typically in varus knees, and then as per requirement to release the posteromedial soft tissue releases. So in spite of doing this, there is tightness on the medial side, so which can be released like this with the help of curved osteotome, and still the tight structure which is remaining even after taking out the osteophytes, releasing the soft tissues, is MCL. So for that you have two options, is pie crusting or osteotomy. So here in this case, in spite of doing or releasing all these structures, I was not able to insert this 10 millimeter insert, and it was difficult trial because of the contracted MCL. So what we do is we palpate the medial epicondyle. Just distal to the epicondyle, you make a soft window in the soft tissue and insert straight osteotome through that window. Just go in direction and come out. Don't detach the epicondyle from parent bone. Okay, just go in and come out. If you feel that epicondyle when you reduce, it literally moves distally or inferiorly by a millimeter or so, and it opens out medial gap consistently by a millimeter or two. That we have observed. So this is how we do it, and the straight osteotome, it goes in, as you can see in this video. This that's the epicondyle I'm showing, and with electrocautery you make a window in the soft tissue, and then osteotome goes in and comes out. So, and as I told you earlier, it just goes in and comes out in same direction. So don't detach the epicondyle from parent bone. You don't need to fix this osteotomy. I have done hundreds of these cases and it works, and there is fear, okay, whether it will just give way and whether you need to fix it. So that patient which I showed you earlier, 10 mm poly also was tight medially, but I ended with 12 mm poly and completely balanced knee, complete correction of the deformity. Some of the patients here, pre-op, and same patient mobilized very next day after the surgery, complete correction of the deformity. Patients pre-op and post-op where, okay. Can we just go to next slide, please? So complete correction is possible, and this has worked consistently. I feel the advantages of this technique over the pie crusting is pie crusting can give way. The punctured MCL can open out. Here something goes wrong, you can at least fix it with a screw, cannulated screw, and which is more secure. So couple of patients here, so pre and post-op. So this we have published in Maharashtra Journal of Orthopedics in 2012. So take home message is osteophyte removal from the tibia, posterior femur, underneath the MCL, especially the rat underneath the MCL, you need to watch out for. Osteophyte usually is hidden underneath the MCL. So take out all those osteophyte, soft tissue releases. In spite of that, if it is tight on the medial side, then only as a last resort, this is applicable. Thank you very much. So we'll start with the next talk and then go for the question answer. Next talk. Akhil, may I request you to the forward video in between, if the second talk, the Cuvis philosophy.
I have one question.
Yes, please, sir.
As you said that there is no need to fix this, what you have shown. Inadvertently sometimes when there is a tightness on the medial side, we try to force the poly and then we try to reduce. We feel some snapping sound and something similar.
Yes.
Something similar happens.
Yes.
And then we realize that okay, we may be little worried at that time. We check ourselves that okay, looks good, no need to fix. So my point is, in this technique, anytime you have felt that after putting the poly and doing the correction, you may thought that okay, now I need to put a screw. Has it happened like that?
Till now, no. Because don't detach and don't denude the epicondyle. Don't try to just feel it and window distal to it, and it works, sir. No, same protocol. range of movement allowed from very next day. See, knee brace while walking in some patients, but okay. Okay, so we just saw this robotic surgery. So robot is a Czech word from it is a and the meaning is forced labor. So original word was robota, and meaning is forced labor. So robots are in use in aviation industry, military, healthcare, finance, almost all industries. They are there where you need precision, productivity, and efficacy. And so first time it was used in healthcare in for neurosurgical biopsies in 1988, and 1991 it was used same robo for TURP, the prostate surgery. But and various other general surgery robo are in use, but in orthopedics it was used at Imperial College London. First time the robo name was Acrobat in 1980s, late 1980s, and then in early 1990s RoboDoc was developed by Think Surgical California, which is now subsequently taken over by Curexo, which are the manufacturers of QVIS. So TJA robotics can be classified broadly into imageless robots, which are Smith & Nephew, Navio Cori, and those which need some pre-op investigation like CT scan or X-ray, like QVIS, Mako, and Rosa. But QVIS is the only fully automated robotic system which is currently available for total knee replacement. And there are various papers published and lot of this is hotly debated topic whether to go for robotics or not to go. This paper published in 2013, and their conclusion was robotic surgery definitely improves the ability to achieve flexion and extension gap, but there are no differences in clinical scores or complications when compared to conventional manual technique. Another study published in 2011, and conclusion was you get better alignment accuracy of robotic TKA, and good clinical results achieved may favorably influence the clinical outcome. Another study published in 2018, and paper concludes there is reduced bone and periarticular soft tissue injury in patients undergoing RA-TKA compared to conventional TKA. So various literature, and especially the current literature, is in favor of robotic surgery, and robo is here to stay. So I'm going to skip, this paper published in 2021, and robotic assisted technology is worth recommendation in UK, that was their conclusion. But where are we heading? I mean, this chart is from US, and the installations are going up every year, and this paper concluded, and the study was in 2019, only 11% of total knee replacements were done using robotics. But by 2027, this number is likely to go up to 50%. And this is not just going to be restricted for replacement, arthroplasty, but in HTO, ligament surgeries, very soon robotic systems will be available which are going to play a crucial role. So QVIS, as I said, is a fully automated system which needs CT scan before surgery, where hip, knee, ankle CT scan is done, and preoperative planning is done, where all important bony landmarks are identified: center of the hip joint, center of the knee joint, medial epicondyle, lateral epicondyle, center of the ankle. So hip and knee, ankle, hip and ankle landmarks you don't need to identify during the procedure. That saves time. And once these important landmarks are identified, we get this at the time of planning. We get this chart where I know that the size of the implant is C, and the distal medial resection would be 8.9, medial 9.1, and the tibia resection would be around 5.6. So this chart is available at the end of the planning. And once this plan is approved, it is passed on to robo, and then there is unsterile and sterile registration process for each and every case. And once that is done, which takes around 15-20 minutes, which goes parallel with the anesthesia preparation, pre-op preparation, and So then robo is ready. I'm going to skip the surgical part here because we have already seen that. I'm not going to show the complete video, surgery video. So let's discuss these cases. So 75 years old gentleman, he had hypertension and IHD, bilateral knee pain since 8 years, operated for fractured tibia 14 years ago. And this is how he presented to us. Severe varus on both sides, and we had to take out the implant. And let's go through his planning. So on screen, on the medial side, in extension, this is in extension, gap was only 3 mm on the medial side, and lateral side it was 8 mm. Okay. So initial resection, can I have a pointer please, or it's there in this? So okay, thank you. So this is an extension. This is the pre-op planning what we had done on CT. This is distal resection on the medial side 9.2, lateral side 7.2, medial posterior resection 10.5 and 8.4. So with this planning, we are having this picture on table, 8 on the lateral side, 3 on the medial side. And once and in the flexion, so I'll just so as you can see, this intra-op adjustments were done with this. So we decided to increase the tibial resection as well as on the femoral rotation side. So this is a small video. So this is how you can adjust on table. So we decided to resect tibia 2 mm more. That will help us to increase extension as well as the flexion gap. Then we decided to increase the femoral rotation to compensate or to adjust the medial tightness in flexion. Okay, so we increase the external rotation by, and that's how you can see it on the screen. So this is 10-10. This is good, nicely balanced now in flexion with 3 degrees of external rotation. And then we check again in the extension. So we extend it completely. So now flexion is balanced, but in extension it is still tight medially. And as you can see here, the limb was in around 9 degrees of or 10 degrees of FFD and around 4 or 5 degrees of varus. So once that is done, so I decided to go for 1 or 2 degrees increase the femoral varus by 2 degrees, as you can see here. And that really helped me to balance my knee in extension. Once that is done, because there was FFD, I decided to increase my distal cut by 2 millimeters. So to get completely balanced knee. So this is how we do it in difficult cases. These adjustments are possible, which literally takes around 5 minutes. And as you can see here, the gaps are completely balanced in flexion as well as in extension. So these are the post-op X-rays. Another patient is a pre-op and post-op. We'll skip this. Another patient, pre-op X-ray and post-op X-ray. And interesting case, this is how he was walking pre-operatively, next day after surgery, and around 4 weeks post-surgery. So such, actually that's a question you get, whether you will be able to handle severe deformities with the help of robo. Yes, answer is yes. So we'll skip couple of these patients here. And so this patient again, it was tight on the medial side and 7 mm on the lateral side and 10 degrees of FFD, varus around 6 degrees. So, and in flexion it is again tight, 7 degrees lateral, 5 degrees medial. So we externally rotated the femur by 3 degrees and we increased the tibial resection by 2 mm. We could achieve 10-10 gap medial as well as the lateral side and as well as in the extension. So, friends, it's possible, and we'll just, at the end of surgery, you get a screenshot like this, where you know the gap and how much resection, everything, and which you can hand it over to the patient. So this is really a handy tool. So we'll just skip a couple of patients here. So we are getting consistently good results with this in severe deformities, varus, valgus, and so here robotics is here to stay. That's what I would like to conclude. And our experience is there is definite learning curve associated with this system as it applies to all other systems. Around 8 to 10 cases you will struggle a bit initially, but after that it is a smooth ride. And most of the cases, I'm happy to share, 9 or 11 poly we could finish in all difficult cases as well. Less drain, less pain, and less hospital stay. So don't think about the existence of robo henceforth. Thank you very much. Excellent question. I mean, so a pre-op, when you do a pre-op planning, so you should know how much flush that femur is to the anterior cortex. Even if you are not notched, then you can safely externally rotate the femur. It will not notch. And you should know, because on table sometimes you need to posteriorize the femur. But if it is too flush, it will not be possible. So we tend to keep it just flush to the anterior cortex, and that works. So even if so external rotate, you don't need to anteriorize the femur. That is not required.
In flexion, as you said, by rotating you manage the gaps. In extension, there is this medial tightness apart from varusizing the femur, which would otherwise varus the whole alignment. What else can you do?
See this kinematic alignment 3-4 degrees total varus is acceptable. So beyond that, if it is required, it is too tight, then soft tissue releases are required.
Sir, have you ever done
which is less likely?
Sir, have you ever done medial epicondyle osteotomy after using the robo?
After using the robo?
Yeah.
No.
So that portion is gone now probably.
Yes.
So it's again back to, it's not a soft tissue surgery, it's a bony surgery with the robo?
Yes, robo has changed the concept.
Yeah.
I mean, our seniors have taught us that total knee replacement is a soft tissue surgery. Probably robo is here to change that concept, and it has, so we adjust our bone cuts so that we need minimal soft tissue releases.
And what about, have you ever thought of going for a lateral advancement rather than going for a medial epicondyle osteotomy, particularly if there's a lot of lateral laxity despite of doing everything?
So lateral advancement is sometimes required so you should know whether it is lateral laxity or medial tightness.
Yeah.
Usually with medial epicondylar osteotomy routine, all these varus knees, it works well. But if there is too much of lateral laxity, then you can definitely consider that, where you osteotomize the lateral epicondyle and you advance it, and then you need to fix it with cannulated screw.
Thank you.
Do you ever sagittally rotate your femur to fix your flexion gap?
Yes, that is possible. See, on table, whatever, I mean, up to 3 degrees, 4 degrees, we can extend, I mean, beyond that also possible, but honestly, I have not tried that. But if you increase your flexion, it is going to impact your distal femoral cut as well. So if you balance your flexion gap by flexing the femoral component, make sure there are a couple of things you need to know, that your femoral placement to begin with, it was flush to the anterior cortex, not very proud, because it will affect your patellofemoral tracking. And then check for the extension gap again to confirm that it has not gone haywire.
Okay, so this is
one question, sir.
One last question.
Yeah, sir. Sure. So in while doing the manual without robo, would you recommend that rather than going for release, keep your tibial cut in varus for 2 degree or 3 degree? What we are doing with the robo, can we do it manually?
That's why robos are here. It is not possible to do it manually, and it is difficult to check it.
Okay, so whatever cuts you are taking, it is not possible. But I think seniors and all those who are high volume surgeons, I'm sure, I mean, so if it is too tight medially, then just pass saw blade couple of times on the medial side. So take out the bone slightly on the medial side. So it automatically puts your tibia in slight in varus and it opens out medial gap by a couple of millimeters.
One last question I would like to ask you. This MCL is known to behave in a non-isometric fashion. So when you do an epicondylar sliding osteotomy, it would remain a little mobile, I suppose, and that would affect its points of origin. So how would that take up?
See, once we balance the knee completely in extension and flexion with after the osteotomy, I have not faced any issues clinically. Honestly, theoretical, I don't have any answer for this question on theoretical grounds, but clinically all patients are doing well. And that's consistent observation, and all orthopedic, all arthroplasty surgeon should know this technique, and this is really helpful, cost effective. You don't need extra implant for that, and just couple take
bailout technique.
Bailout technique. That's the last option.
So we would like to thank Dr. Neeraj Adkar for this, and the next speaker, Dr. Arvind Raval, sir, we would invite on valgus knees.
In the meantime, I have to make one announcement that the lunch, there is not going to be any lunch break. So I think the lunch is served, and those who wants to have it can go out and come in. Because there will not be any official lunch break because we are already way too much delayed. Thank you.
By the time this talk is being loaded, Dr. Neeraj Adkar has a flight to catch. So let us thank him with a memento. Thanks for coming, Neeraj sir. I think Arvind sir will need a robot to get the talk loaded. Have you got a robot for this?
But most of my work has already been done by Amber. So, shall I get my laptop? Do you want to connect it? अरविंद रावल. चले मेरा लैपटॉप लाऊं क्या?
आपने कहाँ पे करवाया? एप्पल पे.
एप्पल पे ही है. डलाऊं क्या? अभी कनेक्ट करना है क्या उधर? So Hemant, how many of your knees, when you do total knee replacements, how many of them are valgus knees when you do?
So I would say about 5%.
Ankur? So that's what my experience as well. Around 10% are valgus knee or maybe less. Pointer किधर है? A pointer किधर है? Okay. So thanks for the patience waiting for the thing to upload. And I'll be talking about valgus knees, and as we were discussing, about 5 to 10% of our in our practice we get valgus knees. And so principles of management of valgus knees are very different from the varus knee. It's not a mirror image of what we do on the medial side. When we look at it, probably it looks like that, but it is completely a different beast. So first of all, planning, you have to do clinical examination, radiological examination, and then obviously examination under anesthesia, and then you can decide. But what you have to ask question is, how much is the deformity? Is the deformity correctable? Is MCL intact or dysfunctional? How much opening is there on valgus stress? And examination under anesthesia obviously may change what you see clinically. Radiological examination is also important, and particularly in valgus knees, it is very important to see a full leg views. If you can get that, that will give you much more information than just a standing AP lateral and skyline views, which are obviously necessary as well. In valgus knees, you should also do varus and valgus stress test to see how much correction is possible beforehand, and that will help you in your planning. So how severe is the deformity? Dr. Mullaji et al. Has suggested a classification for arthroplasty for valgus knees, but in my books, there are only two types of valgus knees, where the MCL is intact and where the MCL is incompetent. So that we'll talk about that, how we deal with these further. Surgical approaches, again, most of the surgeons, because they are familiar with medial parapatellar approach, they can very easily do it through the medial parapatellar approach, but I prefer to do them through lateral parapatellar approach if I have a moderate or severe valgus knees. The main advantage of that is most of these patients have medial collateral ligament is very lax, and if you do a medial parapatellar approach, just for exposure, you have to release a little bit of superficial femoral, superficial MCL, and you are already whipping a dead horse. So I prefer that, because during the approach only you can release the IT band from the Gerdy's tubercle. So that is the picture. If you see, most of the people will think that this is a left knee and with a significant medial varus, if I don't tell you. But this is a right knee, and this is the lateral compartment, this is the medial compartment, this is significant wear on the lateral side. I don't have the video, but just to explain the lateral parapatellar approach, it is not a difficult approach, it's very simple. Just like its counterpart on the medial side, I go just on the lateral edge of the quadriceps tendon, skirt around the patella and along the patellar tendon. And then you take out the whole sleeve of the IT band as we take the medial sleeve. So it's a very standard and safe approach, but one technical tip on this side is that you should save this pad of fat which we remove on the which I remove on when I do a varus knee. Because when you are closing severe valgus deformities after this, sometimes you are not able to close here, and then this fat of pad covers your implant, and it doesn't cause any problem later. But if you excise this, then that may cause, you can leave your implant exposed. So this is, again, when you have exposed it and you are doing through lateral parapatellar approach, it looks like something very unfamiliar. And in this, another technical tip is when you are doing a manual knee replacement and you are putting a tibial jig, you have to use a right jig for the left side and left jig for the right side, because you have to, the left one for this knee will fit in very nicely here. The other point is when we do extra medullary alignment, we are used to medial third of the patellar tendon where we align our rod in front of the tibia. And here we should not get fooled by what we are used to. And if we go to the lateral third, you will make a valgus cut. So your alignment should still stay on the medial third of the tibial tubercle. And this is what we get in most of the valgus knees, a trapezoidal gap, and this is what we want to achieve, as everybody has talked about. Flexion and extension gap should be equal. And how do I correct these deformity? And we can do it by either bony cuts or soft tissue releases. Bony cuts, as we have been told, and that is true as well, that usually the problem is in the femur rather than tibia. In varus knee, there is a lot of problem in the tibia. In valgus knee, it is the femur. And if you see the distal cut of the condyle, the medial condyle, there is significantly large cut, and on the lateral side, very thin sliver of the lateral distal cut has been done. So bone loss in valgus knees, as I said, it is a very different beast. Usually the bone loss is on the distal aspect as well as the posterior aspect. As you see here, there is significant wear on the posterior aspect as well. And that is very important to keep in mind, because posterior condylar line is highly unreliable in valgus knees. As you see in this picture, normal varus knee which we are doing, epicondylar axis is almost parallel to this posterior 3-degree external rotated. But in valgus knees, because there is a hypoplastic condyle, if you rely on this, you will significantly internal rotated your component, and therefore you will be committing a crime, as we heard this morning. So use as many landmarks as you can to get the rotation of the femoral component correct. And I use the white side line here and epicondylar axis, and the trick I do is on the lateral side, I put 1 or 2 osteotome depending on how much defect is there before I pin this jig in, and that will get your component in correct alignment. Soft tissue releases, there are a lot of things talked about. Amber has talked significantly about this, but there are only 4 things in my book which are mainly important, and they are IT band, your lateral collateral ligament, popliteus tendon, and posterolateral capsule. These are the 4 more important structures, and those which are attaching around the epicondyle, if you release them or do a pie crusting of them, it will increase the gap laterally in flexion as well as in extension, while if you release the IT band, your extension gap will increase, and if you release the posterolateral capsule, your flexion gap will increase. So you have to know that and how much you can release. Lateral parapatellar approach, IT band is significantly released, so I usually don't have any problem with that. So what if after releasing everything, whatever you have done, and you still end up with a trapezoidal gap, you are not happy with your balancing? Then what many people will do is that they will release a little bit more and try to stuff a thicker poly, and that will more or less make this thing tight, and you feel that you have balanced the knee. But this is a no-no, because this will lengthen the knee and this will put pressure on your common peroneal nerve, and this patient will never be happy. So if you are faced with this position that even after releasing everything is there, then you should have expected it pre-operative planning, and you should always keep a hinged knee or a constrained knee in such situation, and that is much better way to deal with it. And to leave the medial collateral ligament loose in this case then. Prevention of common peroneal stretching. These are the only cases after knee replacement when I keep the knee flexed on the pillow just to prevent the stretch of the common peroneal nerve. Valgus with medial soft tissue release, sleeve is intact. There is no, when it corrects completely, then you can use any approach. You can medial or lateral or any implant. You can even use a CR knee, which I usually do in most of my cases. But if it is valgus with medial soft tissue sleeve stretched, then I don't use, most of these cases are rheumatoid or inflammatory arthritis. So I don't use CR knee in these cases. I use a PS knee, and I always use a lateral parapatellar approach in these cases. If valgus with medial soft tissue sleeve is incompetent, then excessive opening on the medial side, then lateral parapatellar approach and hinged knee. This is what I use. So this is one of the examples. When I was told to give this talk, I couldn't make a video intraoperatively, but there is significant varus around 35 degrees in this patient when she is walking. There's no point playing the video. And these are the preoperative x-rays. Intraoperatively, you can see that there is good alignment, and this is the approach. I have the benefit of having Corey at my hospital, so you can see that after balancing, you can judge. That is the best thing about this, that there is significant, I'm just finishing, it's not, and full range of movement, full flexion, full extension, and valgus has been corrected. So in conclusion, understanding the pathoanatomy and recognizing the implications of various factors will help in getting satisfactory outcome. Thank you very much.
It was a wonderful talk. It was enlightening. And now may I, sorry sir, no time for question in this case. May I ask our next speaker, Sheetal Gupta. In the meantime, yes, Arvind, you can answer on my mic. Load the presentation.
Yes. Again, yes, but I have not faced this situation before, but obviously you would know that when you are seeing the patient clinically and other things, and in that case you can extend your lateral parapatellar approach or your VY-plasty, and you may have to do a quadriceps snip like thing, but I've never had to do that so far. I don't do routinely, but if it is very tight and there is no flexion at all, then quads mechanism will be tight. And intraoperatively, if that is there, then either you do a V5-plasty of the quadriceps or do a quadriceps snip. If most of these cases, the distal cut is just in air, or it is just skimming the lateral surface and posterior surface. So I don't, I abrade the surface with my saw gently, and then I put pinholes, drill holes in the lateral femoral condyle and fill it with the cement. If there is significant bone loss, then again you will have to preempt it preoperatively, and you have to have a revision system with, like I use Smith and Nephew revision system, and they have Legion system has option of using your wedges on lateral side.
How much safely you can increase your cut, distal femoral cut,
Distal
for cutting this lateral femoral condyle?
Distal what?
Distal cut, you can increase the size, 2 mm, 4 mm.
Plus
9 plus 2 mm.
Yeah, you can go up to the edge of the lateral and medial collateral ligament. So usually I'm 9 millimeters, but you can go up to 11, 12 mm. I don't think more than that is advisable. Otherwise, you'll need to think about osteotomies. Thank you.
One last question that we would like
Hello?
to answer.
Yeah.
So one last question, sir. You are at the junction between a robotic as well as a soft tissue. Your talk was on soft tissue. Now, when you're doing with a valgus knee using a robotic technique, how much would you distribute your soft tissue release vis-a-vis a bony cut?
I am still a soft tissue surgeon. I relieve, even when I'm doing robotic surgery, I remove all the osteophytes, as much as osteophytes I can remove before planning, because I use Cori and intraoperative planning is there. So I do the mapping or painting of the condyles after removing all the osteophytes. Obviously, posterior osteophytes I can't remove, and that's why my question before was that you have to guess it.
Thank you. Dr. Sheetal Gupta, you're next.
Thank you. Greetings from Bhopal, and thanks to organizing committee for inviting me on this talk for the correction of the fixed flexion deformity. So, till now what I was thinking, TKR should be thought as a soft tissue operation, so probably maybe down the line 3-4 years, but we will be talking something else, and probably the teaching of John Insall may change over a period of time. So whenever I get a patient of flexion deformity, the three things come in my mind. What is the cause of the deformity? What if it's left untreated? And how to treat such flexion deformity? So some contracture after TKR may eventually resolve, but if there is a lack of extension is greater than 15 degree, 3 months postoperatively it's likely to persist. So this is one of the brilliant paper in Journal of Arthroplasty in 2011. So the first point that comes in my mind is what is the cause? The cause is basically a multifactorial, which is a bony impingement, posterior capsular contracture, hamstring shortening, and a ligamental contracture. Or it may be secondary to the pain and limited motion, prolonged immobility, contracture of the opposite knee and the hip, and neurological disorders. What will happen if you don't treat the flexion deformity? Patient experience tiring in standing, walking, and stair climbing, and the contralateral knee is going to experience increase in the extension and adduction, and there would be great wear of the cartilage in the contralateral knee. How to treat? You have to do a pre-op recognition, you have to go for intra-op correction and intra-op prevention and the post-operative correction. So pre-op recognition is quite easy. Look for a limb line discrepancy, for angular deformity, and plan for a good intraoperative correction. So intraoperative correction, the flexion deformity, the one option is increase in the size of the extension gap. So the choice of the implant in such cases would be a release of posterior cruciate, and a PS would be a better preferred option in such cases. And how to increase the size of extension gap? It can be done by removal of posterior osteophyte, by doing a distal femoral resection, and the third thing would be a posterior soft tissue release. So that is, you have to work on the femoral side whenever you got a patient of flexion deformity, not to work on the tibial side. So the first point is removal of posterior osteophyte. You can use, has to be done after you have done your bony cuts. You can use the lamina spreader on the cut surface of tibia and the posterior femoral condyle. You can use a curved osteotome and the curette to facilitate this process. So this would be the first step to deal with the posterior osteophyte for the correction of the flexion deformity. So the distal femoral section of flexure contracture, if more than is of greater magnitude, you require a distal additional cuts. So for each 10 degree of flexural contracture, take an additional of 2 millimeter, but this answers the question of Dr. Pramod Nima. The upper limit is 6 millimeter, so you cannot cut distal femur more than 6 millimeter. That is what has been given in the literature. So what will happen if you are going to do over resection more than 6 millimeter on the distal side? The collateral ligament can get damaged. There would be elevation of joint line, which would further lead to mid-flexion instability and extension mechanism weakness, and there would be uncoverage of posterior condyle and leading to poor fixation. So the posterior soft tissue release comes the third step, which can be released on the proximal femur or the tibial attachment as well. It is easier to perform the release of the tibia with knee in the hyperflexion. So capsule release is from the posterior tibial surface using the electrocautery for a distance of approximately 1 centimeter. And this will lead to balancing in the extension, and you can proceed further. Intraoperative prevention, if there is an error in the component positioning, so if your femoral component is in the flexion, then there would be a chances that you will have a flexion deformity, or if there is an excessive tibial slope. So excessive tibial slope is going to increase your flexion gap, and you are going to put, what happened? Hello. So that's going to increase your flexion gap, and ultimately you're going to put a bigger pulley to match it, so that will lead to flexion deformity. So I think it's not coming over here now. So failure to properly balance flexion extension gap, equal flexion extension gap is going to prevent the further flexion contracture. So there are two common mistakes. Intraoperatively increase the size of pulley to stabilize the knee flexion, which should not be done, and cut more tibia to resolve the flexion contracture. So this two things you can do intraoperatively to prevent postoperative residual flexion deformity. So you have to simply follow the algorithm. If you got a permanent fixed flexor contracture left in the OT, it will lead to chronic anterior knee pain. Gradual stretching of contracture is going to lead in increase in both flexion and extension gap and further lead flexion instability. So post-operative correction you can manage it non-operatively. If you got a patient with a residual deformity even after surgery, physiotherapy, gait training, shoe lift, and the dynamic stretching. Manipulation under anesthesia is one of the options. And you may have to go for a femoral revision, increasing extension gap by elevating the joint line, and you have to use a thicker pulley. So a simple algorithm, if patient has got a flexion deformity of 10 to 30 degree, what you need to do is a sequential 2 millimeter of distal additional femoral bone resection. The PCL release, posterior capsule release, and osteophyte removal should be preceded before doing the additional femoral cut. Avoidance of implantation of the femoral component in the flexion. And you have to decrease of the tibial cut posterior slope is helpful for avoiding residual flexural contraction. But if patient has got a more than 30 degree flexion deformity, then the collateral ligament lengthening via pie crusting should be done. And if it's a rheumatoid knee, you can follow the principle of 1/3. Basically 1/3 you can do correction pre-op, 1/3 correction can be done intra-op, and 1/3 you can, at least in rheumatoid knee, if it's not correctable, you can left, and which can be corrected by rehabilitation. So thinking is the hardest work, which is the reason very few people engage in it. So think again and again and avoid problem at the primary surgery. Avoid the flexion extension mismatch and use intraoperative aids like blocks and navigation. Thank you.
Thank you, Sheetal, for finishing well in time. So your questions are welcome. If anybody has, in the meantime, I will ask Akhil to be here and with your presentation ready, and then the next session will start. So
there's a question for this flexion contracture, basically aimed at CR surgeons. They generally try to preserve the PCL as much as they possibly can. So what is your threshold to release the PCL? I think we have to.
I think the Raval sir would be the right person to answer. I mean, if patient is having a 15 degree flexion deformity, still you will go for a CR knee, or, I mean. Do the correction. Okay.
I can also answer this.
Sir, but one simple question, because in the CR knee you are going to increase your tibial slope, but in PS you don't increase the tibial slope. So if you have planned CR in the mind, you already increased your tibial slope because of CR. Now you cannot correct it once you plan for the PS. So how do you manage that?
So the principles of knee replacement will remain the same, whether you are doing a PS or a CR. So you have to have a balanced knee both in flexion and extension. So if you are a CR surgeon, you will take care that if it is tight in flexion, then you can always pie crust or use cautery to slightly release the PCL. But still retaining the PCL, I have never regretted retaining the PCL, and even in FFD is more than 25 to 30 degrees maybe even. Because the release is first, then you are getting the trial. Before the release, you are not going to do the trial also. Right? So the first thing that you have is an extension block. So you balance this in extension first. The moment you do it then you know that if it is slightly tight in flexion, you can always pie crust or slightly release the PCL.
So one last thing. There is also a described method where you probably, you recede the gastroc heads in those soft tissues. Probably basically, almost skeletonize the femur for severe degrees of effusion.
Posterior, yeah.
So how many of us do it, and how many of the times is it required?
I never done it, but the only thing I put the mop and just keep on pushing it till the time I feel that the enough release has been done. If you lift it, you will be able to see the posterior aspect of femur very well. So I think that is probably my endpoint.
One thing I would like to add for the CR surgeons, they will agree that we at times don't see the osteophyte present behind the PCL. So when it is tight, just see that there is some osteophyte behind or a loose body behind the PCL. It comes nicely and everything then stands in place.
Thank you.
Thank you.
One question.
Thank you. Akhil. Yes, Abhi.
One question from Sheetal. F15 rheumatoid, how much release? F15 rheumatoid patient, sometimes we think we should left the knee little tight. Rheumatoid patients.
Rheumatoid, ideally in every case you should achieve a 0 degree of extension, rather I would say a 4 to 5 degree of hyperextension, because that is a natural knee. Rheumatoid, that I have told, it's a principle of 1/3, 1/3, 1/3. So if your patient is coming with a 30 degree flexion deformity, try to correct at least 10 degree by rehab pre-operatively. Intraoperative, try to correct at least 10 degree or 12 degree. Even in rheumatoid, if you left with around say around 5 degree or 10 degree of flexion deformity, so 1/3, 1/3 rule is basically given in the literature, so that much can be left very well.
Thank you, Dr. Sheetal. Dr. Akhil,
Yes.
you're next.
Good afternoon, one and all. I'll be sharing my little experience with a fully automatic robot I have, QS. So in MediSquare, experience meets technology, I can say. So conventional total knee arthroplasty is successful, it's durable, it's reproducible, and we are delivering good results. But then it's not perfect for everyone. Why? We have almost 20% of unsatisfied patients. The reason is we are doing non-anatomical total knee arthroplasty. So this time human intelligence meets robotic precision. I'll briefly go through the computer-assisted surgery. So we have navigation, we have semi-active and active robots. Both saw-based and burr-based systems are available. And we have image-free systems, which is a CT scan-based system. So in CT scan-based system, what we do is, we do the preoperative planning on the CT scan. The software is very versatile. We can place your component in flexion, extension, we can upshift, downshift, whatever you want to do, you can do with the CT scan. So I am mainly a kinematic alignment, or I should say functional alignment surgeon. I don't believe in soft tissue releasing, and I don't release soft tissue at all. So I believe in functional alignment, in which your implant position should be perfect. Your femur position should be perfect. And I don't release, so I keep the TBI in 1 to 2 degree of varus or valgus as per the case. So kinematic alignment is a customized method. We restore the native pre-arthritic joint lines. And malpositioning of a knee replacement, it can cause pain, stiffness, or instability. So in this X-ray, you can see a kinematically aligned tibial cut and a mechanically aligned tibial cut. So kinematically aligned tibial cut mimics the native joint line. Again, you can see there is a varus alignment of tibial component, which is anatomic. So you need to restore the anatomy. So these are some basic steps which we usually follow to balance the knee. I believe in recut in tibia, 2 degree varus or valgus. I have an example to show. Now in this case, as you can see, intraoperative the pic, there is only 2 mm opening on the medial side. Now I had 2 options, either to go for extensive release on the medial side, but I preferred keeping tibia in 3 degree of varus. I don't touch femur much. So now see, my gap is balanced, 13 degree and 13 degree. A reference to my case, functional alignment philosophy. Naturally, it helps in manipulating the implant positioning while limiting soft tissue releases. In my hospital, I call it a #MediRobot technique. It's personalized, as it's based on CT scan. It's precise because we give accurate bone cuts, and it's painless because we don't do any releases at all. It's a basic algorithm. So same preoperative CT scan. On the software we do all kind of planning. To just remember this, on CT scan you plan only the bone cuts. Your real-time gap check will be done intraoperatively if you need to do some subtle changes. So here on the software you can manage the cuts. I'll just briefly go through some. So in this preoperative planning, as you can see, I have decided to go with size B femur. Now the implant thickness, the posterior implant thickness size is 7.7 mm. So I kept equally the same cuts. My distal cut 7.7 mm, my posterolateral cut 7.7 mm. So I'm not worried about the flexion or extension gaps. Now I need to play with the medial lateral gaps. So again I decided to go with size E femur in this case, again 8.8 mm. So I keep the values same, I play with the numbers. So this is the perfect example of how the gap planning should be done. Equal 10 mm gaps in flexion and extension. This should be your goal. Few x-rays. O&E left side, and see the video. The patient is walking with the walker same day post-op and walking after 15 days post-surgery. Again, see how well the implant is fitting. Again, same day walking with walker after 15 days post-surgery. Another x-ray, how beautifully the posterior condylar, your implant is mimicking the native bone. So this patient, she is very happy. Preoperative gait, postoperative gait, immediate post-op, and then she is walking 1 month post-surgery. Few cases. Again. Same with this patient, preoperative gait, immediate post-op, and then 1 month post-surgery. Again, severe varus knee, same robotic total knee arthroplasty. The patient is walking comfortably post 1 month of surgery. So till now I have done more than 100 cases. I bought this robo in the month of March, mid of March. So I'm very happy with the consistent results I am getting, and patients are they are very comfortable. So few of references. So there are many studies which say the kinematic alignment is way superior than mechanical alignment, and then you can keep limb in 5 degree of varus. It's the limit. You should not go beyond that. And then you can keep TBI in 3 degree in varus or valgus as per the case needed. So I conclude by saying robotic TKR is accurate, it's precise, it's tailored fit. Thank you so much.
Thank you, Akhil. Let me acknowledge him for finishing well in time. It always feels good. We are already, running late. So, Dr. Nima, sir, you want to ask him a question?
One question.
Yes,
We have got a sensor tensioner in while we navigate. So, with this sensor tensioner, we can cuts are managed and soft tissue is not released with that also. So can we do the same technique with the navigation using the tensioner? Is it possible or not?
So it's possible, but the one thing is for sure, you cannot keep the component in flexion, extension, upshift, downshift, because problems are there when you have in between sizes. Now if I have to choose between C or D, so I'll see I can use D implant, and I can keep it in 1.5 to 2 degree of extension. I can use again a smaller implant within flexion. So this proper implant positioning is not possible without a robo.
Yeah, it gives very accurate cuts. While with the navigation, you have to release some soft tissue. Yeah.
Thank you.
Thank you. Ankur, may I request you to please hand over a memento to Dr. Akhil. And then I'll request Dr. Sheetal Gupta, is he here? And Dr. Pradeep Chaudhary to please come on the stage and receive the memento for the excellent presentations on behalf of AOSI and Arthroscopy Association. Pradeep, Hemant will do the honors. Dr. Arvind. Okay.
So I request Dr. Alok Jain sir to facilitate Dr. Arvind Parekh.
Hello. I would like
So
to ask
session
I would like to ask Dr. Mohanty sir to facilitate our chairpersons. So I would like to invite Dr. Vinod Arora sir and Dr. Arvind Rawal to chair the next session, please.
May I invite Dr. Mohanty for his talk on bilateral TKR, whether it is safe.
Can I have the presentation, please? So it's a lunch break. Everybody is having their lunch.
Amber, is it possible for us to wait for some time?
Yeah,
No
I think so, because at least
we can
15
have
minutes.
a small break,
Yeah,
and then we
no
can
problem.
start.
It will be better rather than talking to tables and chairs.
to SOS Infraworks. To SOS Infraworks. to SOS Infraworlds.
Been? Okay. How it will change? हाँ, नहीं हो रहा है. डेस्कटॉप में भी नहीं हो रहा है. Okay, now I'll do it from here. Okay. Okay. Thank you, Mr. Chairman, and dear friends. It's a pleasure and honor to talk here on the Association of Orthopedic Surgeons of Indore, and I thank Dr. Nima, my friend Dr. Alok Jain, Dr. Ambar Mittal, Dr. Tantue for inviting me here. Now, I'll focus on a topic which is, very interesting, and many people are worried about doing a bilateral total knee replacement, and I will show how I go about it. Now, why we are talking about bilateral total knee replacement? Because 40% of the patients with osteoarthritis have severe symptoms from the other knee at the time of doing primary TKA. So most of the times both the knees are involved, and hence you need to get rid of the pain from both the knees. Now if you see the literature, it all starts with S. Bilateral simultaneous total knee replacement, where under single anesthetic surgeons, 2 surgical teams operate on both the knees together at the same time. Then bilateral sequential total knee replacement, that is under single anesthetic surgeon, single surgical team operating one knee after the other, following one knee, then the other knee. Staggered total knee replacement, single hospitalization, separate procedures under separate anesthetic session, about 4 to 7 days apart in the same hospitalization. And finally, staged total knee replacement, where this is like 2 unilateral total knee replacement under separate hospitalizations. And what is the interval that has not been clearly defined in the literature. So what most of the surgeons, we do bilateral sequential or staged procedure. And hence, from now onwards, I will talk about bilateral sequential total knee replacement, which usually we practice. Now the reported advantage, which has been described as that there is 1 hospital stay, 1 rehabilitation period, there is less cost involved, and early return to normal activities. And most of the time, patients with contralateral fixed flexion deformity and contralateral severe varus deformities, which you saw in the earlier part of the lecture today, that in those kind of cases, after doing one knee, patient lands up in considerable limb length discrepancy, and rehabilitation becomes difficult and walking becomes difficult. For example, this kind of patient, as you can see here, with bilateral severe flexion deformity of the knee. If you correct one side, then it will be difficulty for the patient for walking and rehabilitation, and hence you have to do both the knees together, so that at least just 3 months post-op, that she is very comfortable in the walking after doing both the knee replacement surgery. But there is a big exclusion criteria. One should not operate in these conditions, and especially patient more than 75 years. And cardiac issues, like is there ischemic heart disease with a positive stress test, ASA grade 3, grade 4, and ejection fraction less than 50%, pulmonary arterial hypertension, chronic obstructive sleep apnea, and there are different scores has been described. The score is more than 5, this top score, bang score, then one should not operate, and congestive heart failure. So all these cases, they are contraindications, or rather one should avoid doing bilateral total knee replacements. So there is an algorithm that how to select your patients for doing bilateral knee replacements. Suppose patient has got a good functional capacity with no history of cardiac disease and no diabetes or hypertension, then straight away you can select that patient for bilateral sequential total knee replacement. But if the patient has got diabetes and hypertension, then just control that thing first, then do the surgery. Suppose this patient has got cardiac diseases like history of ISD, history of heart failure, arrhythmia, or combined diabetes and hypertension, abnormal findings in the ECG or in the 2D echo, then one should order for a thallium scan of course with the help of a physician and an anesthesiologist. And the thallium scan, if it shows thallium scan that is a high risk, then postpone the surgery or don't do bilateral surgery. But if the thallium scan shows that there is a low or moderate risk, then control the disease, then you can go ahead with the surgery. So if you have followed this protocol, then you are less likely to get affected by medical legal issues in future or after the surgery if any complication happens. This is our series till 2016. We have evaluated our result. 540 bilateral total knee arthroplastics which was done, which are sequentially under single anesthesia it was done. Preoperative antibiotic, we give cephalosporin plus aminoglycoside, and if the creatinine is high, we give a ciprofloxacin instead of aminoglycoside. Preoperative single shot hydrocortisone or dexamethasone is given. This is to prevent the embolism. Tranexamic acid, we give 500 milligram bolus plus 500 milligram slow IV. Then tourniquet average time is about 50 to 55 minutes. So if your surgical time is increasing beyond 1 hour 15 minutes or 1.5 hours, then please abandon the second knee procedure, because that increases the morbidity during the post-operative period. We use intramedullary femoral and extramedullary tibial jigs, and normally I do GMR next gen or PFC, RP, and all posterior stabilizing knees. Post-operatively, I keep the patient for a day if it is required, or else patient goes to the ward. Pain control by epidural pump, transdermal patch, and periauricular injection. Of course, last couple of years I'm doing bilateral adductor canal blocks. We give thromboprophylaxis in every patient, like low molecular weight heparin for 5 days, followed by oral aspirin for 4 weeks. And we use on all patient TED stockings. They are mechanical methods of preventing thromboembolism, like TED stockings and calf pumps. Tranexamic given 8 hourly for 24 hours, and patient is mobilized on the first post-op-day, full weight bearing assisted by the physiotherapy, and discharged on the 6th post-operative day. 56 years old male, bilateral severe varus knees. Those are the post-operative X-rays, and this is function 8 years down the lane, and bilateral total knee replacement. This kind of severe varus knee with gross instability, it will be difficult to do one at a time, because the post-operative rehabilitation becomes very difficult. This is one of the patients from Madhya Pradesh itself, a severe hemophilia. I do a lot of hemophilia patients, grossly unstable knee. As you can see here, that mediolaterally and anteroposteriorly unstable. The lower end of the femur is almost destroyed. It's like a claw-like femur, where we did a bilateral, single stage total knee replacement with, of course, in a separate stage we did a hip replacement, and that is 7 years 3 months following the surgery. That is improves the function of the patient and restores the biomechanics of the knee. Before ending this lecture, so I'll just show a video that how I do bilateral sequential total knee replacement. So this is the X-ray of a patient, AP view and lateral view, left side and right side, severe varus deformity, as you can see here, with the osteophytes and bone-on-bone appearance. These are the lateral views. Patient is 63 years, diabetic and hypertensive. So most important thing that we give combined spinal epidural in bilateral cases, preoperative antibiotic, tranexamic acid and single dose steroid given. That is the positioning of the patient before the surgery. And we do a single draping. We do not wash out after doing the first knee. So the preparation of the patient, the slings are sterile roller bandages used as a sling. Then prepare the patient with no touch technique. Then do the foundation drape, that we put all these plastic impermeable drapes at the foundation drape. Then put double bed sheet there after the foundation drape. This is the primary draping after the foundation drape. Then put the bed sheets, 3 bed sheets, in between 2 legs, 1 bed sheet. Then isolate both the legs. So after isolating both the legs, then you take one leg and then put your stockinets over the legs, and then we put the bilateral O drapes, and that is the positioning after that is the secondary drape. This bilateral O drape as a secondary drape. One knee is covered with some kind of sterile cover, so that it will not becomes dirty while doing the first knee. So we are doing the right knee first here. So that is the positioning. So it doesn't require you give a lateral support, so knee remains in position. In all the patients, I use a SMARC bandage and use a tourniquet. So we raise the tourniquet, usually twice the systolic blood pressure. This is anterior midline incision. medial parapatellar approach. Then first cut is tibia, always using extramedullary jig unless I am unable to dislocate the knee. If it is very stiff knee, then I do the femur first. While preparing the femur, remember that while entering the medullary canal, give a thorough pulsatile lavage, almost 300 ml of NS or 300 to 500 ml of NS. I give a thorough intramedullary pulsatile lavage that will take out all the fat debris. Check for the extension gap. Next, you take the sizure. The femoral component rotation is decided by the interepicondylar axis. And next, they take the AP cuts and the chamfer cuts on the femoral side. I do mechanical jig. This is the femur cuts and this is the notch cut of the femur. And next, you prepare the tibia. And after preparing the tibia, then you do a trial reduction. And here I am doing a pie crusting on the medial collateral ligament because of tightness on the medial side. Then prepare the patella. In all the cases, I replace the patella. And that is trial prosthesis in place, and look for the stability, look for the alignment, and look for the patellar tracking during the trial prosthesis. Next, we do the cementing. If there is a hard bone, do multiple drill holes there, cement anchoring holes. If there is a more defect, you can do a screw and the cement built up. So lateral facet of the patella, usually medial condyle of the tibia, there is a hard bone. Then decortication of the hard bone we do with the saw so that cement intrusion is little better. Plug the femoral canal adequately so that less of postoperative bleeding. So tight intramedullary plug. Next, use a pulsatile lavage in each and every case and before cementing. So take out all the fat, debris, blood clots, everything. And next, I give a periarticular injection. So this is deeper structures like posterolateral corner, posterior aspect of the knee, posteromedial corner with a cocktail injection. Next, we do the cementing, and of course after cementing we do the superficial structure again injection. So start with the patella, then the tibia, then the femur. So this is cement intrusion. Pressurize the cement along with pressurizer or patella clamp. Then cementing of the tibia. Then I always use Palaka cement. That is the best cement all over the world, giving good reproducible outcome. Then pressurize your tibia there and give couple of hammers to the tibia. Then cementing the femoral component, and finally we put the polyethylene in. And after putting the polyethylene in, next we give a injection again to the superficial structures like quadriceps tendon, subcutaneous bone, and this is final polyethylene insertion. And next you give then we release the tunicate at that time. So here you see that it is just 58 minutes is the tunicate time there. After releasing the tunicate, look towards the saturation as well as blood pressure. And we give a one dose of sort of antibiotic after releasing the tunicate and do the closure in the flexion. If the saturation drops down below 95 or the systolic blood pressure falls minimum 30 millimeter of mercury, then we avoid doing the second knee. Then superficial infiltration periarticular injections there. And next the subcutaneous closure. Then intra-articular instillation of tranexamic acid about 500 milligram is given, and give couple of flexion and extension so that tranexamic acid spreads over the joint. So then you prepare the second knee and do the second knee like the first knee, and while doing the second knee, your assistant closes the first knee. So we raise the tunicate again 250, 1.5 hours timing which you had given. So give the incision and do everything like the first knee. So while you are doing the second knee, your assistant closes the first knee there. And finally, so you insert the polyethylene there after doing the second knee, and then you do the finally closure there. So second knee polyethylene insertion there. And again periarticular injection there, and the closure out there. So check the monitor again after the second tunicate release. As you can see, saturation is 98 and blood pressure is maintained, and that is the first closure, and then we put the dressings. So this is how a bilateral sequential and post-operative pain control, keep the epidural pump there and adductor canal block. These are the post-operative X-ray. This is a Zimmer Persona knee, right knee epi, right knee lateral, and next the left knee epi view and left knee lateral view. So to conclude, bilateral sequential total knee arthroplasty requires maximum 2 to 2.5 hours of surgery. You require a motivated surgical and hospital staff and assistants. You need the close monitoring of the patient after releasing the tourniquet after the first knee, then after the second knee. And you should do it in younger patient with minimal surgical risk and of course optimal patient motivation which is required for a good rehabilitation. Before I close my lecture, I request all of you to support my candidature for the post of Vice President of Indian Orthopedic Association elections this year, which will be held in September, October, online elections. And if you have not updated your mobile numbers, kindly update your mobile number in ioaindia.org by going to the site. My aim is to build up a guidelines for each and every surgery, starting from the whatever fracture, this bilateral total knee replacement, infection protocols, everything, guidelines to be raised by IOA, Indian Orthopedic Association, which needs to be approved by the government so that we face less of problems while doing this surgery and face less of medical legal problems. I thank you for a patient hearing.
Any questions pertaining to this particular topic on bilateral TKR?
Whatever, I have told you about the algorithm and all these things are there in the literature. But problem is that the legal issues are there. For example, just 2 days back, I received a phone call in Mumbai itself that one of the patients had problems and he has filed a suit and they are asking for legal opinion. One of our orthopedic colleagues called me that I have suggested your name to, give expert opinion. So if you have followed the protocols and show the literature, at least you are safe, that you have followed your safe surgical practice. Beyond that, if problem happens, of course, you have explained the patient, taken the consent, that of course, while taking consent, you have to write down all the percentage of each complication. Infection, thromboembolism, DVT, your, even death you have to write down in the consent and what is the percentage of death, like that. So if you have mentioned all these things, you have followed the protocols and explained the patient, then there should not be a problem. What consumer court they want whether the doctor has followed the safe surgical practice or not. That he is not negligent. Beyond that, if complications do happen, then doctor is saved.
Can I ask a question?
Yes, sir.
Excuse our ignorance, sir. What is thallium scan you are talking about? What does it show?
It shows your, your cardiac activity. It is a thallium scan, thallium stress test, and some people do dobutamine stress echo also. So if the heart functions well, that is not high risk for the heart, that cardiologists they decide, then you can go ahead. And this particular case which I am telling day before yesterday, that surgeon has done a thallium scan. Clearance was given by the cardiologist. That's what they were telling. So whenever you have done the investigation and followed up the things, everything is on the paper, then you should not be.
30% of our patients probably are having hypertension and diabetes together. Most of the patients.
Yeah, that is well controlled. Then it's fine. No, your HbA1c should be below 8 at least. One should not operate, 9, 10, 11, 12. It should not.
They have diabetes and blood pressure together, which is under control, but still you would advise thallium scan for everybody.
Then it's a call up for the cardiologist. Okay. The diabetes blood pressure is only there, and there is no history of any ischemic heart disease. There is no history of any effort intolerance or all these things. Then the cardiologist has to advise. It is not the orthopedic surgeon who advises thallium scan. But routinely I do echo and ECG. If there is any abnormality in the echo and ECG, then of course we advise further investigations.
Thank you.
I entirely agree with you, 100%. I follow the same protocol. So that staggered TKR, which is 4 to 7 days apart, it should not be done. So any patient who have a complication after doing a staggered TKR, then you are not saved. So that is why my principle is minimum 3 weeks if you are not doing a bilateral sequential total knee replacement. Yes, sir.
No, stress cardiac is for myocardial perfusion. It shows you the blood supply to the myocardial muscles, and that's how it shows you the functionality of the myocardium after you have a ischemic heart disease. It's a very safe method, and you know, sometimes it divides between CABG and stenting. So that's one. My question to Dr. Mohanty is that why you have a cutoff for bilateral total knee replacement 75 years or 70 years?
Sir, you know, 75 years because old age per se is a risk for anesthesia and for post-operative complications. You know, surgery will go on well. There is no doubt about it. But these patients, the problem after the surgery. First post-operative, the urinary output is okay, everything is okay. Second post-operative day, okay. You see third and fourth post-operative days, suddenly patient is little confused, little talking irrelevantly. So all the problems start post-operatively. So better in a old age group patient beyond 75 years that we should avoid the risk of doing a bilateral sequencer, because surgery per se is a stress to the body and old age
exactly,
because of compromised
that is the reason,
status.
The tolerability of the patient
Yeah.
of surgical trauma.
Right.
That is one factor.
Yeah.
And probably because you know the surgical trauma for that age group is rather extensive.
Correct.
So I think 75 or this thing, but is it that the physical age will mean much rather than the functional age?
Means together, if the patient doesn't have any other medical issues, then probably 75 cutoff age is important. But the physiological age means suppose a patient with 60 years with having ischemic heart disease and multiple medical problems, diabetes, hypertension, ischemic heart disease, then all these things compound, so their physiological age is again it becoming more. So those patients needs to be
Yes,
avoided.
that evaluation is important. Thank you.
Yeah, so always then you can tell that, yeah, before 75 we can do stage procedure.
Thank you so much, sir. I think we can
Sir.
switch to now live surgery from Medista. I think, please. Thank you so much, sir.
Okay,
so much
thank
for
you very
your
much.
enlightening talk.
Thank you, sir.
Please. Anyone who is going to moderate? In the meantime, probably there is some issue over there. It will take little time. I invite Dr. Ankur Maheshwari. Huh? Ankur Maheshwari. He is going to talk on mid-flexion instability. Ankur.
Should I wait, sir?
I think you do it first. Hello? Can you hear me? Medista OT.
Yeah, this is Medista OT. How are you? Hello.
Dr. Parekh?
Yes, I can hear you. Can you hear me?
Yeah, definitely.
Oh, great.
Okay, so I think we can start conversation. That'll be better.
Sure, great. So this is the patient who has a varus deformity, which is correctable, which goes also in recurvatum, and there is some laxity anteroposteriorly, so there is a ACL deficiency. So we are starting with the medial parapatellar approach. So I'm just feeling the patella. Unfortunately, we don't have pen, so we are taking incision, which is going to be a little medial to the tibial tubercle. Please. And I'm trying to identify the vastus medialis. This is the vastus medialis. Can you see that? This is the rectus. So my incision will be on just lateral to the vastus medialis on rectus.
Picture is too bright. We are not able to see anything.
Okay.
Light intensity over there. This is better now.
Great. So what I have done is I have identified the vastus medialis. So vastus medialis have gone little lateral to in the rectus. This is the patella, so I am going medial to the patella. This is the tibial tubercle. I have gone little medial to the tibial tubercle. Typical lot of fluid inside the synovium. As expected, looks like a remoted patient. I'm taking out the fat pad so that I get better exposure. Can you increase the cautery, please? Since it is a legs joint, we are not going to release much on medially.
This is without tourniquet?
Yeah, this is with tourniquet, but there is a lot of synovitis. This is a synovial fluid. This is not a bleeding.
Do you use tourniquet always, or you prefer to use tourniquet?
Yes, I always prefer to use tourniquet. It is a much better clear view. So this is basic medial release I have done. I am not going all the way to the back since it is a legs joint going little recurvatum. Can I have a spike, please? Spike up de dijiye. We'll put one spike on a lateral gutter, another in the medial gutter. If you see there is a lot of synovitis, so what I'll do is I'll try to do the maximum synovectomy. Will not try to leave any synovium behind. If it is osteoarthritis, we may leave, and that is okay. But when there is an inflammatory arthritis, we have to do a proper synovectomy. I'm doing synovectomy right now, nothing else. Nibbler, please. Nibbler BG. If I want to do a proper synovectomy, I'm just trying to take it out. So when you use nibbler like this, it is going to take out the only bad tissue. If I'm by any chance biting the muscle or something, it will not come out. So of course, you have to be a little gentle. Okay, so I've done synovectomy. I think that looks okay to me. This is a prepatellar fat pad. Some of the surgeons keep that. I usually take out, and that to be with this inflamed joint we want to take out. Pull. खींचे. Nibbler. Okay, fine. So I'll invert the patella. So this is the inflamed synovium. This is a prepatellar fat pad. I don't replace patella. So what I do is I'll just try to denerve the patella and give the shape of the patella like an artificial button. So this is what I'm doing, is a denervation of patella. Okay. So it looks good. Can I saw Diji? So this patella will give the shape like a button. Grasp. Looks good. Lateral spike, right angle वाला जो spike था ना. Little tight on medially. Fine. मत touch. We'll put this lateral spike on the lateral gutter so that it retracts the lateral structure entry, femoral entry. So now this femoral entry is, if you draw a wide side line, just medial to it, just above the lateral PCL, right? Now I just want to see the efficacy of PCL. Yeah, 5 mm above the insertion of the PCL. Artery, please. Artery first. I'm trying to fill the PCL and the strength of the PCL because it was quite legs joint. Because I'm supposed to do a CR joint, whether I'll be able to do it or not. This ACL I've taken off. Okay, not bad. So we can do CR joint. Okay, entry. So again, this is the attachment of PCL, and I'm just going 5 mm above the. It's always better to use gouge like this so that you get proper entry. Don't use straight away drill. Take the entry. Once you enter the femur, just try to make the hole little larger so that the drill goes in its own direction. So you don't never push it. So I'm not pushing it, it goes in by itself. Right? So that is a very crucial thing. Very, very important. Try to suck as and when you are pushing this rod, never push very hard, just let it go gentle so that whatever fluid needs to come out, it comes out by itself. If you push very hard, then there is a possibility of fluid going inside the circulation. So now this is the jig which is gives a 5-degree valgus from artery, please. So this is the jig which gives 5-degree valgus, because then you can use 5, 6, 7, whatever you want. This system as this allows. This is the distal femoral cut which mentions here. That is, if you are here, it is 9 mm, 11 mm, 13 mm. So there are different things which are available here. So I want is 9 mm of cut. I'm touching. Am I touching the medial border? I'm touching. Hammer. Okay. So I'm going to cut 9 mm from the distalmost edge of the femur. Angel wing. Always check with this angel wing whether you are cutting. If you are cutting less, it is okay, but by any chance, if you are cutting too much, then you are worried. Can I have a spike, please? Small. push this one. इसको दबा के रखिए. Cochrane. Pull puller. Pin puller. So this is what we need to check, whether it is 9 millimeter or not. So that is very, very crucial and important. So if you are cutting less than that, then your joint line is going to go down. And if you are cutting too much, then joint line will go up. So you just have to check that. So we have done a distal femur. I prefer cutting femur first because it is easier, because it is in front of you. And now you have to push tibia forward, which would be less, 9 millimeter less. So it is, you don't have to struggle a lot. Okay. The anterior horn of the lateral meniscus. This is the medial meniscus, part of medial meniscus, remnant. Looks good. So tibia is exposed well. Now tibial jig. This tibial jig has a three part. One, this is for the varus valgus. If you can see, can you? Oh, okay. Camera is from the head end, so it's difficult to see. So this is a varus valgus. Let me show from here. So it's a varus valgus. This is the slope, that is the anterior posterior slope, and this is the amount of bone which we need to cut. So we are going to put it at neutral or little valgus. So in this system we usually try to cut neutral to valgus, and that is why you need to do little more soft tissue release compared to the robotic system. So that is the big difference between the conventional method and robotic system. Now what you have to do is you have to go all the way down to the table, check overall alignment of the rod in comparison to the shin of the tibia. Okay, no need. And then you check everything looks okay, then you fix the pin. You can check with the jig. So now this jig has two ways we can check whether it is a 9 millimeter or 0 millimeter. If it is 9 millimeter, that is from the normal side. So whether we are cutting that much or not. that looks okay. So that is what we are cutting 9 millimeter from the lateral side. Okay, hold this one. So, ये पकड़ी, इधर से थोड़ा ऊपर से. So this is an oscillating saw, so don't push that. You just oscillate a little bit. Okay. Start off, please. Straight here. Gap. So if you see on medial side, there is a lot of bone loss. Nibbler, please. So I'll check for the extension gap. Since we have cut very less tibia, we might have to cut a 2 millimeter of tibia more, so that it reduces the defect also. So this is going to be extensor block. It does go in, looks stable, but since I personally feel there is a defect on tibia which is little larger than spike. I'll just show you. Artery, please. Can you see there is a defect here in the tibia, which is little larger. So I'll do a 2 millimeter extra cut here. Tibial jig. I want to cut 2 millimeter extra. Tibial jig लीजिए. Now this jig has an advantage. So we have cut from this square. Now we can cut 2 millimeter more or less. So we are going to cut 2 millimeter more. Hammer दीजिए. जिग को पुश करें. Pin puller, nibbler. Gap balance. We'll just check the extensor gap. Now I'm able to push it. It's full extension with it's stable even in valgus strain and varus strain. So it looks good. So as far as the extension gap, it looks good. Now what we have to do it, we have to keep it at 90 degree. Lift this femur up. And I'll check where my cut is going to be. So it gets me a rough idea that what is going to be my posterior cut, and we mark it with either cautery or the pen. So this is the amount of bone I need to cut so that my flexion extension gap becomes equal. Femoral sizing. So this is a femoral sizing. It goes posteriorly, touches the posterior surface. It comes size A. Pin please. 3. We are going to take fixed 3 degree external rotation here. Go ज़्यादा जाना है, pin ज़्यादा डाल. Fine. बहुत लंबा है. Size A. Size A. Ingelving. So this is size A I am using, and I am checking whether I am notching or not notching. So that is the safest way of doing it. Still I am of little doubt, and I am checking whether whatever I have marked, whether I am cutting at that level or not. Looks like more or less same. Yeah. Okay. Now I need is a pin. Let me hold it properly. Okay.
Dr. Parekh,
Yes, sir.
few surgeons take all these cuts by eyeballing only without zigs.
Who?
Your comment.
No, I will never do it. All these cuts?
There are people who do it. Second thing, this 3 degree external rotation is not fixed for all the patients, or not good for all the patients.
Absolutely.
So how you decide?
So it is either by right side line or by the epicondyle. So if we draw epicondylar line, and it should be parallel to it. Pin puller? Don't know. So somebody who is doing eyeballically is a real god. So this is typically what we would like to see is a grand piano sign. So that looks great. So we are happy about it.
Oh yes.
Chota blade hai. So we have done anterior, posterior cut. Now anterior chamfer. Now this system we have to be careful because this, everything decides on this. So you cannot now take laterally or medially. We are going to use size A. There is no screw. We don't have pegs in this osteotome. Cocker, please. Nibbler, please. Yes. Okay, so now our femur is prepared, tibia is prepared, so we'll do the trial first. मुझे वो पहले टिबिया दे दीजिए। As we are doing a CR, we put tibia first. And over above, we just put the femur. Push up. Hammer, please. Okay, that's good. It's fitting well.
Looks good.
Yeah. Now I extend the knee. Now, can you see that it's?
Oh yes.
It's straight. I'm happy with a couple of millimeter of little hyperextension under anesthesia. So medially it is opening a couple of millimeter. Laterally it is little tight, and I'm able to flex the joint.
Looks excellent, sir.
Yeah.
Excellent demonstration, sir.
Thank you
so
very
much. We'll take your leave now, and we'll proceed with lectures over here. I think any kind of question answer we can have once you come back from there.
Perfect.
Thank you
That
so
sounds
much.
good.
Thank you so
Thank you.
much. Bye-bye.
टिबिया प्रिपरेशन लीजिए। फीमर निकालिए। अच्छा।
Switch over to now program over here. Dr. Ankur Maheshwari, please.
I think you're going to put it from there, no? Yeah, thank you. By the time they put on the presentation, mid-flexion instability is a rather vague concept at times, where we are not very sure what we are talking about. It doesn't have, a lot of studies are actually cadaveric studies in lab models. They have not been very clearly been demonstrated in patients, but still we'll try to get some hang on it, because definitely this is now making the major impact on even design rationales of the newer implants. So that's a basic introduction, but I was trying to talk about. Can you start with this? Okay, so how do we like to define this mid-flexion instability? It's like a mediolateral instability during the 30 to 60 degrees range of flexion. You have a very good balanced extension, you have a very good balanced in 90 degree of flexion, and still sometimes you will, some percent of patients, when you see them back, or some knees that been done and you see them back, there is complaint of a vague instability while getting up from the chair, while climbing downstairs. So that is what, 32 degrees, 60 degrees of flexion, that is the time when this particular term starts coming into picture. And what would be the factors which will be responsible for this? Some of them we have already been discussed. So excessive medial release. So the concept revolves around stability in the mid-flexion, and the primary contributor to that stability would be your collateral ligaments. So excessive medial release, either the medial laxity is there or there is a superficial MCL damage that has been maybe iatrogenic sometimes. Another reason is an elevation of the joint line. Whenever you resect more of the distal femur, either to accommodate for in a tight flex FFD, you're trying to balance your knee, flexion and extension gap. You find that the flexion gap is quite reasonable, but the extension gap is not there. And if you make a distal cut to compensate that, that will lead to a elevation of joint line, and again it will lead to a mid-flexion instability. Similarly, failure to release the tight capsule has almost the same procedure. And another concept that I was talking about was the design rationale, because multi-radii femoral component has been also been incriminated in causing this medial mid-flexion instability. Why? What is the science behind this? So when we look at the MCL, we find that it is not an isometric structure. We call it a single structure, but it is not an isometric function. It has different, it's a large footprint. So if you can see there in this pointer, I think we can get this pointer. No. Thank you, sir. So this, the origin point B and C as well as the insertion point A and D, they are not placed parallel to each other. So during extension and flexion, different parts of MCL actually take over the function. And that is what I was talking about when we had that talk from medial epicondyle osteotomy by Neeraj sir, as to this would disturb the natural isometry of the MCL, and it would definitely cause some degree of instability. But yes, it is a bailout procedure, and at times you might need to do it. So what we say is that the MCL has a large footprint, and that is again the same procedure, that it fires at different times during different range of motions, and therefore it can cause this problem, especially if you are into the elevation of joint line. What happens is that they have a center point. The MCL will have a center point during the flexion extension axis. Now when you elevate the joint line, this flexion extension axis of the MCL has been elevated a little. Now that MCL flexion extension, when the anterior part gives the balanced work to the posterior part of the MCL, it will not behave in the same manner, and therefore it will lead to a confusion, and therefore that instability comes into picture. So that's we have discussed about. Now this is most often it happens during grade 2 FFD. We had a talk about FFD grade 1 and grade 3. So grade 1 is very easily manageable. We will not go into details of that. Grade 3 FFD generally leads to some additional procedures, maybe sometimes even hinged knees. So grade 2 FFD, the middle part, where you can balance the flexion and extension very well, but still the mid-flexion range may not be completely balanced. So what should be the sequence of steps? We have discussed this during the presentations earlier, that the CR surgeons would like to clear out the posterior recess very well before moving on to the whether they want to sacrifice the PCL or not. While the PS surgeons, at the first step in grade 2 FFD, they would always sacrifice the PCL and then move on subsequently to the other parts of soft tissue release. Another sequence of events that can be discussed would be whether you want to do a posterior capsulotomy first, or you want to resect the distal femur a little bit additionally. Amount of distal femur resection that we can actually tolerate is very little. Maybe another 2 from the first 9 mm, you can additionally put 2 mm, that's all. So rest of it has to be balanced elsewhere. So that's what we have already discussed. And transverse capsulotomy, I don't know, I'm not sure if many people would want to do it, but it's definitely one of the things that can be provided when you are dealing with a tight FFD instead of putting distal femur additional resection. And posterior augments is another thing that whenever we are dealing with a grade 2 FFD, it's always wiser to have it on table, because that you can balance your flexion extension gaps through augments rather than to additionally resect your femur. Now femur first, as just been demonstrated. So femur first, I don't know how many would like to do it, but I have been doing it for the last 7-8 years now. And FFDs especially, you benefit by doing the distal femur first. What happens is the distal femur is probably the angle you decided, whether you want the alignment as 5 degree, 3 degree, 7 degree, 6 degree, whatever, that you can decide only on your alignment X-ray. Then it will not be changed in any other steps of the procedure. It was not affected by your soft tissue release. Even the entire femur, if you want to complete, it is not going to be affected by your soft tissue releases. Only the level can change, especially of the distal femur. And if you do your distal femur first, you have still not done your posterior tibia, still you can get access to your posterior part of the femur. So the posterior recess you can clear, you can take out all the osteophytes, you can do a posterior capsular resection, you can slide down the soft tissue structures. Even if you want to do a recession of your gastroc heads, you can do all that by skeletonizing this distal femur. Cuts have already been made. You can put your rod inside, lift your femur a little, so that it gives you a lot of space to work behind. Another thing is by doing your distal femur first, you have the chance of maybe just doing a little bit of juggling around with the tibial slope. So that if you still have a residual extension more than flexion, flexion more than extension, so you can reduce your tibial slope a little bit and then compensate another 5 degrees through that. Then comes the point of if you still, after everything, and I call up any of you guys, look, I am doing my surgery and now I think I am having an intraoperatively mid-flexion instability. How would you like to solve it? Because probably you have already committed to something and you are not sure how now you can proceed. So first and foremost, we can keep posterior augments so that your flexion gap is balanced to your extension gap without any other aspect. Another objective thing you can do is you can upsize your femur. You can put a little bit of cement extra into it and balance your gaps. And then if it's been an MCL damage, you can obviously go for a repair of your MCL damage. I think most of us don't have face that issues anymore now. That's it. I would like to conclude from this. And I want to spare some time for any other questions that we would like to ask.
Yes, Dr. Newman.
So mid-flexion instability would always be something like in the middle range, 30 to 60 degree. When you do a varus valgus test, it would be opening up. So that is what we are talking about, mid-flexion instability. You have a good stable in 90 degrees of flexion. Your flexion and extension gaps are well balanced. But in the middle range, you are not well balanced.
Ankur, one of the reasons may be the multiple radius in the femoral component.
Yeah.
So what do you think about the single radius knee? Would that solve this problem?
Okay, I'm glad that you actually brought it up, because what happens is when we were talking about the isometry of the MCL. So when we are moving from extension to flexion, different parts would be firing at different aspects. And although our own knee behaves in a non-isometric fashion, our components do better when they have a single radius. So there's no changeover. It is during that changeover from that flexion, that radius, when it shifts the component, when you in an implanted TKR implanted knee, the radius shifts from a superior and anterior position to a little backward, posterior and inferior position. That is the time, that changeover, that this particular problem can occur. So single radius designs have been promising to take over this problem. How they have succeeded still remains to be authenticated by studies.
I think single radius knee does solve the problem, but problem is how many of us see these this is probably overhyped. Dr. Mahanti, do you see mid-flexion instability when you do, or patients do complain that middle of the knee while walking they feel unstable?
Especially the mid-flexion instability appears
during two movements, mid flexion instability. One thing while getting up from the chair, number two while getting down from the staircases. There are two instances where people feel little uncomfortable. That is the mid flexion instability what we see. But somehow or other, you know, I do all PS knees. I go with Dr. Ranawat's principle and I do all my knees as PS knees. PS knees, the mid flexion instability are slightly, you know, less, as you tell. Regarding the single radius knee, though theoretically it sounds good, all these things, but practically you don't find any difference in the, whether single radius, multi-radius or whatever. The outcome is all same. Even between CR and PS knees, both are outcome is same. Though at present there are more and more surgeons all over the world are going towards the CR knee. They are doing more and more CR knee. They are keeping the CL, those bone conservative procedure, the proprioceptive sensation of the posterior cruciate ligament, all these things which has been, told. But one must remember that when you revise a CR knee, that you may not be able to go do a PS knee. You have to do a revision knee. Whenever you are revising unicondylar knee, you have to do again that LCCK or TC3. Not that you are revising into a CR knee and then you are revising to a PS knee, then you will go LCCK what is described. These are the surgeries itself, they are individualized surgery. When you do a revision, you have to go for a constant implant, that is for sure.
Probably the fact that the PS knees have a bigger cam contributes to some degree of stability, and maybe it gets away without being that unstable in the middle range. As far as its incidence is concerned, I think most surgeons would say ki it has never happened to my patient. But you always will feel ki yes, when you see other patients and they will complain ki okay, yes, there is some degree of wobbliness. Sometimes even the bilateral knees, patients do tell us that I am more comfortable with this side or the other side. So that is where that slight amount of things are there.
Exactly. Another advantage of the Smith and Nephew system is, their insert have got PS plus like that. That is one of the advantages of the system I found, that whenever you find little, mediolateral instability, then you can change over to a PS plus insert with the same kind of implant, which is not there.
Congruent CR knee insert as well.
Yeah, so and ultra congruent knees, which are also important. In some of the Zimmer knees, what we have done also, we have used the LCCK insert in primary knees.
Okay. So again,
that is not recommended, of course. But on the table, that was a
that is a way to create that stability.
Yeah, that create mediolateral stability.
Okay. Thank you.
Thank you, Ankur. Very nice talk. Thanks. So Hemant, we all are waiting for you now, eagerly. Can we get Hemant's talk here, please?
Good afternoon, everybody. यदि खाना खाने के बाद सबको बहुत नींद आ रही है तो आई विल रिक्वेस्ट एवरीबडी टू हैव जस्ट 20 minutes ऑफ स्टैंडिंग एंड वापस से अपनी कुर्सियों में बैठ जाओ ताकि नींद नहीं 20 सेकेंड 20 minutes नहीं 20 seconds 20 minutes नहीं मैं तो इसलिए खड़ा हो गया ना मेरे पास 10 मिनट है सो we had a very good demonstration of retaining the posterior cruciate by Dimple Bhai just now, and my talk will be focusing on retaining the anterior cruciate as well.
Out of your knees, if you do 100 knees, what percentage is partial knee in your practice? So
now my practice has changed to, sir, almost 20 to 25% of my knees have become uni.
So 1 in 5?
1 in 5, 1 in 4 almost. And that is probably an understatement because one of the premium surgeons, Christopher Dodd and all, they say that
if you really follow the entire philosophy, then probably 40 to 50% of the patients fall into that category. I'm not that bold enough at this moment.
They do
So
fall
I choose
in
my
UK or US, but here in my
So
practice,
yeah.
you know, the patients come to you very late and they have already missed
So,
the boat of UK.
It is just about the philosophy. Once we understand the philosophy, once we start seeing those patients, and I'll be talking on how we decide, how it has changed my practice practically.
चलो अपना ही लैपटॉप ले आते हैं।
नहीं मैंने तो कल ही दे दिया। लोड कर चुका हूँ। ये जॉइंट बंद होगा। कल ही दे चुका हूँ। लड़का कौन था कल? इसमें आया कि 25 की डेट में देख लो। 25 में देख लो। इसमें तो नहीं है। साइन कॉन्क्लेव में तो नहीं है। इसमें कहीं नहीं, इसमें नहीं। ऐसे लगा था क्योंकि फिर इसमें वीडियो चलेगा कि नहीं, आई डोंट नो, कि मैंने चला के देखा था तो चल गया था उस समय।
फिर से अपलोड कर दो ना, अभी दे दो ना, अभी लाया।
हाँ ये है ना इसमें।
मैं अपलोड करके वहीं से प्ले।
हाँ ठीक। वीडियो चलेगा कि नहीं? नी कॉन्क्लेव 2022
उसमें चलता था वीडियो ना।
हाँ चल रहा था, देखा। ऐसी क्या बात है। डॉग की वीडियो डेमोन्स्ट्रेशन पर है। By the time this talk is being loaded, what is the standard practice that we do when we have the patient of a osteoarthritis of the knee coming to our clinics? So we prescribe him X-rays, right? And those X-rays are AP weight bearing, lateral, and probably skyline. Initially, we used to have only AP weight bearing, lateral. In some places, even there is no weight bearing, so it is AP and lateral view, right? So that is what the difference will be with this talk, because now the standard X-rays have changed if you want to assess the osteoarthritis of the knee, right? Yes.
How do you take that X-ray?
Single joint weight bearing is like this.
You have to take support of.
Obviously, if the patient is not able to bear weight, if he or she is in pain, then he has to take some part of the support. But if the patient is able to have a single leg stance, then probably single weight bearing is single SJWV is okay.
Do you take long leg views for all the patients?
So I do take scanograms, definitely. But for a uni, you don't need to have that scanogram. So this talk is beyond that. डेफिनेटली जो पीए व्यू है उसमें आपको मीडियल साइड में बोन ऑन बोन दिखेगी अदरवाइज, बिल्कुल. बट दैट इज नॉट व्हाट वी आर कॉमनली टेकिंग द व्यूज.
मरीज को कन्विंस करना, बोन ऑन बोन दिखाना.
So let this talk come.
What about varus valgus views?
So that is all is being covered in this talk. Okay, so we have got the talk now. So my talk will be unicondylar knee arthroplasty. I'll be partial to the knees, but I want to be fair to my patients. Why uni? Knee arthroplasty is growing day by day, and as Arvind Bhai was telling, probably if everybody gets convinced in the long run, probably 25 to 30% of our total knee patients will be converted into unis. There was a very bold statement made by Chris Dodd that every modern arthroplasty surgeon has to learn or at least have the knowledge regarding AMOA. So now we are not talking about OA knees, we are talking about AMOA knees, that is anteromedial osteoarthritis. And the experience of surgeons who have large volumes, 20 to 40% of their total knees have shifted to the unis. So during my first years of arthroplasty, I started with PS, then I started conserving the posterior cruciates. I changed over to a CR surgeon, and still I used to wonder at times. The green one is there? Okay. So when we cut the tibial biscuit, I used to wonder that the joint is fired only at this place. The lateral tibial condyle looks absolutely all right. And 1 out of 4 or 5 cases, this happened, that the lateral condyle is absolutely all right. You have a 10 mm or a 9 mm cut on the lateral condyle and a 0 mm on the medial condyle. Still you could find a good amount of cartilage on the posterior aspect. And I used to wonder whether we are doing justice to this patient by doing a total knee arthroplasty. The defect or the disease is only here and we are covering the entire knee. And that is where my training went, and I learned about this thing. So friends, we have to learn to diagnose anteromedial osteoarthritis, that is AMOA. And the selection criteria or the indications for diagnosing is, it has to be a full thickness medial cartilage loss, that is bone on bone. It has to be a correctable varus. So we have to take a stress, valgus stress AP view also. So now the X-ray series of a knee has got mandatory 4 views. A weight bearing AP view or a varus stress if the weight bearing is not possible, a valgus stress AP view, a true lateral view and a skyline view. The FFD has to be less than 15 degrees. Obviously it has to be a non-inflammatory arthritis. There has to be a full thickness lateral cartilage, which we can see only on the valgus stress views. And slight ulcers are okay, I'll be showing in few of my cases. The symptoms have to be severe enough for the patient to undergo an arthroplasty procedure. So if once we have exhausted all the possible means, and I'm not denying any knee preservation surgeries also, but in bone on bone, probably no knee preservation surgery is going to help the patient. So it is 1 in 3 OA knees which fall into this category. So the philosophy of uni knee is, it has to be clinical based, confirmed with radiological diagnosis. And when I say radiological diagnosis, the Oxford group does not believe in seeing the MRI. They probably diagnose it only on the 4 views of the X-rays. And the biochemical tests have to be showing non-inflammatory arthropathy. So the standard pre-op X-ray that we take is the weight bearing, single leg weight bearing. You can see a bone on bone on this aspect. But when you do a valgus stress view, the lateral side does not close. That means the thickness on the lateral cartilage is full thickness, and the varus is correctable. So what we are talking about is correctable varus with full thickness lateral cartilage. Then a patellar skyline view or a merchant's view is needed to have to know that the patella is okay. Once you start doing unis, then you will believe probably that the medial patellar, if it is bone on bone, it does not matter. Lateral patellar ulcerations, they also don't matter, but if there is lateral bone on bone patella, then it's a contraindication for uni. And you need a true lateral view. Now, everybody would agree that we at times don't get the true lateral view. So if you are not seeing both the femoral condyles in a single thing, one over the other, then it's not a true lateral view and you cannot appreciate the posterior cartilage of the tibia. So one has to have a true lateral view also. Now what are the benefits of partial knee? The smaller incision, minimal bone loss or minimal blood loss. Akhil was telling that he does not have any pain, he has total painless joints because he does not cut the soft tissues at all. Well, you have to cut skin, you have to cut the fascia, you have to do an arthrotomy. But besides that, there is no soft tissue dissection in a uni also. Normal ligamentous joints, you save the ACL and PCL both, so you have greater flexion, you have almost near normal knee. Joint proprioception is intact. The rehabilitation and the recovery post-op is very, very fast, that is beyond doubt. And you preserve almost 3/4 of the normal knee. Functions are definitely better in the early stage, though it is debatable that the long-term benefits of UK and TK are the same. But definitely the early functional rehabilitation is better in UK. And I would not agree to Professor Mohanty that if you need to convert a UK, you can definitely convert it with a standard CR or even a PS. I have done it in 1 or 2 of my own cases, sir. So you don't need a hinge prosthesis, you don't need a constraint prosthesis to convert this into a total knee. So you have got one more chance probably for doing a total knee. So the Oxford group has given this mobile bearing design which works like a ball and socket. So if it is working for the hips in a younger patient, there is no reason why it should not work for a knee. And the articulation has been unchanged since 1976, since the start of the first phase of microplasty. Now we are into 4th phase of uni and we are doing the knees with microplasty instruments. There are few tips and tricks which are different from the TKR. The patient knee is hanging like in arthroscopy position. The tibial cut is the main key. So if you get the tibial biscuit out, almost 70 to 80% of the surgery has been done right. There is no or very, very minimal medial release. So you don't release the medial collateral ligament or the medial side of the tibia. As against the TKR, you balance the knee first in flexion, followed by balancing the knee in extension. And the intramedullary point is slightly further medial. So it is on the medial side of the summit rather than on the summit. And one has to understand the Spigot's maths. We are poor as doctors in mathematics, but it's simple addition and subtraction. So if the flexion is 3 and the extension is 1, then you have to use a 2 spigot to balance it. It's a very simple math. I was told to have a video demonstration. So this is the hanging leg position. This is the incision. The incision is almost in length or in dissection, it is almost 50 to 60% of the total knee replacement incision. It's very difficult to have all the steps in just less than 10 minutes, but I've tried to. So after doing medial arthrotomy, you just release the part of the Hoffa vertebra. Now what I am doing is checking for the ACL integrity. This is the most important step. This is where you decide whether you want to continue with a uni or you want to shift to an total knee. And probably 2 or 3 of my own cases, I have on table decided to go for a total knee because the ACL was not intact, though clinically it was looking to be an AMOA. You remove all the medial osteophytes from the femur. You have a good notchplasty also so that the flexion improves. And this is the spoon for the sizer of the femur. We'll not go much into the details of when to size it. So with that spoon, we have a 3G or a 4G clamp by which we take the first cut, that is the tibial cut. The tibial cut is almost just near to the footprint of the ACL. I am drawing a line with my cautery so that my recip saw can go in line with this. So this is the reciprocating saw that I am using for the vertical cut for the tibia. I have to be very sure that we are in line with this. So we can check with the saw in with flexion and extension that we are not medial or lateral, we have not cut more or less. And then with a oscillating saw we take the horizontal cut to take out the tibial biscuit. So if you have a tibial biscuit which will be showing that it has got anteromedial osteoarthritis, then almost 70 to 80% of the surgery is over. This is the entry point for the femur. You open the marrow with a small awl or a chisel, and then there is a small rod which you can hammer with your hand only, you don't need to hammer it. Many times you see a cartilage loss in the femur also. So the femoral component has to be in the medial condyle in the middle third. So what I am trying to mark with the cautery is the middle third of the entire medial femoral condyle, because there will be two holes for the femoral condylar component pegs, and there is a good attachment by which the jig automatically fits over there. So the microplasty instruments has made the life of the surgeon very easy. So these are the two drill holes for the pegs of the femoral component. And you can see that they are in line with the line that I had made. This is an instrument specifically for Oxford. This is the milling instrument by which we make the femur like a sphere. And then we take the posterior femoral cut by this. So now we can balance in flexion. So the cut is just like to the size of the posterior part of the femoral component. Now with the femur, only last 2 or 3 steps remaining. With the femoral component in place, we'll put the tibial component and try to feel the flexion gap with the feeler gauge. So this is the tibial component, this is the tibial trial. And with a spoon we'll be feeling what is the size actually of the flexion gap. So this is what I am doing is testing the flexion gap. It is in 110 degrees, and then with 20 degrees I'll take the extension gap, and then with the spigot I'll match both the flexion and extension gap. Okay. So this is the extension gap that I am measuring. This is the tibial biscuit that we take out to just have the size of the tibial tray. Accordingly, we have got AA, A, B, C and D sizes for the tibia, and extra small, small, medium and large for the femur. And now we have balanced this. We have put the trial components in, and we can have this. So now everything remains is to have a wash and to cement it. One more step, probably this is important because the keel of the tibia has to go inside. So with the toothbrush saw, we have to drill. This is the toothbrush saw that we use for the keel of the tibia, right? What I am doing is injecting for the posterior capsule. This we can skip. And this is the final trial that was put. If you can see, this is the mobile bearing, meniscal bearing biscuit. The closure is done in routine fashion. I am going to skip this. Just one or two cases. So, left knee standing. This is the valgus stress view, sorry. This is the lateral view and this is the skyline view. And this is the tibial biscuit that we take out. So, this is anterior, this is posterior, and you see a lot of cartilage over here. So, this is pure anteromedial osteoarthritis. The post-op view looks like this. And the follow-up x-rays like this. So, the posterior anteromedial arthritis can go still here. Still you can have a lot of cartilage over here. So, even in delayed cases you can have a pure AMOA. Again, a bone-on-bone AMOA with Oxford. I probably photograph every biscuit of mine to just know where the cartilage loss is there. There is a full thickness cartilage loss over here. So take home message, friends, that anteromedial osteoarthritis does exist. About 20 to 40% of our TKR patients may be AMOA who are candidates for uni. Excellent long-term survival and better patient satisfaction with mobile bearing or the Oxford knee that I am using. And again, this is a controversial statement, but partial knee is for all ages. It is not a time-buying procedure for total knees. So don't take home this message that for 45 to 55 you will do a partial knee. If the patient is having anteromedial osteoarthritis, I have done Oxford even in an 89-year-old male. So age is no criteria. You have to follow all the criteria for the Oxford group that are bone-on-bone with a correctable varus and non-inflammatory arthropathy. Thank you for your patient listening.
Thank you so much. I think we will proceed to next lecture. No question answer here. We can discuss it out later on. I invite Dr. Mohanty once again for his talk on infections in total knee arthroplasty.
Thank you, sir. I think all of us will be awake after listening about these complications after total knee replacement. While in total hip replacement, dislocation remains the most common complications which surgeons are worried about. In total knees, infection becomes the most common complications what the surgeons are worried about. Now, managing infection is a teamwork. It's not only the arthroplasty surgeons, but microbiologists, infectious disease specialists, and a good laboratory workup or backup is what is required for management of infection. So, to diagnose the infection, we are still following the 2011 criteria of American Academy of Orthopedic Surgeons. Of course, in 2013, they changed the criteria for the minor criteria where they took out that presence of purulence in the joint. They put as a 3 out of the 5 minor criteria should be there to diagnose the infection. So I'll give a guideline or algorithm that how to diagnose infection. The first thing is if you are suspecting the joint is infected, then first do a ESR and CRP. If both are positive, then infection is likely. If either of them are positive, then proceed to knee aspiration. Next step is after aspirating the knee, send a material for total count, differential count as well as culture sensitivity. If total count, differential count and culture sensitivity both are positive, then infection is likely. But if either of them are positive, then you do a repeat aspiration after 2 weeks. And please remember, within these 2 weeks, do not put these patients on any antibiotics, just give a symptomatic treatment within these 2 weeks. Then after a repeat knee aspiration after 2 weeks, if you see either of them are positive, that means either the total leukocyte count or the culture, then infection is likely. But if again both are negative, and if your X-ray shows the implants are loose or one of the implants are at least loose and you are planning for a surgery, then intraoperative frozen section is what is important to diagnose the infection. But the prosthesis bed is well fixed and it is not loose, and if you are not planning to open up the joint, then keep this patient under observation for at least 3 months. And again within these 3 months, do not put these patients up any kind of antibiotic, thus give symptomatic treatment. Please remember there is no role of nuclear imaging, no role of MRI, no role of PET scan, etc. for diagnosing a case of infected knee replacement. In 2018, they changed the criteria again, which is based on mainly laboratory parameters like alpha defensin, leukocyte esterase, synovial fluid CRP, which is not available in most of the centers in our country. So we do not follow this criteria at present. Now, if you see the management of infection, either you give an antibiotic therapy or what is known as antibiotic suppression, do a debridement and irrigation of the joint with a component retention or removal of the components. And if you are removing the component, either you do a 1-stage revision or a 2-stage revision or reimplantation, and finally arthrodesis or resection arthroplasty. And 2-stage reimplantation remains the gold standard of treatment which most of the surgeons in our country we follow. Now the problem of antibiotic suppression is development of antibiotic resistance. We published this thing in the 2003 JBJS that more and more resistant organisms we are getting nowadays, that is because of using inadvertent use of high grade of antibiotics, that means which is both gram positive, gram negative, MRSA, we inadvertently start with a very higher antibiotic. Please remember, higher the antibiotic the chosen by the surgeon for prophylaxis, the lower the confidence in his setup. So please do not give a higher antibiotic for prophylaxis, that give a first generation or second generation cephalosporin that will work as a prophylactic antibiotics. Next step is what is known as debridement, antibiotics and implant retention. The more and more surgeons are following this procedure, but if it is in properly indicated cases, it works out very well. Early post-operative infection with the joint age is less than 3 months, or if there is less than 3 weeks of onset of the symptoms of infection, then this gives the best results. And short duration of onset of symptoms with a stable implant in situ, with a healthy surrounding soft tissue in an immunocompetent host is the best case scenario for doing a DIAR or debridement. Remember, DIAR should not be done as an emergency procedure. It has to be taken inside a routine OT in the next available routine OT or maybe next day or day after to do a DIAR. And certain technical aspects about DIAR, do a thorough synovectomy of the suprapatellar pouch, parapatellar gutters, you clean it thoroughly, meticulously, then take out the polyethylene and you have to put a thicker polyethylene. So always keep a trial thicker polyethylene and original polyethylene ready on the table. Then do a debridement of the posterior aspect of the joint, do a thorough debridement, take out the synovium, and remember to curate out at the bone cement interface, because that is where all the granulation tissues stay, and if you curate out those granulation tissue very meticulously, there are less chances of recurrence of infection. Otherwise those granulation tissues, that will cause osteolysis and that will cause loosening of the implants. Then take multiple samples, 5 to 6 samples for culture and sensitivity. Do a thorough lavage of the joint using almost 9 liters of saline. I normally take 3 into 3 liters, 3 bottles mixed with gentamicin antibiotic and use the pulsatile lavage in low pressure in order to do a thorough lavage. Do a thorough lavage throughout the joint and then close the skin with monofilament nylon, because monofilament nylon has been shown to be less infective rather than braided sutures, which will retain the organisms in the braiding of the tissues. So take at least 5 to 6 tissue samples from different parts of the joint, suprapatellar pouch, parapatellar gutters, posterior aspect of the joint, around the patella, all these things, and send it for culture sensitivity. It should be cultured in an enriched medium for at least 14 days, and always send a tissue for a histopathology to rule out either a tuberculosis or a fungal infection, especially in our country. And tell your microbiologist that they may send the culture medium to the theater so that immediately you retrieve the sample and put it inside the culture medium, so that the outcome is more predictable rather than just keeping it in the refrigerator and sending it next day or so where the outcome is less predictable. This is one of the 56-year-old female where I do a dire procedure. Now I put lot of calcium sulfate, antibiotic impregnated calcium sulfate pellets or what is known as stimulant in the parapatellar gutter and suprapatellar pouch and in the posterior aspect of the joint before closure. And here, as you can see, a thicker polyethylene used. So always it requires a thicker polyethylene before closure, and this patient is infection-free about 4.5 years now. So outcome studies, in our study, almost we have got 76% success rate in dire, and most of the organisms are coagulase negative staphylococcus, and knee is a poor predictor of outcome compared to hip, and high ASA grade is a poor predictor of outcome. Next, regarding one-stage and two-stage exchange, though one-stage exchange has been shown to give a superior functional outcome, but the one-stage revision has shown that almost 34% greater adjusted risk of reinfection than two-stage reimplantation. And hence two-stage exchange remains the gold standard. So after doing a thorough debridement, you put a cement spacer, and during the interval, isolate the infecting organism, treat these patients with antibiotic for about 6 weeks. Weekly you do ESR and CRP, which is used as a prognostic marker. Patient can be mobilized with support. And after treating almost 6 weeks of antibiotic, give an antibiotic holiday for 6 weeks in order to look for the patient's immunity or immunocompetent status, that the infection is not recurring again or the ESR CRP is not rising again. If there is no rise of ESR CRP and there is a constant decline and clinically the joint appears to be quiet, then do a second stage reimplantation. And again during second stage reimplantation, you can take multiple tissue samples from 5 to 6 areas and do a culture again post-operatively in order to look for infection. If in doubt intraoperatively, you can send a frozen section also on tissue to look for whether there are more than 10 polymorphonuclear leukocytes for high power field. If it is there, then you can put again another spacer and come out rather than doing a reimplantation of the joint. Now preparation of the cement spacer is important, that you can use a 2 contour static spacer silicone molds which are available in the market. You can do like this, or else you can do your own way, that you can put the cement on the femoral side like this and take the polyethylene spacer and mold the cement on the femoral aspect. And on the tibial side, again you put the cement and take the femoral component and mold on the tibial side. And before the cement sets, again do a mediolateral stability test. Your joint has to be stable, because instability again may lead to recurrence of the infection, and a stable joint give a better outcome. Patient can be mobilized with some kind of support, and patient has got a good well-being also, feeling of well-being. But if the joint is unstable like this is a patient who operated in 98, infected in 2002 and presented to me almost in 2018, 16-year-old periprosthetic joint infection, osteoporotic bone and dislocated joint, then you have to put a static spacer. This is the way I put a static spacer. I prepare cement cigars like this using 2 5cc syringes with K-wire in situ, then cut these syringes, these cement cigars are ready. I put stimulant inside the medullary canal and put 1 cigar in the femoral side, 1 cigar on the tibial side. Then I put the cement in between the gap and hold it in stable position till it sets. So that is a static spacer. This is a post-operative exercise. These are stimulant there on the posterior aspect of the joint inside the medullary canal that will take care of the infection. And this 16-year-old infection got healed with this kind of static spacer, and patient can be mobilized with some kind of support. This is a polyarticular rheumatoid lady. She is able to walk with a walker there. And finally, now we have our own method of preparation of cement spacer. This is a ankylosing spondylitis patient. We took out the implants. This is our method of preparation of cement spacer using our molds. This polysiloxane spacers, which can be re-autoclavable and reusable almost 100 to 200 times. And this is where the spacer has been put with the stimulant granules there. And this is the X-ray after the first stage of debridement and cement spacer. And that is second stage reconstruction using a LCCK type of prosthesis. And that is the almost 4.5 years follow-up of this patient, and that is the function of the patient. So if you are putting a articulating spacer like this, the function can be restored, the parapatellar gutters can be, soft tissues will there, patient having a good post-operative infection at the end of the second stage also. Hence to conclude, take-home message, ESR, CRP aspiration is the hallmark of diagnosis in our country. Always have a high index of suspicion for COX and fungal infection. especially in case of immunocompromised patient like diabetics or rheumatoids or patients on immunosuppression treatment. Antibiotic resistance is a concern. Do not use inadvertently higher class of antibiotic just for prophylactic purposes. Judicious decision for dire or debridement is important because that saves the joint, and two-stage revision remains the gold standard for infected total knee replacement. One must learn the techniques of putting a stable articulating spacer preparation, and finally, if everything fails, one must learn the techniques of arthrodesis or excision arthroplasty. Again, before I close, this is my last lecture. I thank you all for giving me an opportunity to present my thing, and I again request you for your support for my candidature as a Vice President of IOA. Thank you, sir.
Thank you so much for such a elaborative lecture. Any questions on this? He's going to leave.
Sorry? I keep the drain, in case of primary knees, I keep for 24 hours. In case of putting a spacer, I keep it depending upon how much drainage it is happening. If the drainage is less than 100 cc, I take it out in 24 hours. If it is more than 100 cc, I keep maximum another 24 hours. But I understand that, stimulant sometimes gives rise to sterile discharge. But if it is the stimulant is put in the superficial tissues, they are more likely of sterile discharge. But if it is kept in the deeper tissues, then it is less likely that it will give rise to sterile discharge. But if the sterile discharge comes out, then if you do a couple of dressings, gradually the discharge reduces and it becomes all right. We have not seen gross problems with this kind of discharge after stimulant insertion.
Thank you so much, and I invite Dr. Dhakar to present this memento to Dr. Mohanty.
Thank you.
Dr. Mohanty. Yeah. Hello, Dr. Mohanty.
Yeah. Yes.
My question is, how often you use sonication?
How often you use?
Sonication.
No, sonication I have not used, but sonication is a method that you take out the prosthesis and send it for sonication, and for culture it is available in Mumbai also. So if your routine culture shows negative report, sonication sometimes give you the positive culture. And it is told that if there is a global loosening, that both femur and tibial component are loose, or on the hip side if the acetabulum and stem is loose, always exclude infection unless proved otherwise. So sonication in those kind of cases, it is helpful.
Okay, fine. When you are ready, we are ready here. Please let us know.
Thank you. Thank you.
Ankur Maheshwari, please come on stage. I invite Dr. Pramod Nema to honor Ankur Maheshwari.
Okay.
Sir, we are ready. We should start to incision वगैरह लगाना. Sir, you can go ahead. You can start, sir, surgery.
Okay. So I have my colleague, Dr. Yuvraj, and your name? Mr. Harun from here, and Raju from Ahmedabad. This is a case, the same patient, second side, which Dr. Dimple Parekh showed the CR knee, inflammatory condition, bilateral knee affected. The right side, Dr. Dimple has just operated. We are operating the left side. Please focus on the X-ray. You can see the valgus deformity with the tibial bone defect on this. But most interesting is here the clinical situation which we are showing you now.
Hello.
Which is quite a lax knee. 30 degree of valgus stress. You can see the laxity here, and there is slight hyperextension also. We can see. So this is a lax knee, valgus, tibial bone defect. This is a correctable deformity. We can usually go for a medial parapatellar approach, but just for sake of demonstration, we are planning to do the lateral parapatellar here. But this is a case is not ideally indicated where you have to do the lateral parapatellar. But for demonstration purpose, we discussed with Dr. Lavesh, and we thought that okay, let us do the lateral parapatellar incision. Slightly on the lateral side, but the skin incision remains the same. And now, instead of going to the medial side, now we are going on the lateral side, cutting the, keeping the lateral retinaculum the same way we keep in the medial side. I think, can you focus the top camera? It's too much of light. Fine. So, one. So this is the tibial tuberosity here. This is the patellar tendon where my forceps I have put it like that. This is, and our incision has gone on the lateral side. This is the medial side. So we have just opened the arthrotomy from the lateral side, keeping the normal soft tissue attached to the patella for the lateral closure. Similarly, what we do on the medial side. Here there is a difference. This is the fat pad which we are going to preserve because the fat pad is going to be useful. This is the fat pad. Can you see that? Appreciate?
Yeah.
Okay. So this is the fat pad. Now the patella has come on the medial side. This is the fat pad. This is the patella which has now come on the medial side, right? And the joint is open. You have flexed it. Right. Now here, the patella has not been everted. It has been just subluxated on the medial side.
Okay.
We are gradually doing the synovectomy on the, can't see here.
It's too dark.
Too dark.
It's okay.
Ini बताओ कसरी लो come here probably कसरी लो
What is it? Is it
It's a big osteophyte, yes.
Osteophyte.
Yeah, this is the osteophyte which has been just removed.
Yeah, we can appreciate.
Let's focus this. Is this camera view better?
Yeah, it's good.
Sorry?
Yeah, this view is better.
वो तो आए come on this side slightly. Slightly. Come here. Listen. This is the angle you have to do. Be careful. I told you, right away, फिर बटेगा. कोई बात. Fine. Okay, now because this is a lateral thing, just like a medial parapatellar triangular release, we are just doing little bit of release on the tibial side, proximal on the lateral side. This is the lateral side, we have just exposed and done the release. The patellar tendon is on this side and this part has been released now. The arthrotomy is clearly visible now. Usually we do the lateral parapatellar when there is a fixed valgus deformity which is not correctable. Okay. We'll need the top camera to focus to show the tibial bone defect on the lateral side.
Yes, sir, we can see.
Now, this is the tibial defect. I think it appears that probably no way we can go to the base. That's a basic principle that we should not try to cut the tibia up to the base of the defect. This is actually a very lax knee, as we have already shown. So the basic principle is that we have to cut the less tibia, bare minimum, and try to do the defect management.
Okay.
That is what we are going to do now. This is the medial cartilage surface, which is not bad, and you can see the defect on the lateral side.
How much is the defect, sir? Approximately.
Left up. See, the other thing, we are operating the left knee.
Yeah.
We have put the right side jig.
Oh, yes.
This is just because our approach is lateral parapatellar. We are going to cut around 6 to 7 mm tibia. So the rest of the defect we'll have to manage. Once we take the cut, we will discuss how we are going to usually. I think this is a contained defect because we can see the peripheral rim here on this side.
Yes.
On this side, the peripheral rim is there. The contained defect is there. We can put the bone graft with the screw. But unfortunately, our cut in the femur is also going to be little less because this is a lax knee, so we are not likely to get too big a femoral condyle to fill the defect. So we might have to probably go whatever bone we are going to get is going to be extremely important for us. If we don't get a proper full bone block, then probably we might have to do the infection grafting. Just please keep this bone reserved. Just prepare the bone also. Mop. Okay.
What is your policy? You lateralize here?
No, we are not lateralized yet. No. We are just trying to see. I think the tibia size will be 2 or 3. I think the first important.
Are you going to undersize?
No, we are not going to undersize. No. We have just refashioned the cut on the medial side. We are just now preparing the tibial defect to get the proper assessment. There is a rim available. As I said, this is a contained defect. So there is, the ideal thing would be to fill up that cavity. So if it's a small defect up to 10 millimeter or so, Rita's technique, we can put cement and screw, which has got a long-term good results available. If the defect is slightly bigger than that, then probably we might have to put the bone graft. If you put the bone graft, probably we'll have to use the rod. So just show this. Now this is another thing which we do manually. This is not a robotic surgery, but we can see that the medial tightness is there. The lateral is opening. This is by putting the hand below the underneath the femur. We are lifting the femur, which shows that there is opening on the lateral side, and the medial is tight. So in this case, we have to be careful about the external rotation of the femur part, which has been already discussed by the the speakers number of times. So we just, when we put the other thing is the entry. Because of the valgus, we try to take slightly a medial entry. And this is also another point which has been discussed in the previous lecture by the speaker. So we are taking the medial entry compared to our conventional normal thing. Suction. Okay. Yeah. Usually after the femur drill, we try to put the saline and put the suction to take out the fat granules and globules to reduce the chances of the fat embolism. Another saline. Another saline. We hit saline.
What is the status of lateral femoral condyle? Is it deficient?
Yes, the lateral foot patti about foot patti. So if we just put it like this, I think from the top camera, we can appreciate that there is definitely this is touching the medial femur, and there is a gap here, at least about 1 finger.
Yes.
The gap is seen on the lateral. So that much of the loss, hypoplastic lateral femoral condyle is there. But I think probably we should be able to manage a part of it with a distal cut.
In the femur, how much cut you have planned, sir?
We are just planning 8 or 9 mm. It is always better to do it and repeat it again rather than cutting more. As we already discussed, this is a very lax knee, and the other side has now been operated, which is fairly stable. So we need to give them a fairly stable knee, not over tight. This is an inflammatory condition, likely to get loose later on. But we don't accept the tightness on table. So now we can see that probably there will be hardly any cut on the lateral side. And probably by cutting the medial side, we will be able to
just some dust will take out. How much valgus you have taken?
3 degrees.
3 degrees.
So now, this is both the medial and lateral surface are same. I don't think there is a need for any femoral augment or anything.
Okay, sir.
Langenbeck. Okay. So this is the extension gap.
Yes.
There is.
You are stable with that insert? In 9 mm?
No.
It's 6 mm, which is little less. I want to go to cut the tibia again. And still being conservative.
It's 9 mm insert?
Yeah, that is the minimum.
Okay.
But because we are cut the less tibia, and as I said, it is always better. Langenbeck, please. I just hold it here. Now here we have to make very sure that our posterior part, it touches both the condyles, and it should not give you the rotational problem, because on the lateral side the femoral condyle may be hypoplastic and you may just put this into internal rotation. So make sure that
how much rotation you are planning here, sir?
now that's what we are going to show you. This is the newer jig for the Merrill, the Freedom. This is a new jig which we have used. Now, what we are going to use it, here we have already measured our size, which comes to B.
B.
Just a minute. Just a minute. Focus on this. Just a minute. Yeah. So, you can see here, right?
Yeah.
Okay. So, we can see that it is on the B. Okay?
Yes, sir.
No, focus this. Focus the camera. We can. No, correct. This is better. So we can see it's B, size B.
Yes.
Now, we are just using this for the sizing. And now we are trying to use the principle of gap balancing to manage the flexion gap by femoral cutting by Ranawat technique. Please understand, we don't have that Ranawat blocks here.
Yeah.
But what we are going to do, because always in the valgus knee, we should manage our flexion gap by the rotating the femur. It is the femoral cut rotation which is going to balance in the valgus knee. I think the previous speaker must have told about that.
Yeah.
So we have now taken this B 4-in-1 jig, right? And block. So, yeah, something similar to the Ranawat gap balancing technique we are using here to make sure that we get the parallel, the cut.
To the tibial surface.
Yes, correct. Now, we are just going to show you. So, this here. Block.
Can you show it with the negative specials?
Oh, sorry.
6 mm.
Yeah, that's what we have put now. So, this is what we have put now, right?
So equal mediolateral flexion
Correct.
gap.
So, see, the principle is that in the valgus knee, your flexion gap after now cutting the anterior bone and primary cut, we have seen that there is no notching like what Dimple showed, the piano sign, everything. Now we are fixing our 4-in-1 jig with the 2 screws and the 2 side pins to make it more stable. The principle is that you manage your flexion gap in valgus knee by rotating the femoral jig and cutting the bone by making it parallel to the tibial surface. That is the principle, right? Extension gap we have already done, right? And we saw that it was tight, it is about 6 mm. We still have done. Ostrodome. Bone चाटो जो keep all the bones preserved, please. Keep it ready. So, small size. Board hook up to. Hold it like this, very gently, don't pull too much. Fine, fine. Okay.
कर लिया हाँ तो पटेल
So, there is no recurvatum.
Yeah.
This is full extension, and this is pretty stable. No hyperextension going on. Mediolateral stability is excellent like this. The important part now, when we do this, is a closure. So, the proximal part is not an issue. We can close the normal arthrotomy like this, but this fat pad which has been kept here is an important structure for the closure. Right?
Yes.
Here. So this fat pad we are going to use for the closure. That is what it is. The only thing which now remains to be seen is to the management of the bone defect. As I said, we will just remove the trial implant. We'll show you the defect, and probably we'll leave you at that stage. Either we might have to put an impaction bone graft in the defect, or we might put a cement, but we will just see how much the defect when we prepare actually the tibia.
Yeah, sir.
Yes, in the lateral parapatellar is an important part. No, in the lateral only. Yeah, fat pad is important for the closure structure in the lateral parapatellar incision. In the medial we actually excise.
So, can you explain in a nutshell how did you plan and execute it? I mean, you took a very...
Okay, let me just briefly, just let us see the defect and then I will tell you in a minute. Just give me 1 minute. Postage aage. Yeah. So this defect, yes. And prepare karo na jara. Birthing are pila. Okay. So that 25 mm defect which was there is now it's around 1 centimeter. We are just trying to see whether this sort of graft, yes, will fix with the screw. This is the femoral condyle graft which we have removed. So that we will fix with the screw, prepare the flat tibial surface, prepare the tibia, and for sure we will put a tibial rod. Okay, so that is going to be the case. What you are asking me, as I said, this is a correctable defect. This is not a pure indication for a lateral parapatellar incision, but this is a valgus knee. The main valgus is because of two things: soft tissue laxity because of inflammation, and a tibial bone defect on the tibia on the lateral side. This is a content defect, so it's easy for us either to put a bone graft. If suppose flexion extension both gap would have been tight, I would have still cut little more 2 millimeter tibia, as we all do when the both gaps are tight. Probably my defect would have gone down, but certainly in this case there is no way I can go to the base of the defect because it's too deep. So either it has to be filled with the bone graft or it is to be filled with the cement. When you use cement and screw, which is a very good technique by Ritter, as I said, with the long-term results of 20 years follow-up, lot of papers have come out of that. Up to 10 mm defect is very good. Here, as I said, we are going to put the bone graft, and when we put the graft, supporting rod is usually recommended. So that is what we are going to do. We are just preparing the tibia now. Prepare the tibia and then do the trial rod, and then probably we can leave you at that stage. What I was discussing, that in the valgus knee, after the extension, I think the speaker would show the slide to us. You do the extension first, soft tissue release, but the flexion gap balance is done by rotating the femur in flexion in a way that your cut is parallel to the tibial surface. You rotate. It is not necessarily 0 degree, 3 degree, 5 degree, 2 degree, right? In the robotic surgery, they are going to tell us, here we don't have robot. So we have to do and rotate in a way that your posterior femur cut is parallel to the tibia. And you rotate the jig, the 4-inch way, one jig using either a block, and make sure that it is parallel to that. That's what the point was. And now here we can see the part of this kill and part of the central drill is going to Now for the rod we have different options available, and there are different philosophies also. Either to use a short cemented rod or a long stem uncemented rod. So these are the 2 points which we need to keep in mind. In most of the obese patients, when there is no defect or anything, purely for obesity, when the BMI is very high, about 35, 39, 40 or 40 plus, a weight is 100 kg or more, we use the short cemented rod. But in other defects, many a times we use long, short, long uncemented rods. Both the rods, the cemented, uncemented, are of different material. One is COCR, one is titanium. The Merrill has options of both. The long cemented, uncemented rods have got a flute. It's a fluted rods with a spline, which gives the rotational stability also. I think here we have available, both the rods are available to us. We'll just see after this. Drill. एक scoop जो आप हो, give us a scoop. Prepare the graft. and give us the rod Riemann. So now we can see this is the defect here. You should be able to fill it with the impaction grafting or one large piece of the femoral condyle fixed with the screw and use the rod also.
Yes, sir.
Any question? Or
Yes, sir.
I think the purpose is over what we can do. Probably you can carry on. Dr. Mohanty, the expert man.
Yes, sir.
Professor,
Yes, sir. We are enjoying your surgery.
you are not enjoying my surgery. You are talking my loud voice.
No, I am enjoying you thoroughly.
Thank you. Thank you.
The parapatular approach and parallel to the tibial cut technique, and now filling the defect and reconstructing the tibia. All.
Mohanty Sahib, हम लोग देशी लोग हैं. We don't have robot.
No, we follow you. You are our leader.
So this was as I was just when we saw. In fact, we saw the patient here only on the table. By the time we came here, the patient was already draped, painted and draped. So we can leave at this stage. If you
Yes,
can
sir.
carry on with the further lecture.
Thank you very much for the
Right?
excellent
And,
show.
I think the idea was to show some principles and discuss few things.
Yes, sir.
Thank you.
Yeah, sir,
My
thank you.
colleague Dr. Yuvraj made the things very simple. He was the primary person. I was just talking.
Yeah.
And the other two colleagues from here, Arun Bhai.
Yes, sir. So he's
And
Yuvraj
Emraj.
and you are the king.
Thank you. Harun is from the Merrill and
and-
our another OT person is also from Ahmedabad. Thank you
Yeah,
everybody.
please introduce your scrub, nurse and anesthetist also. They are extremely
Anesthetist,
important.
has been Dr. Atul Vyas. There
Thank
is a
you,
Merrill
Dr.
guy.
Atul.
There is a Merrill guy here. There is a OT guy from Dr. Lavesh's team here. Dr. Yuvraj, you all know, and Mr. Raju is from Ahmedabad with us. So I
Thank
think
you.
it will be a good thing.
Thank you.
We
You can
request
say-
and pray that the patient gets good result. Bilateral surgery has been done, inflammatory patient, and we hope that she will get a good result. Thank you very much.
Thank you, sir. We enjoyed the lateral parapatular approach.
Thank you.
Okay, so now may I request Professor Dhakar to give his talk on total knee arthroplasty in obese patient, how to avoid nightmare.
निबलर आप जो निबलर एक छेल्लो पिक्चर बताइए जिस
First of all, I would like to thank Orthopedic Surgeon Association of Indore for inviting me. So obesity is now, it's a global problem, and every segment is facing this problem. This is nearly tripled since 1975. The world getting fatter, and there are a lot of reasons behind it. In 1980, it was 250 million peoples, but now in 2008, 904. So how this obesity is increasing? This obesity gives a lot of problems. So orthopedics cannot leave behind. The common disease due to the obesity are the arthritis, especially concerned with the orthopedics. And it's a ABC a concept by which we can prevent it. Adopt new healthy habits and balance your calories and control your weight. So how to calculate? This is a formula. If BMI is around up to 25, then it is okay. But if goes more than 30, then it is categorized in class 1, 2, 3. So in class 3, most of the OVs, they have a morbid problems and they are the real challenge. The distribution of the fat is different in male and female genders. The male, it's a android obesity, and mostly it comes in the later middle or in the late age. And in the female, it's a gynecoid type. It's a mostly fat deposit in the lower portion of the back and thighs. It's a direct correlation. As obesity gives rise to a lot of problems like hypertension, diabetes, and as the joint reactive force increases, it gives wear and tear to the articular cartilages, and again these debris, they generate inside the joint, and also in the later age group, so barter holding capacity of cartilage is decreased. So again, wear and tear increases. So this is a direct correlation between the osteoarthritis and obesity. So what to do? It's a challenge in front of the orthopedic surgeons. So a preoperative period, they have to check for the bait. It is associated with the multiple medical problems. It affects negatively both on the results of the arthroplasty as well in the other anesthetic problems. Mostly diabetes, type 2, so insulin-dependent diabetes is a challenge. High blood pressure, heart disease, cholesterol, gallbladder disease, and in morbid patients, they have a sleep apnea. So medical complications of obesities are in numbers. So out of them, so arthritis is a problem that comes in the way of orthopedic surgeons. So diabetes is a major complicating factor for the arthroplasty, especially insulin-dependent diabetes. So also obstructive sleep apnea, it increases the risk of dangerous episodes leading to the hypoxia, especially in the case of general anesthesia and some drugs used for anesthesia. So before going to do arthroplasty, patient must be counseled on increase the complication risk and need to hear the realistic expectations of their expected outcome. What to do? To delay surgery. But if you ask your patient to reduce weight, then patient always reply, चला तो जाता ही नहीं है, कैसे वजन कम करें? So this is a day-to-day questions come in front of the orthopedic surgeons. So before going to intervene, we have to choose what kind of anesthesia. As I mentioned, general anesthesia is risky, so it has to be decided which one is safer. Again, to use of tourniquet, the obese patients may need high pressure, and also under the tourniquet, there may be a fat necrosis. Sometimes surgeons should be prepared to operate without tourniquet, but these patients, they may be related with the high blood pressure, so chances of bleeding is there. Mostly they need longer incision. Higher overall complication rate is high, especially for the superficial bone infection and prosthetic infection. And sometimes we encountered, it's a fat necrosis that delay the wound healing. See, possible cause of wound issues It's a weakened immune response, especially in the obese, morbid obese patients, impaired release of the lymphatic migration inhibiting factors, and strongly associated with the reduced subcutaneous tissue oxygen. Z consideration, that is also a question, but nowadays you have a computer assisted surgery and also the robotic surgery that may solve the problem. But these patients are greater risk for the fat emboli, so intramedullary rod should be avoided. Limb alignment consideration, also this can be solved with the help of computer assisted surgery. In the postoperative period, especially for the morbidly obese patients, the total knee patients have significantly higher revision rates and greater complication rates, including the high rate of infection and wound healing problems compared with their non-obese patients. A lot of studies is still, but there is no clear-cut conclusion. However, the morbidly obese patients and non-obese patients experience similar improvement on the knee society score and knee functional score. Restrict the range of continuous passive motions machine to avoid the reduced oxygen tension in the healing skin incisions. Avoid antithrombotic stocking, which is unlikely to fit the heavy legs, and avoid limited ambulation, often leading to the post-hepatic syndrome, which is more common in the obese women. Extensor problems such as the patellofemoral dislocations and patellar periprosthetic fractures are common, but in obese patients, patellar resurfacing should be avoided. Obesity may be one of the best indicator for non-resurfacing the patella. So higher postoperative complications like superficial wound infection, fat necrosis, and the prosthetic joint infection, a lot of wound healing problems. The high rate of aseptic and radiological loosening and osteolysis or bare. So overall, these patients, they start problem as the obesity increases. So take home message, the obese patient should be counseled regarding their increased risk of failure and inferior functional outcome, should be encouraged to lose weight, especially morbidly obese patients. They have a BMI more than 40, and these patients, however, should not be refused for total knee replacement based on the BMI. Counsel them better, and procedure is likely to offer them a significant improvement in the functional outcome and quality of life. So this is regarding the obese patient. Thank you very much.
Thank you, Doctor, for enlightening. May I request our next speaker, Sparsh Nayak, to come on the podium and prepare his lecture. And in the meantime, yes, Dr. Manish sir has to ask something.
Dr. Dhakad, as you were telling, let the patient lose weight before you go in for a TK. I had a similar patient who was very obese and bilateral knee was required. Patient was sent to a bariatric surgeon. Bariatric surgeon sent the patient back to me, we can't do a bariatric surgery if patient is not ambulating. So what to do then?
See, sir, this is from all over literature. This is a controversial thing, but especially for the morbid obesity, they have a more than 40 BMI. They should control the weight before surgery.
Dr. Sparsh.
Okay. Good afternoon, everybody. First of all, I would like to thank Joint Conclave team and organizers for giving me this opportunity. I'm Dr. Sparsh from Jabalpur. So my topic is hyperextension deformity, also known as genu-recurvatum in TKR. Now, what is hyperextension deformity? Genu-recurvatum is operationally defined as knee extension greater than 5 degree, and it is one of the oldest known deformity depicted in Egyptian paintings going back to 1370 BC. If we talk about incidence, the books says incidence is around 0.5% to 1% present in patients presenting for TKAs. The incidence rate is low because a lot of time this is missed or have not been reported. But Mullaji et al. Found around 3.9% in their case study, and Seo et al. From Korea found out to be around 11.9%. Now, if we talk about etiology, it is due to continued postural adjustment of the limb to achieve stability. Genu-recurvatum can be constitutional, which is usually bilateral, or can be acquired, which are usually unilateral. But as an orthopedic surgeon or joint replacement surgeon, what is important for us is whether it is associated with neuromuscular weakness or non-neuromuscular causes. So neuromuscular causes are poliomyelitis, myopathies, hemiplegia, and non-neuromuscular are malunited fractures, post-traumatic, chronic ligament injuries, PLC injuries, rheumatoid arthritis where there is excessive laxity of ligaments and cruciate ligaments. There might be an iliotibial band contracture, proximal growth plate injury, excessive generalized laxity as seen in connective tissue disorders like Ehlers-Danlos and Marfan's, and also seen in post-HTO patients where there is impaction of the anterior tibial cortical bone, which results in anterior slope of the proximal tibia. Now, the pathoanatomy which leads in arthritic knee needs to be known. It can be bony abnormality. There might be decreased posterior slope, anterior sloping of tibia, or post-HTO, which leads to hyperextension deformity. More importantly, there are soft tissue abnormality. The posterior tissue is overstretched. You can see it leads to a slack over there, which is known as the hammock effect, and the cruciates and collaterals are usually attenuated. There might be an iliotibial band contracture, which is usually seen in the valgus deformity. The result is the extension gap is already greater than the flexion gap. Now, if we go with the traditional cuts, we'll be creating a much more larger extension gap. So traditional cuts needs to be avoided in these cases. Now, the issues related to genu-recurvatum, the most important is identifying this etiology, and because it will definitely affect the post-prognostic factor and post-operative results. If a patient is there with quadriceps weakness, you might not get the results which you are expecting for. So identifying the etiology is very important. Common problems associated with this deformity is the coronal deformities, valgus varus deformities, bony abnormalities as I mentioned. Then there might be significant collateral instability, there might be deficit in joint proprioception, limb length disparity, then choice of implant. Literature says there's no much more difference in functional outcome whether you use PS or CR. But yes, constraint should only be used in patients where there is significant quadriceps mechanism, intact quadriceps mechanism. And in polio, hinge knees have been recommended. If we go for preoperative planning, standard radiographs and scanograms should be done to assess the deformity, to assess the bone quality and the slope. Routine blood investigations, CTs, and the most important again in this is thorough physical examination. The recurvatum test can be done during the examination, then assessment of the hyperextension deformity using a goniometer, ligament integrity and laxity needs to be tested, range of motion. The important part comes over here is the quadriceps, hamstring and gastrocnemius power charting. Now, people with weak quadriceps are not a good candidate for TKA because these people use the hyperextension mechanism to lock the knee and then to ambulate. Now, people with good quadriceps mechanism or good power, they can be proceeded for a normal TKA. The important part is to examine the foot and ankle also. If there are present of plantar flexion contracture or weak dorsiflexors, those need to be addressed. Contracture should be released earlier. Surgical technique, approach, again it is surgeon dependent. You can use medial parapatellar, subvastus, lateral parapatellar. Now cuts, no standard cuts needs to be taken. Minimal cuts is the key and the guarded release. Now aim is to achieve 2 to 5 degree of flexion at the end of the procedure along with the stable joint. The surgical steps, again the points which we need to remember is minimal distal femoral cut needs to be taken, 3 to 4 mm less than the implant thickness. use basically a implant which has got modularity in the cutting block where you can assess. Then downsizing of the femur also gives it gives a fair flexion gap as more of the posterior condyle are cut. So the extension and the flexion gap is managed, is equalized, and also thick insert can be used. Under section of tibia has been advised 6 to 7 mm, and the key is reassessing with every step your extension and flexion gap. That is more important. And even after when you're doing a release, the trials has to be taken again and again. A strict no for a posterior release because already the capsule is lax. Further release would cause more relaxation of the capsule, and guarded release of the soft tissue as per the coronal deformity. Now, several other techniques have also been advocated for this at the time of TKA. There's posterior capsule plication, that is tightening, collateral shifting, proximal and posterior, use of thick inserts, distal femur augments, and constraint prosthesis. Again, constraint prosthesis should be only used in people where the quadriceps mechanism is good. If we use in a patient where the quadriceps mechanism is weakened, these patients usually use the hyperextension mechanism to ambulate, and it causes a lot of stress on these implants, which ultimately leads to loosening or failure. This was one of the algorithm to treat hyperextension deformity given by Dr. Arun Mullaji, and where he has suggested that for rigid deformities, preliminary release should be done, 6 to 8 mm cuts can be taken, and gradual and medial release, and he usually does an epicondylar osteotomy. For correctable deformity, no release, again just the cuts, and for unstable knee, no release, just use an undersized femur and a constrained implant. Post-op rehabilitation remains the same. Yes, brace can be given for few weeks to avoid hyperextension. Complications, these are more common in patients with neuromuscular weaknesses. There is recurrence of recurvatum deformity, recurring instability, and sometimes in extreme cases there might be loss of ability to ambulate as seen in a lot of polio patients. Now, there are certain advantages which has been advocated, like in these difficult surgeries, the computer-assisted techniques and robotics, as they accurately quantifies the amount of bone resection and soft tissue release during TKA, which usually cannot be done by the eyeballing technique, and also enables the surgeon to fine-tune the extension alignment of the knee, the final alignment. So the ingredients for a happy TKR is soft tissue balance, proper bone resection, and gap balance. This was one of the case where, I think the video is not playing. So if you can see closely, there's a hyperextension deformity which we noticed. This patient was a 70-year-old male. We came to us bilateral varus deformity and a 10-degree of hyperextension deformity. We proceeded with the surgery and we did the minimal cuts. Even after that, we required a 14 mm poly. These are few interesting papers. Very little literature is present on the hyperextension deformity, but these are few interesting papers. This was done by Seo et al. From Korea, where they found out that the average cut for distal femur was around 7.5 mm in their study, and they also found out that the poly which they used in these cases was around 12.5 mm. Then whether if you're not able to achieve, another paper by Kevin Koo from SGH Singapore, where he has advocated that fixed flexion deformity is any day better than genu recurvatum while achieving the final stability. At 2 years follow-up, they found out that the knees in fixed flexion deformity did in better than those who were with recurvatum deformity. This was a paper by Arun Mullaji, where he has presented the advantage of computer-assisted total knee replacement in patients with arthritis. And one more, a systematic review by Dr. Anup Prasad and Richard Donovan, where they, in poliomyelitis, outcome of knee arthroplasty in poliomyelitis, where they have advocated that the revision rates are very higher, and constrained implant should only be used when there is intact quadriceps function, and have advocated that hinge knees should also be used. So the take-home message is identifying etiology and patient selection, proper counseling, thorough clinical examination and neurocharting, anticipating challenges, minimal distal and femur cuts, thick inserts can be used, smaller femoral component, soft tissue balancing, and a big no for a posterior release. Thank you so much.
Thank you. First, Amit, please be on the stage because you have got a train to catch. है ना? Plus, is first just one question. मैं पूछता नहीं हूँ, पर जब पूछता हूँ तो लगी समझ लो. Can recurvatum exist with equinus? Okay, show me the gate. No, with equinus. With equinus, recurvatum of the knee. Equinus. So correct that slide. What I mean to say, you correct that slide and rectify your statement that you need to release all the contractures at the ankle, correct this and no, equinus for me cannot exist with the recurvatum.
Good afternoon, respected seniors and colleagues. My topic is TKR in tubercular knee. Slide is not changing. Change nahi ho rahi. Infection is the biggest threat to all of us. Before any planned surgery, we rule out any source of infection in the body. If present, we eradicate it. But in mycobacterium is not as dangerous as other bacteria. Incidence of TB in India is 2% in all musculoskeletal infection. Spine is the most common, followed by hip and then knee. Knee arthritis clinically present with swelling, patella tab, thickened synovium field, rolled between the finger and underlying middle condyle. The typical femoral striate seen in the X-rays, juxta-articular osteoporosis, peripheral located erosions, and gradual narrowing of the joint. It is similar to RA, but the TB is monoarticular and erosion is poorly defined. In advanced stage, triple displacement is seen, lateral and posterior displacement, and lateral rotation. These are femoral striate, osteoporosis, erosion, and narrowing of the joint. In advanced stage, this dislocation is seen. Basic investigation we should do CBC, ESR, CRP, sinule aspirate, AFB staining, TB gold, CB NAT, and biopsy is a gold standard still. CB NAT, along with that, we can do the rifampin sensitivity also in CB NAT. Situation in TB, we have first healed TB, there is no sign of active TB. A patient can be diagnosed at the time of the surgery, which is suspicious and confirmed by the biopsy. And third is active disease. Instead of two-stage revision, two-stage surgery, single-stage joint replacement done in TB because Mycobacterium tuberculosis divide once in 15 and 20 hours, but Staph aureus only in 20 minutes. Unlike other bacteria, Mycobacterium do not form biofilm. Implantation is successfully done in Pott's spine, so why not in replacement? To say, active tubercular arthritis, 4 to 5 month AKT is given. If not respond, then debridement and synovectomy and complete the course. TKR, if required, depend upon the deformity and bony defect after return of the inflammatory markers. TKR can be done with active tuberculosis with proper pre-op and post-op AKT, which is said by the Sindhu with 23 cases. Again, Chinese study, the long-term disease-free interval should not be prerequisite for that routine arthroplasty. Wide surgical debridement is the mainstay to eradicate the disease, and post-operatively anti-tuberculous chemotherapy controls the residual foci. Most of the studies are total hip in this case. Anti-AKT treatment was given for at least 2 weeks pre-op and continue post-operatively. Thorough debridement must for the single-stage replacement. Two-stage only done with the patient have a history of sinus drainage. If the known case of TB, then our protocol is 2-week pre-op AKT, do arthroplasty, thorough debridement and pulse lavage, use local and streptomycin antibiotic, use negative drain for 48 hours. If intra-op biopsy shows active disease, then full course of AKT should be given. If biopsy is negative, then AKT should be continued till inflammatory marker return to normal, which is 2 to 3 months. Success of one-stage arthroplasty for active TB joint is subjected to 3 points: perioperative AKT, thorough debridement, and complete curettage of the infected tissue at the time of operations without previous history of sinus drainage. There is risk of reactivation of TB infection in patients who do not receive pre-op chemotherapy or a patient with a dependent on steroids. Two-stage arthroplasty done in case of history of sinus drainage because there is a risk of pyogenic superinfection is this. Stage 1 pre-op AKT, debridement, local antibiotic spacer, post-op AKT till inflammatory marker reduces, usually 3 months. Then TKR post-op chemotherapy 9 to 12 months. There is a study of, again Chinese study, they have 8 patients, only in 2 patients required two-stage TKR, one in with the popliteal abscess and another with the sinus drainage. Some studies suggest that two-stage TKR, but in two-stage TKR, bone and soft tissue loss is more, and in some time, revision process is needed. This I present some cases. This is a case done 2010 in Indore only. 55 years old male patient with rheumatoid arthritis, nearly bedridden, left knee, proven case of TB, complete treatment taken 2 years back. Left knee range of motion 30 to 90 degree, right knee 20 to 140. Osteoporosis, muscle weakness is there. These are clinical pictures, X-ray pictures, and this case done in 2010. After operation, deformities correct completely, and knee bending achieved. The patients usually come with me whenever I came in Indore for the social meeting only. Second to 54 years male, pain, swelling left knee, aspiration done outside, AFB gram staining is negative, cultures negative, synovial fluid aspiration analysis insignificant, but TB PCR could not be sent. So these are clinical pictures. Thus is a category of suspicion at the time of the surgery. Thorough debridement done, local antibiotic, biopsy was positive, so completed the course of AKT. Local streptomycin is proven in Pott's spine so that we can use in TB knee also. The post-op X-ray. Another case is heel TB 7 years back. Clinical photographs. Intraop appearance is normal, biopsy was negative. So we gave AKT only for 2 to 3 months only. The 5 years follow-up. Patient just in the last 2 months, complete recovery. No pain, he walks 5 kilometers per day. The active disease, patient is very young, advise AKT, but after complete AKT, pain reduces, so she doesn't want TKR. With this protocol, did 5 TKR, 3 THR, and 3 TKR and 2 THR, no recurrence. One patient who had history of drainage sinus 4 years back, TKR did only 1 stage. This is my mistake. It causes delayed skin healing, but ultimately healed without any problems. To conclude, success TKR can be done in arthritic knee with cover of AKT, even if recurrence occur, usually in patient with no prophylactic AKT, may be treated without implant removal. Any case with post-surgery fusion, culture negative, suspicious of TB sample should also be sent for TB PCR. Thank you. Any questions?
Next, I would like to invite Dr. Vipin Maheshwari, sir.
Many times we see accidentally tuberculosis detected. That is a group of patients where actually you open up joints for maybe rheumatoid, you think that it may be something else, but accidentally you detect tuberculosis on the table. So in those kind of cases, we go ahead with the TKR, and post-operatively we have to give AKT for about 9 to 12 months.
Tinovac is very important in that case.
Yeah.
All the protocols should be followed.
Yeah. Basically in tuberculosis there are 4 groups of patients. The first group is the accidental detection of tuberculosis on the table, which most of the happens on the knee rather than the hip, where you prove it tuberculosis, and post-operatively those patients have to be treated to 9 to 12 months whatever AKT. Second group, where there is no frank pus or sinus, but only granulations. Again, those kind of patients which you have proved MRI you do and take a biopsy and prove tuberculosis, first put them patients on AKT for at least about 3 to 6 weeks then do a knee replacement, then you follow about 9 to 12 months, complete the course of AKT. Third group is where there is a frank pus or there is a sinus. Those patients require two-stage surgery. There you do a debridement, put a cement spacer and add streptomycin to the cement like this, and second stage you do and continue AKT for about 9 to 12 months, which he had shown. And fourth group is a heel tuberculosis, where patient has got a past history of tuberculosis and he has been treated with tuberculosis, heel joint. There if you are doing a joint replacement, so after you do a joint replacement, you have to cover with anti-tubercular treatment. Previously we used to think about 3 months what actually he is giving now, but nowadays they are telling there are a lot of resistance to the anti-tubercular drugs, so continue to for about 6 to 9 months at least in the heel tuberculosis, just to prevent a recrudescence or a recurrence. Even then, reactivate, that chance of recurrence, that is recommended by the recently actually why this thing, why even last year we had an entire webinar of ISC, Indian Society of Hip and Knee Surgeons, about tuberculosis, arthroplasty and tuberculosis. And one of the physicians from Hinduja Hospital, she is a chest tuberculosis specialist, she only recommended that now post-operative will give at least 9 to 12 months to prevent a resistance, the INH and rifampicin resistance.
Sir, in the case of active tuberculosis, suppose as he mentioned, after coverage of 3 months of AKT, how long would you like to continue? Because 12 months. I have my experience, same as you saw in this case. It was an active disease, cover with AKT for 3 months. Then I replaced the joint, and the bone was very fragile, very porous, and that patient. But I continue AKT since 18 months, and after 5 years he came last month. So fantastically doing. So a very good thing in tubercular joints, if you cover with the AKT, it heals back.
Respected Chairman, sir, my senior colleagues and friends, I am speaking on the role of sleeves in total knee arthroplasty, and we have our medium-term results of revision knee arthroplasty using metaphyseal sleeves. I begin with a case of a 69-year-old gentleman weighing almost 90 kgs and presented with acute pain in the left knee following a violent kick-starting of the scooter. A total knee was done in 2010, and patient made an uneventful recovery, was asymptomatic since the last replacement, and was walking normally and riding scooter daily. On examination, we found there was swelling in and around the knee joint, a healthy midline vertical surgical scar. Local temperature was slightly raised. There was mild varus, which was correctable on valgus stress, mediolateral instability. Enteroposterior was relatively stable. The extensor mechanism looked to be intact, and range of motion was present. Though it was painful, there was no stiffness. Patient was afebrile. Vital parameters were normal. And here you can see that there was a tilting of the tibial tray and fracture of the metaphysis, the tibial plateau on the medial side, and a fracture of the lateral cortex. So now we started with the investigations. ESR was normal, CRP quantitative was normal, knee was aspirated, frank blood was there, and we sent it for culture. There was no growth. So we had a case challenge with the component loosening, varus subsidence, fractured of the proximal tibial metaphysis laterally and medially, and there would be further bone loss due to cement removal. So we would have to do a bone defect management. The favorable factors was there was no periosteal reaction, no cystic changes, cultures were negative, and femoral component looked to be stable. So we approached for surgery and took a midline skin incision. A quadriceps snip was done at the outset. Tibial component came out easily after poly removal. Bone plug removed carefully, but there was some bone loss. There was a medial plateau defect, and a lateral metaphyseal cortical fracture. So we landed with a T2B defect. The femoral component was well fixed, so we wanted to retain the femoral component. We did a single stage revision using the MBT revision system. A porous metaphyseal sleeve was used, modular fluted stem was used, IRP size 3 revision tibial tray, and we eliminated the dead space using Kronos OS blocks and granules. And you look at the X-ray, immediate post-op X-ray looked to be quite good, and then at 3 months we had a good healing on the medial side as well as the lateral cortex healed well, and the tibial tray subsided and settled down. And this was the range of follow-up at 4 years, flexion of 105 degrees, just short of full extension. So the purpose of the presentation was, when the tibial component is loose, revision knee replacement is indicated using a stem tibial component. Proximal metaphyseal fractures after total knee are difficult to reconstruct using fracture fixation devices if the fracture is very high. And plateau defects require metaphyseal sleeve augmentation, and selective component retention is possible in a few cases. So the goals of revision are restoration of the anatomical alignment, sound fixation of the revision implants, and accurate re-establishment of the joint line, and a good functional stability. Bone loss management is a critical aspect of revision knee arthroplasty. Bone loss can hinder correct positioning and alignment of prosthetic components and can prevent a stable bone interface. For this, we have metal or tantalum augments, tantalum cones, porous metaphyseal sleeves, structure allografts, and special prostheses. So we had 2 cases of aseptic loosening, 2 cases of infection, and 1 case of a metaphyseal fracture, which I showed you. We used the AORI classification to classify all the defects. We landed with 2 cases of F2B defects and 4 cases of T2B defects. And the MBT revision system with a rotating platform was used in all cases, and a quadriceps snip was done at the outset for all the cases, and in 2 cases we done the Kunze-Adams turn down. And we used 2 femoral sleeves, 4 tibial sleeves, 4 femur extension rods, and 4 tibial extension rods. This is a case of primary done in significant amount of varus, as well as there was a tibia vara also, and this led to aseptic loosening. This was case we received from Baroda, which was done at the Railway Hospital Baroda, and we received it in Ratlam. So we did a revision using metaphyseal sleeves both on the femoral and tibia side, and we had a fracture also. We did a prophylactic wiring, and then in the other knee was also done. And this is a recent follow-up of that case. This is one of our own cases which had a infection, and we did a Prostalac mobile spacer and did a 2-stage revision and good metaphyseal sleeve placement both in the tibia and the femur, and a good follow-up at 4 years. The process is holding very well and sleeves very well integrated. And this is another case of a diabetic patient, our own case, which had an infection. We did a 2-stage revision, and at about 4 to 5 years, the well integrated metaphyseal sleeve here and extension rod holding well. So we have a follow-up of all 5 cases ranging from 65 months to 96 months, average follow-up of 80 months, almost 6.6 years, and there is no radiological evidence of loosening, good functional range of motion in all cases. Extensor line of 10 degrees in 2 cases where we did the Kunze-Adams turn down for the exposure. There is no evidence of infection recurrence in any case. There is no change in alignment from the immediate post-op to the latest follow-up in any case, except for 1 to 2 mm subsidence of the tibial tray. Our series, though small, is substantiated by literature. Now, a lot of papers are coming on this use of metaphyseal cones and sleeves in revision knee arthroplasty, bone loss management by metaphyseal sleeves in primary and revision knee arthroplasty, excellent midterm osteointegration and implant survival using metaphyseal sleeves in revision knee arthroplasty. Revision knee arthroplasty with porous coated metaphyseal sleeves provide radiographic ingrowth and stable interfixation. So to conclude, metaphyseal sleeves provide excellent stability by fit and fill in cavitary bone defects. Metaphyseal sleeves allows osseous ingrowth with no evidence of displacement or osteolysis at medium-term follow-up. Porous coated metaphyseal sleeves in combination with extension rods and stems with rotating platform has shown promising midterm results. And can you play the video? Play this video. This is a gentleman weighing almost 90 kg with a metaphyseal cortical fracture, and he had an excellent result. I thank you very much for your patient listening. And
Thank you, sir.
all this work was done with my colleague Dr. A.K. Malviya at Divisional Railway Hospital, Ratlam. I request all of you to support candidature of Dr. S.S. Mohanty, my great friend. We have almost association of almost 28 years now together, and I request to support his candidature for the post of President of IOA, Vice President post. Thank you very much.
Thank you, sir.
Next,
I would like to invite Dr. Saqib Yassin to deliver his talk on patella, whether to resurface or not.
सर मेरे को एक चीज़ आपसे पूछना है, मेरे को ज़्यादा समझ में नहीं आता आर्थोप्लास्टी, पर इतना समझ में आता है कि पहले वाले पेशेंट में जब फुल रेंज ऑफ मूवमेंट था तो क्वाड्रिसेप्स स्निप क्यों किया अपन ने, मतलब मैं ये समझना चाहता हूँ. नहीं, हाँ.
Good afternoon, everybody. Thanks for staying back after such a long day. My name is Lieutenant Colonel Saqib Yassin. I serve at Military Hospital, Jabalpur. My talk is on patellar resurfacing, whether to go for resurfacing or whether to do patelloplasty. Some basics about patellofemoral joint. Patellofemoral joint is an integral part of knee joint, which is the largest and the most complex synovial joint and is tricompartmental. Patella articulates with cartilage in patellar groove on distal femur between 10 and 100 degrees of flexion. Contact area, of course, increases with flexion. Acts like stair climbing, can cause reactionary force which is more than 7 times your body weight. And patellofemoral arthritis is very common entity. It is around 50%. It can present as independently or concomitantly with tibiofemoral arthritis. So let's come to the basics of patella. Patella is the largest sesamoid bone in the body. It is an integral part of extensor mechanism. Average thickness is around 23 millimeters. Average cartilage thickness is around 4 mm. And what was earlier supposed to be a useless bone is now known that it is an integral part of extensor mechanism. There is an important role in 15 degrees of extension, and it helps the quadriceps mechanism to centralize the forces. So patellar resurfacing, the first patellar resurfacing was done by Dr. McKeever way back in 1955, when in those times the options for anterior knee pain were either patelectomy or patelectomy or some excision of the patella. Now, with the growth of total knee arthroplasty, the patellar resurfacing has increased, and it is a very common procedure in United States and in European countries. So much so that around 90% of patellar resurfacing is done in all the TKRs. It involves patellar resurfacing involves resection of part of the patella and replacing the same with patellar component. General rule is that osteotomy volume should be equal to the thickness of the patellar component. Now, as in any other part of arthroplasty, we have got controversy. So the controversy is between people who would always resurface patella, people who would never resurface patella, and then there are people who would selectively resurface patella. And the opinions about the feelings are very strong in all the camps. There is Chitranjan Ranawat on one side, and on the other side of the table there are people like Leo Whitesides and our own Dr. Mohanty sir, who would always resurface patella. So the controversy is there. Now, for those who support patellar resurfacing, who always do patellar resurfacing, the simple argument is that knee joint is a tricompartmental joint. So if you are not replacing patellofemoral joint, you are only doing a bicompartmental arthroplasty. That is the main argument, period. They say if you are not resurfacing patella, you are not doing a total knee. And then in their support, they have got multiple studies, high level data, level 1 studies which support that argument. And right now, they have got registry data also. Registry data from Sweden and registry data from Australia has proven that the incidence of revision among those who undergo resurfacing is less. So is the incidence of anterior knee pain. Then people who present with diffuse synovial inflammation, inflammatory arthritis, overwhelming data in favor of patellar resurfacing. And third argument, which is very logical, what they say that matching of two purposely designed surfaces, patella and phalange, avoids the risk of forcing anatomically differently shaped patella into a single surface of the trochlea. So that is the third argument which they give, which is quite logical. Fourth is the unpredictability and about the quality of the cartilage which is there. You are not predictable, you are not sure about it whether it was going to survive or not. So that is their argument. While on the other hand, people who say we never resurface patella, they say that it is a useless procedure. Incidence of unacceptable complications like patellar fractures, polywear, component loosening, and there is no strong evidence in literature about the decrease in anterior knee pain. And Indian populations, Asian populations, which got smaller statures, people like they got very small patellae, so it's very difficult. And then there are people who are selective resurfacers, like, and there is data, which they quote. Then they say that like people with severe cartilage loss, PS designs, they're more prone for secondary resurfacing after surgery. So they go for selective resurfacing. Inflammatory conditions, obese patients, imperative stair climbers, and valgus knees. Now, for them, indications of not resurfacing are presence of viable cartilage, adequate patellofemoral congruence, young age, a normally shaped patella with normal thickness, and with people who have got, where you are expecting that 12 mm or less will be residual. So they will not, that is a no-no. Literature is abundant in favor of both. So, people who will resurface, they will say that there is a reduction of revisions at 10 years, at 15 years, and there is a reduction of anterior knee pain also, and they will quote all the registry data and all. And those who are non-resurfacers, they will say, look, there is no difference. Clinically, there is no difference, and whereas there are problems. And another interesting aspect of literature is that some studies have shown that people who had no anterior knee pain, after resurfacing they developed anterior knee pain, and interestingly, people who had anterior knee pain after resurfacing, they have no anterior knee pain. So the data is quite confounding, quite confusing. Complications of resurfacing: loosening, fragmentation, AV and lateral facet pain, stress fracture. Though the incidence is very low, but once you have one case, lots of people have converted from being resurfacers to being selective resurfacers once they encountered these complications. Because these complications are quite horrible, they are difficult to treat, and the outcomes are very, very bad. So complications of resurfacing, if you under resect, there is an increase in patellofemoral pressure, there is stuffing of the joint. 1 mm increase in patellar thickness will cause 3 mm decrease in overall range of motion. And there is a positive association between overstuffing and increased knee pain. Similarly, if you under resect, if you over resect, then there are problems like patellofemoral joint pressure, though it will decrease, but then problems of patellar crepitations, even dislocations and all, there are those problems. So complications of resurfacing, again, asymmetric bone cuts. If you do asymmetric bone cuts, then again your results are going to be bad. And there is a paper by Berger et al. Who said that who is studied anterior knee pain, and they have seen that 1 to 4 degrees of patellar of combined internal rotation, if you have, it will cause patellar tilting. More than 7 to 7 can cause patellar dislocation as well. So tips for a good patellar resurfacing is removal of synovial tissue. Measure before resection. Always measure before resection. Keep 15 mm of native bone always. And restore patellar thickness. That is the most important thing to achieve good clinical outcome. Avoid asymmetric cuts. Medialize and place the patellar component superiorly, and avoid all those things. Take home message is: please see the patient before you operate. Please ask about the anterior knee pain, and tell the patients about the potential benefits and the risks associated. Keep patellar instruments ready in your OT whenever you operate, and be selective and be smart. Thank you very much.
Thank you, Dr. Sakib.
Any question?
Now I invite Dr. Manish Rao, sir.
मनीष सर को लेके आता हूँ मैं स्टेज पे, पर यासीन एक बात मुझे बताओ कि those who don't resurface, don't they do neurectomy sort of? Okay. So that means they believe in that pain. Okay, denervation. So that means on the other way around, logically speaking, they believe in the pain originating from the patellofemoral articulation, and for which they are. So that's not logical. No? Killing the nerve like Nadal is going to get for Muller-Weiss disease is not the treatment of Muller-Weiss disease.
Good evening, everyone. I have a brief to talk about TKR post-HTO. Osteotomy is the surgery which is done when there is a unicompartmental osteoarthritis or a malalignment is there. It has good short to long-term success record depending upon how well you do the surgery. It realigns the limb. It reduces the stress on the articular cartilage. It gives equal weight-bearing load sharing in both the compartments. HTO can be a varus unicompartmental disease. When it's a medial disease, we do a high tibial osteotomy. It can be a closed wedge. It can be an open wedge surgery, dome osteotomy, tridimensional fixation, different methods you can employ to fix it. Ilizaro is another technique by which you can do it. Distal femur osteotomy, when you do, is a valgus deformity in the knee. The lateral joint space is reduced, and you do a lateral surgery. The current trend is now you try to do a unicondylar knee even in a patient of 45 to 50 years of age. And if it is elderly, you try to do a TKR. Osteochondral bone grafting is the another technique which arthroscopic surgeons do propagate, and autologous chondrocyte implantation is other technique by which you can deal with a unicompartmental osteoarthritis. There are a lot of issues with the TKR because it leaves behind its footprints of the previous surgery, like the prior incision. The operating exposure becomes difficult. It is a patellar baha. Retained hardware is there. Joint line angle distortion is there. You have to deal with it. You can have malunion, non-union, and you can have an offset tibial shaft. Deficiency of the medial or the lateral tibial plateau can be present. Prior incisions are challenging. Many times you find multiple incision. You have to respect the old incision. Lateral flap is vulnerable. You have to keep your incision as far laterally as possible. Short oblique incisions you can ignore. Long lateral patellar, if it is there, parapatellar, try to use that incision. Many times you use a delayed incision or a SAM incision technique. Tissue expander can be used if you are in a doubt. Operative exposure is always difficult because there is a scarring around the osteotomy site. There is patella baha, quadriceps release or snip has to be used, and you have to prevent patellar avulsion, and use of the pin is to be there. If you encounter patellar baha, frequent it is after osteotomy. You have to lower the joint line. In this case, you can never take up the joint line. You have to minimize the size of the patella. You have to free the patellar tendon from the scar, and your closure should be such that you gain in the length of the patellar tendon. Retained hardware, again, retain it if it is not coming into the way. Remove screw and staple if they are coming into the way. Long plates, try to remove 4 to 6 weeks prior to the surgery because one stage becomes very difficult. And obtain deep culture, always consider it to be a revision surgery. In this case, bilateral STO was done. In one of the side, we could manage with a normal implant. Other side, the patellar peg had to be cut because the screw was coming into the way, and we did not want to remove the screw and the wires because dissection becomes very difficult if you try to go medially and laterally. Then you have the problem in the capsular closure. Patient continued to do well. You can do a partial removal of the implant if it is not coming into the way. In this, the partial removal, only the screw has been removed 2 years post TKR. Certain times you find funny types of implant both on the medial side and the lateral side. In this, I tried to do a 2-stage procedure. Once in the first sitting, the left knee TKR was done, and on the same sitting, I removed the implant both from the medial and the lateral side, and after 2 years, I did the surgery on the other side. There are issues of the multiple scar into these type of patient. Howsoever careful you are, you can have superficial skin necrosis for which you have to deal. You have to be patient enough, and superficial skin necrosis heals very well. There can be a joint line distortion. It can be in two-plane varus valgus or the upslope joint line. Progressive varus can be there after STO if it is not done well, and that needs to be converted into TKR. Non-union is there. As we are orthopedic surgeon, we have to remember that we have to address the non-union. Even if you are done doing TKR, you have to remove all the fibrous tissue, bone graft the non-union site, and use the long stem. Malunion is there. It is very challenging because you can have all types of deformities into it, varus, valgus, flexion, extension. In this, you can do 1 stage or 2 stage if the patient is young. Tibial tubercle rotation is there. You have to take consideration for that. Truncated tibial metaphysis is there. You have to deal with that. Semi-constrained implant should be ready on your table. Meticulous preoperative planning, it requires long stem cemented or press fit stem can be required into this situation. This is one of the patient who had blood pressure, diabetes, and BPH. He had a fracture after doing a STO. His nailing was done, but progressive. The joint was bad, and he was feeling pain into the joint, and he was not able to walk. There was the valgus deformity with anterior bowing of the tibia. 1 stage procedure was done into this because intra-articular correction of the extra-articular deformity was done into this patient, and the patient did well with 1 stage surgery, but this requires very preoperative meticulous planning. Overcorrection of varus is bad because it now leads into valgus, and valgus deformities are challenging. Joint line is changed from varus to valgus angulation. Lateral plateau bone deficiency comes into place, and you have to deal with that. Rotational alignment of the femur becomes a challenge because now the femur is externally rotated. It is difficult to balance these type of knee into flexion, and sometimes you have to reduce the rotation, or a bit of internal rotation can be considered. Downsize the patella and shift it medially. Lateralize the femoral component. Offset tibial shaft is another problem which comes into after doing osteotomy, because it's more common if you do a closing wedge osteotomy, the tibia becomes offset. Preoperative, again, templating and planning is important into this. Shift the tibia medially, downsize the tibial component, and you have to be ready with the offset stem, which are not very readily available, or most of the companies have stopped getting into this. This is one of the patient, STO was done, the progressive disease was there. What are the options into this case? You do a corrective osteotomy, or you get an offset tibial plate, which is not available here. You don't get a now offset tibia rod also, or you downsize the tibial component. But how much tibial component you can downsize? Because most of the companies allow only one size up or down. And if you have to downsize this component, probably there would be a mismatch between the femur and the tibia. So this was done for this patient. All poly component was used. I didn't have all the energy to take down this osteotomy and to do the correction. I used a PFC all poly component, and the peg of the tibial component was cut such that it could be accommodated on the lateral side, and I could get away with this. Patient continued to do well after this. There are certain complications with STO, howsoever you can be meticulous. Skin necrosis, patellar fracture, patellar tendon avulsion can be there, infection, and the peroneal nerve palsy. This is one of the patient in which a fat lady which had undergone STO, she had progressive disease, and this was converted into TKR. Post-operatively, she was well, but suddenly after walking, after a few days, she felt a snap, and she landed up into this. You can see the patella has gone up, so this is a case of patellar tendon rupture. You can see clinically the contour of the knee is lost, and this becomes very difficult because the management of the extensor mechanism is very challenging and the results are not very good. There is a lot of literature to support also for conversion of HTO to TKR. Conclusion would be adequate exposure is required into these cases. You have to have a controlled bone resection. Restoration of the joint line is very important. Component alignment must be perfect to have a good result. Soft tissue balancing, lateral, posterior lateral, you have to take into consideration the releases. The medial side tibial augment might be required. A constraint implant should always be ready. Conversion of STO to TKR is associated with slightly inferior result, but attention to surgical techniques can improve the results to almost comparable level. Thank you very much for your kind attention.
Excellent talk, Manish sir, and nothing else was expected from you. मगर सर एक बात बताइए कि है ना अभी जो ये medial open वाला जो हो रहा है, पहले तो ये सब अपने पुराने lateral
because I showed you कि this
my अभी इसमें और इसमें tibial shift की जरूरत पड़ती है क्या? इतना technical differences है क्या, या ऐसा कोई case किसी के अनुभव में है क्या?
I have not encountered a case because these are all.
Medial open. अच्छा दूसरी चीज उसमें क्या होता है कि इसकी जो plates हैं और इसके जो screw हैं, ये they are directing almost to the subarticular बिल्कुल उस level पे तक पहुंच जाते हैं. उसका इसलिए मैंने पूछा एक बार.
Answer भी पता.
Next, I would like to invite Dr. Varun Chauhan. This is the last talk of the day.
सर का सुनना इम्पोर्टेंट है. First of all, I want to thank organizers, scientific committee and AOSI for giving me this opportunity. Management of bone defect is a very huge topic, but I think the previous speakers, they have covered most of the area, and I will try to summarize it. इसको आगे कैसे बढ़ाना है? ये अच्छा रेड ग्रीन अच्छे इससे हो जाएगा. Okay. So bone defects, they mainly occur in revision situation, but may also occur in primary as well. Today, as we saw that in primary knee, there was a defect. The causes of bone defect in primary knee are the erosion secondary to the angular arthritic changes due to inflammatory arthritis in case of osteonecrosis and fracture. Bone defect in primary knee are mainly asymmetrical and peripheral, but they can be contained due to cyst formation. In primary knee, the defects are peripheral and the bone is condensed and sclerotic. But in revision knee, the bone is osteopenic after the removal of the components. So that is a slightly difficult situation. For bone defects, we follow AORI classification. There are various classifications, but AORI classification is a very practical classification. In type 1, bone defect is contained and can be managed easily with primary implants. In type 2, there is type 2A and type 2B, depending upon the medial, when only medial side is involved, one side is involved, then it is type 2A. And if both the sides, like both the sides of the femoral condyle or both the sides of the tibial petu is involved, then it is type 2B. And in type 3, severe metaphyseal and diaphyseal bone involvement with soft tissue involvement is also there. Then the management options, there are various options like translation of the component away from the defect, lowering the tibial resection, cement filling, autologous bone grafting, metal augments, allograft, metaphyseal sleeves and cone, and megaprosthesis. So the first four, they are usually used in the primary knee surgery, and the last four, they are used in the revision, but we can use any combination depending upon the situation. So lateralization of the tibial component, this eliminates the bone defect, but we should not lateralize too much because the principle is that largest tibial tray and polyethylene insert should be used so that the reasonable contact surface should be available to distribute the load. Lowering the tibial resection, this has a limit. It should not be, we should not go beyond the tip of the fibula and ITB. And lowering the tibial resection, lower tibial resection will also reduce the size of the tibial component. Cement filling, it is used for defect up to 5 to 10 mm. The radiolucence lines are commonly observed under defect filled with cement. And this method has also been used till the defect 20 mm or higher, but for larger defect, it is not, it is an inferior method. And large volume of cement will be used for the large defect and which will cause thermal necrosis at the cement bone interface. Bone grafting, it is readily available in primary knee, high rate of incorporation, it has got osteoinductive properties and disease free. So it is a good option. And tips of bone grafting, I will speak because everybody knows. This picture is self-explanatory. We remove the condensed bone and prepare the bed of bleeding bone, and then fix the graft. Graft should be stable, and the implant should load the graft so that graft doesn't resorb. Metal augments, they are used for defect up to 25 mm. They are triangular and rectangular in shape. Both cemented and cementless options are available, and main advantage is that they allow quicker rehabilitation without restricted weight bearing. Impaction bone grafting is another method, and allografts, they improve survival and restore bone stock, but we know the risk of transmission of disease, immunological reaction, and infection is there, and resorption is also a possibility. Then sleeves and metaphyseal sleeve, Dr. Maheshwari just showed us the example. They are used in type 2 and 3 defect, and they improve the construct stability and survival rate. Metaphyseal cone, they are again used in type 2 and 3 defects, and but cones require press fit, so risk of fracture is there in the hose bone, and they are slightly difficult. Their extraction may be difficult. Then megaprosthesis, this is the last resort, and they should be used in low demand people, as there is high risk of mechanical complications, and there is a risk of infection as well. So this is in summary about the bone defects, that what should we do. Thank you. Thank you very much for your presentation. Infection bone grafting should be mainly done in contained defect. If you are doing in, like I showed the X-ray, if you are doing in which the defect is non-contained, then you will require something like a mesh or something to contain that graft. And if it is done properly, it is a very good option. Okay?
Hi. So for last 2 days we were working on joint preservation and joint destruction, or whatever, by end of the day. So it was a wonderful session, having so many faculties, dignitaries amongst us. I'm not an arthroplasty surgeon for that matter, but still I enjoyed the whole day. And the most important thing is interaction, learning together. So it was a frank and open house discussion, which always let us learn a few new things daily. So thank you all for being here, and I thank on behalf of AOSI to all the, seriously, like to start with Arvind, I cannot keep on naming, but yes, at the outset I must thank our sponsors. The list is here: Smith and Nephew, Max Merrill, Biotech, Yajat Life Sciences, Sri Surgical, Flex Knee and Pure Surgicals. So all our events are successful because of the delegates who were here, and of course the learned faculties who spent their time. They have come over here, and least and not in the end, and not anything. I never do that, but Monty has been a friend like for almost 28 years or 27, 28 years. So it's an appeal for amongst us to support him in his upcoming elections. So amongst us means, I mean to say, if I am saying this, I represent us, and I have a right for my friends and junior colleagues to seek support for the one to whom we are in direct contact and in love. ऐसा नहीं कि बाकी सब दुश्मन हैं, पर फिर भी कोई एक तो प्यारा होगा. Okay? Thank you very much, guys. Let's call it a day. Thank you very much.